Good morning, everyone. We take the pleasure to invite our speaker, the first speaker for the session, Dr. Sheetal Sharda. She's a pediatrician who has done medical genetics. She has an experience of 18 years of experience in the field of medical genetics. She is currently the director in clinical genomics development and implementation, Neuberg Center for Genomic Medicine, Ahmedabad. She has worked as a senior resident in the Saran Hospital, Saran Director Hospital, New Delhi, and she has worked as a senior research associate in the genetics unit in AIMS, Delhi, and she is worked as a senior resident in SGPGA, Lucknow, and also she has worked as a professor in genetics and metabolic unit in PGI, Chandigarh. And she is like consultant clinical genetics in Medical Labs, Bangalore. And she has various publications in national and international publications to her credit. And she has contributed several chapters in molecular diagnosis, genetics in IAP color. And over to you, ma'am. And madam is going to speak on the on reproductive genomics. And over to you, ma'am.
Good morning, everyone. At outset, I would like to thank Dr. Sujay and Dr. Satyamurthy for inviting me for this talk. And it's always lovely to be among students because we come with the intention of giving some incentive to you for your future career options. So medical genetics is an upcoming branch, not an upcoming. It is definitely the era of genomics now. And starting from reproductive genomics is like we have paved the way for using genetics in multiple segments in reproductive genomics. So whether it is starting from male infertility, female infertility, or planning a pregnancy, or even after pregnancy, if they want to see whether the baby is okay. So when we are monitoring the pregnancy by doing biochemical testing or using non-invasive techniques, then there are couples who want to plan pregnancy, but they are getting recurrent pregnancy losses, or they have a bad obstetric history in view of neonatal losses. In such all segments, probably genetics is playing a very big role. So, right from planning pregnancy to following up pregnancy, and even after that, is the era where we are now heading towards. So, the objectives of today's talk would be whether we can identify a family who needs special genetic testing to explain to them that they are at high risk of having a child with a rare genetic disorder. And based on that, can we give them some reproductive options so that they can plan their family well? We all know that couples today are getting married late, they are planning their careers and they are having plans of having just one or two children. In that case, they all want a so-called totally normal child. And if we can promise them that by doing some basic screening and diagnostic tests, then it is also useful for the family as well as the society. We also want to know the difference between a screening test and a diagnostic test, right? And we have to be familiar with the ongoing genetic tests which are available. So there are multiple tests for different disorders. There is no single test which can say, okay, now we have tested you and now you are at no risk of any genetic disorder. So we want to know that who are these high risk families, what disorder is there in their family, when should they be tested, why they should be tested, and how they will be tested. So we will try to answer these questions in the next session. So we have to understand that genetic disorders are really rare, and more of what we see in the clinical OPD is more of the environmental. So when we talk about infections or complex disorders like hypertension, diabetes, these may not be pure genetic disorders, but they definitely have a component of genetics. So we are predisposed to having any complex disorder based on the inheritance of certain genes from our parents, right? So the importance is, even if they are rare, the risk of recurrence of having a next child, or a person who is having a genetic disorder, the risk of having a child with that, be it cancer, be it a muscular dystrophy, be it retinitis pigmentosa, the risk is very high. Advantage being it is unifactorial, so you can test the couple or the family for this. Unlike the complex disorders, which fall like hypertension or diabetes, all those things may have a very, very low recurrence rate. but the genetics is very complex. So we might not be able to tell them that what is the risk in the next pregnancy. So that's why we have to understand what is the role of environment and what is the role of genetics in having a abnormal baby. We don't use the word abnormal, but we use terms to describe whether the child is syndromic or whether the child is having a rare condition. So there would be a combined effect. So if anybody is posted in obstetrician and gynecology department or who is anybody practicing in the audience, we know that there are multiple reasons of why a baby can be malformed. So including neural tube defects or cleft lip, cleft palate or having a congenital heart disease. But we can see that the monogenic or the genetic causes may not be very high, but still they form a big chunk of these disorders. And then there are unknown factors that why they are happening, we still don't have enough evidence. We also know the teratogenic effects of certain drugs, certain maternal infections, certain maternal disorders. So if the lady is having uncontrolled diabetes, the chances of having a neural tube defect or congenital heart disease in the fetus is very high. And then we know the importance of starting folic acid to decrease the chances of neural tube defect. So these are all proven facts. So the dilemma in minds of clinician is that if we consider that a particular disorder is genetic, what do we do next? What kind of tests are available? Because probably before a decade or so, we didn't even know that there were so many different tests which are available. And are the tests different for different disorders or can we send just one test? What would be the interpretation? So when the first MRI came, when the CT scan came, only the people who are specialized in that knew about it. Even now, if we want to describe an MRI, we have to take the help of a radiologist. And if we want to go deep into neuroradiology, then we have to take help of them who are experienced in that. So the interpretation of the reports also is similar because genetic report is also not a pure like a ABG that there's a pamphlet comes out and you can decipher it. So the interpretation becomes very important, and more so because if you are doing a genetic test and if it comes out negative, are we sure that it is not a genetic disorder? So that has to be explained to the couple or the family. And the most important thing is parents feel that now you're doing a genetic test, it is so costly. Will it change the management in my child? What is currently going on? Can we change that? So yes, we are moving towards genetic based treatments now. So there is precision medicine. You know the gene, you know the variant, and you know the exact drug which will help in that condition rather than just doing trial and errors in treatment. So yes, the management also changes whether renal transplant needs to be done, whether it can be rejected. Now there is a role of pharmacogenomics. Anybody in pharmacy, they would know that along with pharmacokinetics or pharmacometabolomics, there is also pharmacogenetics. So we know how a host would respond to a drug, right? So, and then when we are talking about reproductive, the couple wants to know whether it will help us in planning future pregnancies. So, and if we have one child with a particular disorder, be it Duchenne muscular dystrophy or hemophilia or thalassemia, can we have a test which can prevent it in the next baby? Because we all know that such disorders are a huge emotional and financial burden on the family itself, but also on the society. So the best tool, I would say, or best investigation we can use to understand whether we are looking at a genetic disorder is drawing a 3-generation pedigree or a family tree working. You can do this exercise when you go home. That you can just go and see how you are related to your, cousins and at what level of medical knowledge is available amongst your cousins also. So there could be inheritance patterns like autosomal dominant, autosomal recessive, X-linked dominant, X-linked recessive, mitochondrial. So the inheritance patterns are different. So I'm just telling this to the students that don't skip that page or don't skip that chapter in genetics when you are reading your Nielsen or you're reading your pharmacogenomics or textbook. So there is a chapter on these and you can definitely go through because these patterns of inheritance will explain the risk in the next baby. So probably this is the first thing which a clinician can do in their OPD is draw a 3-generation pedigree, right? So now coming to the basics, why we are talking about genetics? It is because when we are talking about how we are made, it is from what we get from our parents. The parents are giving us their DNA. So 50% of the genetic material is from the mother, 50 from the father, and that is how we are made. But the dogma of life is that there is a cell, the cell has chromosomes, and in the chromosomes there is our coding material, which is called genes. So just like a computer has the binary 0101 code, in the same way we have codes made of 4 nucleotides, that is ATGC. And these nucleotides are making your codes, coding is done. And then after the gene is made, it is being translated to a protein. And that protein is hormones or enzymes or anything what will give color to your eye, give your hair curly or straight, which will give your height. So everything which is there in the phenotype is based on what has come out from your genes. So this is how the resolution goes. Yeah. So when you have a cell, it is easily seen under the microscope. You can even see the nucleus. When you go for a cytogenetic posting in pathology, you may see even the chromosomes under the microscope. But beyond that, everything becomes submicroscopic. You will not be able to see under the microscope. So you have to go at a molecular or a DNA level. So there are 23 pairs of chromosomes, but there are 20,000 genes which are coding those chromosomes, but there are 3 trillion base pairs. So whether we have a chromosomal abnormality or we have a base level abnormality, the test will differ. So just as an analogy, like right from a library, you have to go to the abnormality of a letter. So any change in the ATGC or the basic code of your body will change how you are going to manifest the disease. So you have a patient with tuberculosis in the same family. One will very well respond to the anti-tubercular drugs, but the other will not respond. What is the reason? So there could be something, a change in the genetic. In the same family, you might have a person who is totally. So the question that people ask is, in a 3 generation, nobody has a genetic disorder. How come we got a child with this? So they start feeling that guilt, that how is that we are getting it? So we have to explain the reason that how it can happen at a base level. So for if you can see the difference in the resolution, accordingly the resolution of the test also changes. So you have to know if you want to test the chromosome, you will go for chromosomal analysis, which is a karyotype. But if you want to look at microscopic level, you may have to go for a test which is known as fluorescent in situ hybridization, which is FISH. You may have to go for a better resolution, which is chromosomal microarray. So these tests test for the chromosome. But then if there is deletion or there is a change at the gene level, there are different tests. So you may have to go for different types of tests, and the choosing the test depends on your phenotype. So if you have a child with Down syndrome, you know it is a chromosomal disorder. It is trisomy 21. So as the name suggests, these are the chromosomes. So they are in pairs, right? So these are 46 chromosomes. X and Y is the gender chromosome. So XX is female, XY is male. So when the chromosome 21 becomes 3, it is trisomy 21. If the 13 becomes 3, it is trisomy 30. And similarly, other chromosomal disorders can be tested. Now, the stages, so when we are talking about preventive genetics, when we want to avoid a genetic disorder, what level of prevention is possible? Prevention is better than cure. That is told to everyone. How can we prevent a genetic disorder? So, tertiary prevention is postnatal. Once the child is born and you do a newborn screening, which will be taken up in one of our lectures today, then you can prevent the complications. That you are diagnosing it early, probably sometimes in the asymptomatic stage, like hypothyroidism, right? It causes so much of morbidity in the child. So if you can detect it by newborn screening, we can prevent the long-term complications, including intellectual disability, if you start the treatment early. So that is newborn. Secondly is you have a first child with a genetic disorder, you want to prevent it in the second child. So that becomes a prenatal diagnosis. So when the lady is pregnant, we do a testing in her by CVS, which is chorionic villus sampling, or an amniotic fluid, and we test whether that fetus has any abnormality. So we are preventing the birth of the child, but that conception has already happened. Tertiary, primary prevention is you don't allow even the first child to be born with a genetic disorder. So that is called a primary prevention, which can either be done by pre-implantation genetic testing. So we have an IVF, we do in vitro fertilization, and we do a pre-implantation genetic diagnosis to see if the fetus or the embryonic level abnormality is there. And then we have the primary prevention. Why do we even go to that stage that we have to terminate something, we have to abort something, or we have to use this method? So can we do a primary prevention? Can we do a carrier screening of the couple? Nowadays children are very aware of what can happen. They are very aware of techniques available. But we are still in the stage where the parents will say, "Janam kundli milani hai," that they have to match the birth chart. So why can't we match the genetic charts, right? So if we see a couple, and we do a couple carrier screening and see if they are at risk of having a child, it is becoming very common now for thalassemia at least. So every couple is screened before, preconception. As soon as the lady gets pregnant, we do the HbA2 levels. If she is a thalassemia carrier, the spouse is done. And if they both are carriers, then we know that there is a risk of having a child with thalassemia major or sickle cell disease or any such condition which is autosomal recessive. And so we can go and do a testing in them and tell them the risk, and then they can have their options, whether they want to continue the pregnancy, whether they want to do prenatal, or sometimes couples say we won't have a child. So that reproductive option decision can be given to the couple. So now as we are going towards genomic medicine and the number of tests are increasing, we know that now we have to plan before conception, preconception. Premarital probably in our country may still be a little, out of the box type. But there are couples who are coming before marriage to see if they are at risk. But ideally, our country, we can say that preconceptionally they can be given a choice to do a carrier screening and then give them the option of reproductive, like pre-natal diagnosis or PGT. So the step, instead of doing the tertiary that we are doing a prenatal, I'll start with carrier screening. So carrier, we all may be carriers. If we all sitting here, we do our genetic testing, we might be carriers for 8 or 9 genetic disorders. But a carrier is not having the disease. They are just carrying that abnormal gene or a variation. And when they marry somebody who has the same variation, only then they can have a child with the disorder. So carrier is a healthy person. So there is no stigma if you're a carrier of any of the genetic variation. So carrier screening is we do molecular genetic testing of these people who are carriers of this genetic disorder, and then we tell them the risk, right? So when do we offer is again a debate, but we have options. Best is preconception before they get pregnant. So if there is any abnormality, we have time to do a genetic counseling and give them the option. Mostly, currently what is happening, they usually come after pregnancy, and then we have a very small window of doing a prenatal diagnostic testing there. So this is the committee opinion of American College of Obstetrics and Gynecologists, and they say that at least the information should be provided to every pregnant woman, and it should be provided ideally before pregnancy. If one partner is found to be a carrier, then the spouse has to be given the option of doing the genetic testing. And if they are found to be carriers, then they can opt for the options. And then if they are found, and if there is a high risk of a common disorder, we can also give them an expanded carrier screening or for their siblings. Because if they are carriers, there is a 50% chance their sibling might also be a carrier. So this way, testing one person is going to help the entire expanded family. So there are options that, okay, if you don't want to do very expanded testing, there are options that how do we check these high-risk couples? Who are these high-risk families? So they already have a family of a genetic disorder. They themselves are having a genetic disorder like neurofibromatosis. So these are people who will be adults who will marry also, but then the risk of transferring their abnormality to the child is very high. So if they themselves are having genetic disorder, especially, we have couples who are congenital deafness. So they have undergone that societal stigma and the difficulties in social challenges. So they usually marry each other, but then they don't want a child who can be deaf sometimes, right? And then a couple who has bad street history, consanguinity is a very high risk or a red flag, we would say, where we can give them a carrier screening option. And there are certain communities who are at high risk. So Agarwal community has been very well evaluated, and there are like 30 genes in which they are very high risk compared to the common population. It is just like Ashkenazi Jews, right? We always ask for the ethnicity. Before we felt that they would feel bad, but now we know that if we ask the ethnicity, we can have a way of explaining to them that they might be high risk. So there are special communities in tribal where they are very high risk for sickle cell. So based on the ethnicity, we can give them that you are high risk. And now we are also having cases where IVF is being done by donor egg or sperm, and afterward we find the patient to have a genetic disorder which was not there in the family. So the problem is the donor as well as the person whose egg or who has been taken are carriers, and then they have a child. So these are the high risk category of couples who can be offered carrier screening. So here we can see that why consanguinity increases the risk. It's not like the risk is going 100%. But if you see that as close you are to the relationship, higher the chances of having the similar proportion of the shared genes amongst you. So if you are a second degree relationship or a third degree relationship, the proportion of shared genes is very high. And so the risk of having a child with a genetic disorder is also high compared to people who are not married within the same family relationship. So there are multiple tier systems. So everybody says, why should we do everything for everyone? There could be something and they will be like very stigmatized. So we have options. Okay, let us do just thalassemia, let us just do spinal muscular atrophy or SMA, which are very common in the population. Even if there is no consanguinity, you might have the carrier status. So let us do just the common genes which are common in the population. Then there is more extensive that at least let us do for a more commoner manifestation than the very rare ethnicity based. So there are many options which can be given. So you can go from a lesser panel to the most highest panel where we are going to check all the 2500 or 3000 genes which can cause a disorder. So clinical utility is always like they ask you after we do this, what are we going to do? So yes, you may decide not to have children or you may go for adoption. Like you don't want to take any risk because rest of the risk are with either you have to take a negative reproductive decision or you may have to terminate or you have to manage the complications. So these options can be given, especially since now we have an opportunity to IVF with pre-implantation genetic diagnosis. But when we do the carrier screening, it doesn't mean that the couple will never have a child with genetic disorder or they themselves will never have a genetic disorder. There are certain genetic disorders which are not inherited. For example, cancer. So this disclaimer is always there that you are at risk, the background risk still remains. Now the second part comes that okay, now since they have already decided to get married and now the couple has come with pregnancy, how do we monitor these pregnancies? Are all pregnancies high risk? Seeing the current situation, it feels that pregnancy has gone from a physiological state to a pathological state because as soon as they get pregnant, there is a list of tests which they have to do. Right from a simple hemogram or thalassemia screening to HIV, HPSAT, everything there is a list and then we are adding a genetic test on top of it. So yes, but the thing is that can we pick up some of these high-risk pregnancies and can we give them one option? So yes, we have biochemical markers which we do in the first trimester. So everybody who is from the ops and gynae, they know that biochemical markers are being done like dual screen, triple screen, or even a quadruple marker. And then they do a non-invasive ultrasound to see whether there are any soft markers like increased nuchal thickness or hypoplastic nasal bone, echogenic bowel, echogenic foci in the heart, or ventricular megaly, inner thyroid. So these are such soft markers which can be evaluated in the first trimester, means in the first 3 months, and you can see that okay, they are high risk. Now we are giving them towards a more comprehensive testing for them. So you can do a risk assessment and then decide. So the purpose of differentiating screening is it's just like giving an entrance exam. You are getting screened whether you are worth it to go forward, right? So you will be screened in or screened out, but then there will be a second level test. So before you go to that final conclusion of entering job or your seat in your PG, you have to go for this exams, right? In the same way, these are just screening exams, but it doesn't mean that you are going to have a diseased child or you are not going to have a diseased child. So that's why we need diagnostic tests. So diagnostic tests, again, it is invasive. there are no non-invasive diagnostic tests, right? Whether you do a dual marker or an NIPT or just an ultrasound, they are not diagnostic until unless it is a major fetal malformation which has a very poor prognosis. None of these tests are diagnostic. So you have to go for diagnostic tests to prove that you are looking at a genetic disorder, and then you decide whether you want to continue the pregnancy or not continue the pregnancy. So it becomes very important to understand the limitations of the screening test versus the importance or the significance of the diagnostic test. But according to all societies, whether it is European or American or even Indian, it is that the screening and diagnostic should be discussed and offered. Whether you do or not do is a different thing, but it should be offered to all pregnant females regardless of the age or chromosome. So there was a cutoff that advanced maternal age. As soon as the female reaches 35, she is considered high risk for chromosomal abnormality. But it is not that a 22-year-old will not have a child with Down syndrome, right? But there was a cutoff to say that you are at increased risk. But now they are saying that even at the first pregnancy, be it primary at whatever age, they should be discussed these options. So these are the non-invasive tests. The radiologists, obstetricians, or gynae who do the first scan, they know the importance of nuclear translucency and hypoplastic nasal bone. These are screening tests which give you that there is an increased risk of a chromosomal abnormality, especially chromosome 13, 18, and 21. So when you see this, the next step is either you go for, because this is a screening method, either you go for a second screening method which has a high sensitivity and specificity like NIPT. So when you do that, and that is also high risk, then you may have to go for invasive method. So when you have other soft markers or when you have a high biochemical screen, be it dual marker or be it a quadruple marker, you may have to go in for an invasive testing. NIPT is becoming important because it is non-invasive. You are doing the fetal blood testing. So the fetus releases its cells. So the placental side of the maternal side of the placenta, it releases this fetal DNA into the mother's blood. So from the mother's blood, we are testing whether the fetus is having any abnormality or not. So that's why it is non-invasive for the fetus. For the mother, she just have to give a sample, and in that we see whether the fetus it has high risk. So it is quite a sensitive and specific test for screening out Down syndrome, trisomy 30, 80, and X. The indications are limited. We may not offer it to every female because it's a costly test, no doubt. But if there are certain indications where you have soft markers or you have abnormal biochemical markers, you can definitely offer it as a second line of test before going in for elimination. If soft marker and NIPT both show high risk, then you can confidently go ahead and do an invasive to rule out the chromosomal disorder. But we have to see that ultrasound still needs to be done. Neural tube defect, cardiac defects, all these will not be tested by NIPT. We are just going to screen the chromosome. And the positivity rate is quite high, the negative predictive value is very high, at least for trisomy 21. So the focus is always on Down syndrome because it is a viable chromosomal aneuploidy. It is associated with intellectual disability. In fact, it's the most common cause of intellectual disability among the chromosomal disorders. And people are aware because there is not high mortality. These children live to a quite a long time, but then the morbidity, comorbidities associated, they do not want a child with Down syndrome. For the other aneuploidies, the positive predictive values may be low. So the NIPT picks up sex chromosomal abnormalities very well, like triple X or monosomy X. But the positive predictive value is low, so you have to go for a prenatal testing. So these are the recommendations by various bodies that for any female, every pregnancy you can offer NIPT if they are affordable and if they want to go for, but it should be associated with a pre-test counseling to make them understand the limitation. And if there is any previous pregnancy or abnormal maternal serum screen result or advanced maternal age, you can go ahead and do a non-invasive prenatal. Though the name says NIPT, currently we are going for NIPS. So we still consider it as a screening test. Based on NIPT, we cannot take any negative decision to terminate the baby or to continue the pregnancy if the result is inconclusive. So these things are explained in a test counseling that there could be a chance of repeating the sample due to various reasons. So we have to go ahead and go for an invasive. So we have done carrier screening, we have done monitoring of the pregnancies. Now, if we find a female with high pregnancy risk of having a child with chromosomal abnormalities, then we may have to go for CVS or amniocentesis based on the gestational age. The CVS is done between 12 to 13 weeks. So that is just the end of the first trimester, and amniocentesis is done after 16 weeks, which is the end of the second trimester. So for chromosomal abnormalities, so you can see there could be trisomy, there could be monosomy, there could be triploidy, there could be a deletion, there could be an inversion, there could be a translocation, and all this can be checked by tests like chromosomal microarray, karyotype, or FISH. Right? So based on your suspicion, you have to choose the test. But if there is any major abnormality, no need for an endoscopy. You can directly go in for an invasive method. Because again, and I'm telling again and again, it is a screening test. Even if it comes low risk and you have a major malformation in front of you, it could still be another syndromic association which will not be picked up by any of the tests which you are doing. Right? So these are the various tests which can be offered for aneuploidy. You can go ahead and do a karyotype. So those who are in the pathology or those who are posted in cytogenetics, if it is being done here, I'm not sure. But a karyotype takes almost 12 to 14 days because you have to culture it, you have to harvest it, you have to band the slides, so it might take time. But traditional people consider it as a conventional gold standard. But still there are many things which a karyotype may miss, and so you may have to go for a newer resolution test. So these are the other, like FISH and QFPCR are rapid aneuploidy method. So that if you are seeing a child with ambiguity, ambiguous genitalia, or you have a high risk only for trisomy 21, because FISH is a very specific test. It will detect only what you have tested for, and it will not test anything else. So it becomes a limitation. So all these three tests can pick up trisomy 21, 30, 18, everything. Karyotype is a little more traditional method. But now, currently, as per all guidelines, chromosomal microarray has become the first tier testing, right? It is able to detect very small changes which we cannot pick up in a karyotype or under the microscope. So for all practical purposes, instead of sending a karyotype, all obstetrician fetal medicine now opt for chromosomal microarray as per the guidelines. So there are newer tests like prenatal aneuploidy testing by NGS. So sequencing also can pick up. So these are also very rapid tests and it can be done instead of microarray. So why we need a follow-up after NIPT is high risk or low risk? So because of the limitations, and what are the options, how we can bypass those limitations, is like we have to choose the appropriate test. So here you can see that there are multiple clues towards an abnormality. You have an increased risk even on dual markers. You have an unossified or an absent nasal bone. You also have an NIPT which shows that there is increased risk for Down syndrome, but an invasive test is coming as normal. Now this is a surprise for the doctors also. They said that microarray is diagnostic. Why you are doing a normal report? It should be that microarray just balances the normal and abnormal cells. So they test the ratios of the normal and abnormal tests. Though this family opted for FTP, we were so strongly like, if NIPT is high risk, how come microarray is normal? So we decided to evaluate further. High resolution microarray was also normal, QFPCR was also normal, but here the patient had mosaicism. So few cells had trisomy 21 and few cells had monosomy 21, right? Almost 50-50%. So when there are equal number of cells, the ratio becomes equal, right? So when 47% of the cells were monosomy 21 and 44% were 21, which is very well seen in fish. Now, based on this, we have to decide that do we start doing fish in all the samples or not? So that's why we have to say that case to case we have to discuss if microarray is normal and there is still a strong suspicion, what is the next best test? You might get something which is not conclusive. So here there was high risk for trisomy 13, but we got a micro duplication on 13, which doesn't cause trisomy 13, but something which is known as microporia. So in such cases, we may have to do the parents testing. The mother also had the same copy number variant, and she was totally asymptomatic. So we continued the pregnancy, and the baby is fine now. So the post-test counseling for such type of disorders becomes very important. And now coming to the last, that there are certain syndromes or certain monogenic disorders which will not be picked up by microarray. Microarray, in spite of being a very high resolution test, we may have to go for a better test, which is going at the molecular level. So now comes the last part where molecular diagnosis becomes more important, which is based on next generation sequencing. So here you can see some examples how your code can be wrong. So if the sentence is the cat ate the rat, the cat ate. So the code is different. There is a bug which is causing a change in the code. So the sentence makes no reasoning. So that's why we have to go at the ATGC level or at the molecular level to understand why this has happened. So for this, we have again multiple tests. So you have to decide if you're very strongly suspecting that echogenic bowel in the fetus. So you can do a CFTR or cystic fibrosis single gene. But if you are suspecting skeletal dysplasia based on your growth parameters, based on your bone, mineralization, bowing, shortening, then you can go for a skeletal dysplasia gene panel. And then you can go higher and higher depending on what you're suspecting. Right? For example, even for increased nucleotransmission, so once your microarray is normal, what next is the question? So here the child had just increased NT. Microarray was normal because this is the next step it was told to you. This is another fetus who had increased NT but also had hypoplasty. So based on parameters, we have just to send for microarray. But if that is normal, we may go ahead and do a sequencing in which first child was found to have Noonan syndrome and second fetus was found to have Costello syndrome. So if microarray is normal and you are still feeling some high risk for a genetic disorder, you may proceed for a higher resolution, which is whole exome sequencing. Especially in families like this, it's really unfortunate that in current era we still get families with such bad obstetric history. If they are referred in time, if they are evaluated in time, if the detailed history is taken, and we can do something. So consanguineous couple first red flag, recurrent pregnancy losses, second red flag. So G1, G2, G5, G6, spontaneous abortion. So like 4 spontaneous abortion. One fetus with hydrops. At the G4, the mother was so anxious that without doing any testing, she went ahead and did a termination. But then again at 7th pregnancy, the same, hydrops right? So when you have such bad obstetric history and you're suspecting something, then what is the best test? Ideally, we can go ahead and do a couple carrier screening to see whether they are at risk. But if they have already come during pregnancy and you are already finding multiple abnormalities in the fetus, you can go ahead and do a whole exome sequencing. Because when we have spontaneous abortion, bad obstetric, the first test we do is the karyotype of the couple to find if they are balanced translocation carriers. But the phenotype which shows that it has arthrogryposis or hydrophetalis, and here we found a variant, pathogenic variant in a gene DOC7, which causes a disease which is fetal akinesia deformation system. Right? So based on what the fetus has, if we offer the right test at the right time, probably we can take a better decision. So there are multiple papers now which show the importance of doing the next generation sequencing. So even if it is isolated nucleotransferency, the pickup rate is just 2%, or whether it is skeletal dysplasia. Going directly for whole exome sequencing is also making sense. But people, if they don't want to go directly for whole exome, they can do the microarray, get the DNA stored, and then go ahead and do a whole exome in the next. But that takes time. Every test takes time. So if you're doing the first trimester, it will take 2 or 3 weeks for the microarray to come. And then you are sending whole exome, again it will take 2 or 3 weeks. So you need almost 2 months to come to a conclusion. Rather than that, if in the initial stage, based on what the fetus is having, if you consult a clinical genetist or the laboratory, they can tell you, okay, for this condition, it's better you to do a whole exome sequence. So this is what a partial autopsy. So people who might go into pathology, histopathology, this is again like fetal autopsy. 50% of the cases may have a change diagnosis based on this. So you can take X-rays, you can store up the fetal DNA, and do a placenta cord along with the fetus. Always test the placenta and the cord for any other findings. Then you can opt for carrier screening and go for further testing. So these were cases of lethal skeletal dysplasia. So in ultrasound, you will find that all long bones are short, and every 2 weeks you are feeling that the bones are getting shorter. Then you say, okay, they are getting curved. But the typical findings of a telephone receiver will only be seen on an X-ray. So even if you are terminating the fetus and you are suspecting a skeletal dysplasia, you should take an X-ray. You can have clue. So this is typically thanatophoric dysplasia based on the X-ray finding. So anybody who wants to do radiology and interested in skeletal dysplasia, there are 450 different skeletal dysplasia. Lethal, non-lethal, progressive, non-progressive. So this can be a very good correlation between a fetal autopsy, a radiology, and a genetic diagnosis. Because in this, karyotype will not help, chromosomal microarray will not help. This is another fetal, antenatally against some suspected skeletal dysplasia. But if you see the fetal, it is quite similar to the first part, but here the diagnosis was different. So the molecular diagnosis is confirmatory. Based on just a photograph also will not be able to do the prenatal until you go directly for whole exome sequencing. And more importantly, because the inheritance pattern is different. In that it is X-linked and in this it is autosomal dominant. So you have to explain the risk in the next pregnancy based on the inheritance pattern of that skeletal dysplasia. So everything changes based on the molecular diagnosis. So the Society of Indian Academy of Medical Genetics, along with Society of Fetal Medicine, they have come up with a position statement that these are the indications where you can directly go ahead and do a whole exome sequencing or NGS-based testing if these conditions are present. All said and done, after explaining all the tests to you, there are still cases which are undiagnosed. So we have to be ready for that. So this is a board tibia fibula congenital tendon. It looks like a skeletal dysplasia on ultrasound, but here neither karyotype will help nor a microarray will help, and even a whole exome has come out to be negative. So there may be cases which may be due to teratogenicity, which may be due to torch infection or any other non-genetic cause. So you have to keep that in mind when you counsel the patient that even after doing all this, there still might be cases which are left undiagnosed. Right? So the thing is that whether they are reaching at the preconception, early pregnancy, or when you directly diagnosing the fetus, it depends whether you are doing assisting them with for the pregnancy, or you are assisting them with a probable risk, or you are giving a final diagnosis to them. Will also depend on what time they are presenting to you. So you have to be. So this is a mixed bag. You might be an MBBS, you might post for. So whatever you go ahead with, the clinical diagnosis, we always say phenotype is the king. So the clinical acumen of the clinician is very important when you are sending any test. You can send a hemogram, that anemia hemogram. But if you say that I am suspecting spherocytosis, I am suspecting sickle cell disease, I am suspecting virus, or I am suspecting falciparum, the pathologist at the back of that microscope will take extra efforts to correlate your clinical finding. So your clinical suspicion, what you are suspecting, is the best thing which you can offer to a laboratory. And then they always said, please correlate clinically. So if you have already given the clinical, then it becomes much more easier for them also. When you are sending a cancer biopsy, you have to tell them what cancer you are suspecting, what part it is, from where you have taken it. Pathologists can decipher it on the cuts and all. But still, if you give them that clinical information, it becomes very important for the pathologist to correlate whether you do just a hemogram or an X-ray or HPLC for inborn error of metabolism. Right? So clinical indications become very important, and in the near future, as the sequences are getting smaller and smaller, the costings are getting lesser and lesser, there will become time when you are going to take your whole genome as a master card. Right? Just like you have your Aadhaar card, you will have your whole genome data in a smart card, and you will be in a smart generation. But for that, you have to have the incentive of reading genetics, be it MBBS or be it in MD. Thank you so much.
I'm sure today's session has sparked many thoughts If anyone has a question for Dr. Sheetal ma'am, please feel free to raise your hand. It
I
seems
thought too much, I think.
Yeah, it's a very elaborative from preconception to postnatal, madam. You have given us very useful tips on that. If the couple comes with a family history of a subnormal person in a family, not been evaluated earlier, what does the test do we need to suggest them, ma'am?
So when you have just a suspicion, ideally you have to evaluate the first person. So the index case or the program. So even if they don't have the person, they might have some records with them. So even some small records. So people come with 1998 records when their person was shown to somebody in Mumbai or somewhere. But such small records can give us a clue that what we have to look for. If we feel that it could be something for which a genetic test can be offered, if the person is with us, we would test them first. Ideally, always test the program. Directly testing the fetus is a big no for all the clinical geneticists for now, because we are still struggling with variants of uncertain significance for which we do not have enough evidence in literature. But if we have that a proband had a particular condition, even if that person is not with us, and if we can offer carrier screening, even in that we might be able to give them a clue that, okay, since you are from that same family background, we can screen both of you. If we find something, we can offer a prenatal diagnosis. But there are couples who come that my brother had Duchenne muscular dystrophy, test my fetus directly. It becomes a little unethical because she might not even be a carrier. So ideally, the mother of that proband can be tested. So her mother can be tested. If she is a carrier, then the female has to be tested, and then we test the fetus. So indirectly, this takes time. So whatever abnormality is there, it's always better. Now everywhere we are doing online teleconsultation also. So if they have, we can do an online teleconsultation, review the record, draw the pedigree, and then we can offer them the test accordingly. If it is, even if they have a muscle biopsy showing muscular dystrophy, then we can offer some testing, but then we have to do the carrier screening first before doing the fetus.
Thank you, ma'am.
excellence deserves appreciation. Let's recognize excellence with a well-deserved applause. Thank you, Dr. Sheetal ma'am, for an exceptional session and reflective cheers. I now invite our respected chairpersons to kindly felicitate our distinguished speaker. It is now our privilege to express our heartfelt gratitude to our respected chairpersons for their invaluable presence and guidance. May I invite Dr. Geeta ma'am to kindly come forward and honor our chairpersons. Thank you, Dr. Geeta ma'am, for kindly doing the honors. We sincerely thank our respected chairpersons, Dr. Sheetal ma'am, and each one of you for contributing to a wonderful first scientific session.
As we transition to the next session, it is thought to reflect on 70% of clinical decisions are influenced by laboratory investigations. Then the true value of laboratory research lies not only in the number itself, but in its integration with the clinical context. The third perspective, we now move on from an insightful lecture to an engaging exchange of ideas. It's my pleasure to welcome you to the second scientific session of panel discussion on challenges in the interpretation of common laboratory test results. May I now invite our esteemed moderator, Dr. Sujay sir, who has over 30 years experience in laboratory medicine, along with the distinguished panelists, Dr. Jairam sir, Dr. Mallikarjun Kirti sir and Dr. Yogendra sir to kindly come forward and take your seats on the dais. Ladies and gentlemen, please join me in welcoming them with the applause. A very good morning to all of you. Thank you, Dr. Shikal, for that wonderful session. A lot of insights there. At the outset, I would like to thank IMA Chitradurga for their banner under which we are having this full day CME. I'd like to thank the Department of Pathology, Basaveshwara Medical College for organizing this. Thank you, Dr. Murthy, for the entire organization. I see a lot of students. How many of you are undergraduate students? Please raise your hands. Wow. Thank you for coming. In whatever context you have come, you deserve an applause. May I see some hands for postgraduates? Give them a round of applause. So, laboratory medicine is a significant part of clinical medicine, and like it was mentioned, 70%.
First topic will be very heavy for you. It was very interesting.
A small technical glitch and we are up and running now. So, when it comes to laboratory medicine, there are many aspects that need to be looked into, whether it's screening or confirmatory, early or late diagnosis. All of those needs to be looked at, and Dr. Shikal took us through the entire reproductive genomics in a very insightful way. I think she's part of the panel along with Dr. Jairam, Dr. Pradwal, and Dr. Swati. And yeah, so each of them are experts in certain areas of laboratory medicine, and we hope to see how we can cover the entire next 1 hour in routine testing, common testing. I've included Dr. Sheetal because genomics also has started to become routine. So, as from that point of view, we have looked at. So, these are the general topics that we are going to cover. And at any point in time, if you feel that you have a doubt and you would want to ask a question, please raise your hands and we can have that question answered by the panel. So let me start with Dr. Sheetal herself. We did hear her telling screening and confirmatory tests, but I still wanted to have this from her. Is genomics a screening test or a confirmatory test? Clinicians often treat a single genomic result as the final word. Where does that framing break down? Meaning, it can be a pitfall. And what is the risk in such an approach?
Okay, so again, I would say it all depends on what your, yes. So the purview being that whether you just want to screen a asymptomatic person or you want to test a person who is having the disorder. So the difference is that. So if you have it and you're testing it, it is diagnostic. If you don't have it, but you want to know, then it is a screening test. So we get samples of children as young as 12 years, 18 years, not even 18, 10 years, for because the mother had early onset breast cancer and she BRCA1 variant was found. The thing is, being asymptomatic and at 10 and 12 years, you are not going to do anything for them anyways. So whether you want to screen that small child before she attains an age where she can take the decision whether she wants to be tested on it. So BRCA1 testing in the mother is diagnostic, but if you want to screen the children, it becomes a screening test. And even the presence of a BRCA1 is not 100% that she is going to get breast cancer, but that anxiety will be 100 folds. So because there is incomplete penetrance. So the limitations of the genetic test comes in the, not the principles, but the exceptions. So when you have exceptions like incomplete penetrance, variable phenotype, and you have that it is coming from an asymptomatic person, then those limitations bring the level of the testing down. So again, as what I told, that it remains the context in which you are testing. So if you're screening the population for thalassemia, you will find carriers. So that becomes a screening test. But when you test the spouse, again, that is screening. But when you do the fetus, it becomes diagnostic. So that is the context between diagnostic.
That's wonderfully put. In the screening of asymptomatic, have you come across false negatives? You go ahead and do a genetic screening test. Have you come across false negatives?
Yes, there are occasions because it depends on what test you have done. So if you are testing for DMD and you are sending a whole exome, you might not find the deletion. So you have to send a different test. So if the test is different, you might get negative. But even if you're sending the right test, there are chances of false negative depending on where the variant lies. So currently, we are at the level of whole exome as a diagnostic, which are just testing the exons of the genes. We are not testing the introns, we are not testing the promoter regions, we are not testing the entire genome. We are just testing the exons. So yes, if a variant lies in that, or there is a post-translational error or post-transcriptional error. So there are certain epigenetic disorders which will not come up in the test which we offer as a diagnostic test. So yes, they might come out as false negative.
So clearly the decision on which technique to use, whether it's karyotyping, FISH, microarray, or whole exome sequencing, is a matter of immense importance because as a clinician or a laboratory person, we may not have a full understanding of which technique to choose. And that's where I think it's important to seek the counsel of genetics experts so that there is clarity in which test we do. The incidence of false negatives also depends on which technique is used.
Yes, definitely.
So
definitely.
each of them can miss out many.
So we have in which the first child was affected with spinal muscular atrophy. So we have to test SMN1 and SMN2 genes for deletions. But for the couple, the doctor offered karyotype. Karyotype came to be negative. So they said there is no risk, you can go ahead and have a baby. And then the baby was also affected. So they chose the wrong test for screening the parents. So if they would have done the same test in the parents that they were found to be carriers, then prenatal would have been done and we would have told them that that baby is also affected. So choosing the test for the parents also becomes important.
So if there is a genetic change, but the phenotype is okay,
Hmm.
what would be the approach?
So in that case, it is what is the age of onset of that phenotype. Sometimes we are screening newborns. They have still not developed the disorder. But in the future, will they develop it is the question.
Yeah.
Right? So some disorders may come after the weaning has started because the protein overload is there. So the inborn error of metabolism will come that time. Until that, the child is normal. But you are doing a newborn screening and you find something abnormal. Then you have to keep the child under surveillance. So that's what I'm saying. The anxiety is there, but at least we will be able to keep the person in surveillance and pick up the diagnosis. Similarly, if we are testing a child and they come to be having a molecular diagnosis of a disorder which causes, the child is having cardiomyopathy, and the gene causes cardiomyopathy as well as adult onset muscular dystrophy. So the parents, if they are having the same, they will have to look out for developing symptoms of muscular dystrophy and cardiomyopathy also.
Thank you, Dr. Sheetal. I'll come back to you later. Coming to surgical pathology, I think there's a lot that is happening in surgical pathology, particularly when it comes to immunohistochemistry and genomics on surgical pathology specimens as well. In surgical pathology, cold ischemia time and fixation of the specimen quietly degrade if you are going to do ERPR to and TIS67. What is the pre-analytical failure you most wish clinicians understood, and how does this affect the interpretation of the IFC biomarker? Dr. Jain.
I think it's a very well recognized fact that for a, especially when you do a predictive markers for IHC, a pre-analytical sanctity plays a major role. The biopsy has to be clean, and if it comes to choosing one pre-analytic, I think the entire sequence of pre-analytics helps in giving a good preparation. Starting from the operation theater, how clean the biopsy is, how free of crush artifacts the biopsy is, itself determines how clean your IHC preparation is and how clean your interpretation is going to be. Now, coming to cold ischemia, that's the time taken from the the time the tissue is actually disengaged from the patient to the time it is put into a fixative. That is called a cold ischemia type, because a lot of antigenic degradation can happen during that time. And ideal maximum, the allowable cold ischemia time would be 1 hour, but ideally 30 minutes would be the limit within which that tissue needs to get into formalin. Now the formalin, again, the pH is very important. It should be close to neutral, 7.4, 7.6. Then it should be neutral, it should be buffered, right? So this formalin, of course, 10% neutral buffered formalin is the ideal fixative. Now you cannot, you put the tissue into formalin within, say, 1 hour or 30 minutes, accepted. But then it should not stay in formalin for a long period of time. That's the other time that is important. And people have said that if you have a tissue which is in formalin for more than 72 hours, then especially the HER2 staining and other predictive markers, they take a beating. So the duration of fixation also becomes important. Then comes the laboratory part, how the processing is done, how how big the tissue blocks are, and how the blocks get stored before the immunohistochemistry is done. If there is a delay, ideally these blocks should be stored in the refrigerator. So on both sides, from the clinic side as well as from the laboratory side, there are a lot of pre-analytical issues that need to be addressed for an ideal predictive IHC marker report. Apart from that, of course, we have other issues about your the viability of your antibodies and all that, but that generally is taken care of by the laboratories.
Thank you, Dr. Jalan. I think the pre-analytical variables that go into interpreting IHC biomarkers is very important. And with that pre-analytical variable, like Clara mentioned, we request the surgeons to consider putting the specimen, the tissue into the formalin, the right formalin at the earliest, and the labs to handle the specimen in formalin in such a way that it's not longer than 72 hours. So, those are the important aspects when it comes to initial surgical pathology questions. I'll come back to you, Dr. Java. Coming to hematology, Dr. Swati, which automated cell counter analyzer flags do you treat as non-negotiable triggers for a manual smear review?
So firstly, all the analyzers do give us the flags, but what we focus primarily are the scatter plots and histograms. So there are these certain patterns that we observe. And even before we look at the flags, we look at the scatter plots and we pick the abnormal scatter plots. Say in WBCs, there are atypical cells. In RBC histogram, if we see macrocytosis, or if we look at platelet clumps, which is reflected in IPF mode. So all these give us an answer even before we read the flags. But when it comes to analyzer flags that we consider as non-negotiable, one would be for platelet clumps and any platelet abnormal distribution. If the platelet count is less than 1 lakh, we ensure that we look at the smear, we do a smear review and only then finalize the results. And there's also certain flags such as atypical lymphocytes, which we see often in a lot of cases, which may not be very specific. So we don't pay too much attention to that flag, but we focus on the scatter plot. But at the same time, if there is a flag on WBC abnormal scattergram or WBC abnormal differentials, which is present across analyzers, we pay attention to that and we take a look at the smear. So in such cases, smear review is non-negotiable.
Thank you, Dr. Swati. So the corollary to that,
Yes.
which flags do you accept and not see as smear review?
So if it is just increase in counts like neutrophilia, eosinophilia, or presence of NRBCs, I mean, we look at the, NRBCs I think would still require a smear review, but just increase in counts or microcytosis, macrocytosis may not really need a smear review.
So isolated count
Account,
flags,
that,
go ahead and proceed with
yes,
the
yes.
A follow-up question on that. Spurious results like EDTA-induced thrombocytopenia, platelet counts, you already mentioned. Walk us through how your lab catches these before they reach the clinician.
So with respect to platelet count, EDTA-induced pseudothrombocytopenia and platelet clumps, so we have a rule, any platelet count less than 1 lakh, we do a smear review. We process it in IPF mode, which is a much more sensitive method of processing, of looking at platelet count than impedance. So one, IPF mode, and IPF scatter also gives us a clue on presence of platelet clumps on the smear. And we invariably look at the smear for those cases. And with respect to cold agglutinins distorting MCV, MCHC, yes, cold agglutinins, again, RBC histogram has a very peculiar pattern. Even before we look at the values, by looking at the RBC histogram, we can suspect there is presence of RBC autoagglutination. And MCV, MCHC is markedly high, which is not usually seen. So in those cases, again, we pick those up by looking at the histograms and the numerical value and do a smear review. And lipemia, yes. So the hemoglobin hematocrit, the rule of 3 doesn't really fit well whenever there is lipemia interference. And also, again, scatterplot helps us in picking up lipemia cases where there is a lymphomono merge, which we usually observe. So that, along with hemoglobin and hematocrit value, we can predict there is lipemia. There is an interference. And also, with respect to this, we have a flag, turbidity or interference flag, which we take a look at.
Wonderful. For platelet counts, what are the techniques the cell counter generally uses? Impedance, every cell counter.
Yes, that is the first one, impedance. Then there is Sysmex analyzer has optical. which is in retic mode. Along with these two, there is IPF, which is fluorescence, and IPF fluorescence is taken to be the most sensitive, especially in presence of RBC fragments.
Thank you, Dr. Swati. We move on to,
If I may interrupt, Dr. Swati, it's a common, practice that when a machine gives low platelet count, a lot of people rely on a manual platelet count, and then they release the reports based on the manual impression. So, what is your take on that? What should be done ideally?
I'm not entirely sure what should be done ideally, because I think everybody has a different opinion on that. But what we think is analyzers are much more sensitive, especially like I mentioned, if it is processed in IPF mode, the count it almost always matches with the smear review as well. But from the clinician's point of view, the request that comes for manual smear review is to have the uniformity, because the patient might go to different places, different labs, different analyzers are being used, and it is not always mentioned which methodology is used to give the platelet count. And then the clinicians apparently they think that they don't know exactly what is happening with the patient, whether it is whether it is like Harris platelet syndrome, which doesn't really need further workup, or it is some disorder where actually workup is required. So to have that uniformity, they request us to do a manual smear review. But in our experience, if the platelet count which is processed in fluorescent mode almost always matches with the smear review criteria.
Thank you, Dr. Swati. When it comes to platelet manual review on the smear, in addition to the counts, I think it's also the
Morphology, correct.
that will help us.
Correct.
Probably your macroplatelet
Yes.
or granulation of the platelet.
Yes.
Those will help as well
Yes.
when it comes to manual. But when it comes to counting, the cell counter counts thousands, if not hundreds of thousands of platelets, whereas the smear counts only 5 or 10 platelets per
HIPAA field, yes.
So the sensitivity of the platelet count is the best with
Cell counter.
The specificity is best with smear review.
Agreed.
That complements each other. So please don't eliminate one over the other. Both are important, but you need to know when should you actually look at the smear when it comes to platelet counts. With that, we'll go to the next one, Dr. Prajwal. Cystatin C is now recommended for confirmatory EGFR before consequential decisions. Drug dosing, transplant eligibility, clinical trial entry. Where has your lab actually operationalized it, and where is it still aspiration?
We are doing cystatin C from long time, but to operationalize confirmatory EGFR, we are validating currently. Maybe in another 2-3 weeks, it will be completely operational. So we have certain challenges in using the new formulas which have come in 2021 by CKD API. There are 3 formulas have been released. One is for creatinine, one is for cystatin C independently. Third formula is a combined formula which takes both creatinine and cystatin C, which has been proven superior to all the other 2 formulas. But there are conditions where you may have to go back to the actual formula, which we had a case, say patient around 40-45 years. So they have sent for creatinine EGFR. So creatinine was persistently not detectable. It was less than the AMR limits for the patient. So, but clinician is suspecting strongly renal failure and he wants to do the EGFR. So where cystatin is, then we follow up with the clinical history. Patient was known polio case for almost 30 years. So the muscle mass was very low. So creatinine was not generating. So we done the cystatin C. We used a combined formula where both creatinine and still EGFR was normal. Then we used independent cystatin C formula. There actually it picked EGFR was low, patient is going towards the failure. So it was totally, we thought we'll straight away operationalize combined formula for everyone, but it is not correct. We have to use all the 3, and situationally we have to use which formula to be used for which patient depending on the clinical conditions. And it becomes very critical at around the EGFR value of 60, where your critical decisions changes for transplant eligibilities and even drug dosing, everything changes around 60, where cystatin C plays a key role. So we have to decide upon the situation whether to use combined equation or cystatin C only equation. And there is one more challenge in this case also is creatinine has two different methodologies. One is kinetic Jaffe, the other one is enzymatic method. You also need to be sure the whichever method you are using, it should be ICP-MS reference method. Then only the formula may work correctly. And also there is a study in Indian population, only creatinine GFR matching to the measured GFR, it is not that great, but cystatin C combined with creatinine GFR is very helpful, especially in the Indian population.
Thank you, Dr. Pradeep. Are there any clinicians who use EGFR that you would like to hear their challenges with EGFR? Anybody in the audience? Okay, so another question there, what are the conditions on your standard checklist that make an HbA1c result untrustworthy? And how do you flag them so clinician doesn't diagnose or adjust therapy on a spurious study? I think I'll ask Dr. Prajwal and Dr. Swati to comment on this. Have you had any?
There are a lot of interferences with respect to A1C values that we observe every day. Most commonly is RBC hemolysis causing false low A1C values. So we have picked up a lot of hemolytic anemia cases by looking at really low A1C value. So any value less than 4.4 A1C goes for a smear review. And most common abnormality that we have picked up is hereditary spirocytosis. And recently there was a case of which was sent to us for A1C, and the value was 2.9, which is very low. And then it was observed. So we got a CBC done, pancytopenia, and we got a retic done for that case, and retic showed 19%. So it was, and DCT was positive. So it was an immune hemolytic anemia which was causing markedly reduced A1C. So in those cases, like hereditary spirocytosis also causes 4.3, 4.4. So we don't usually, I mean, the value goes, but then we make a note that it might be falsely low because of RBC, because of hemolysis. So it is ideal to use a different platform for monitoring glucose levels and not A1C in those cases. And also in very high counts, when CLL, CML cases, so we don't get a value. I'm not entirely sure why, but markedly high WBC counts interfere with the A1C value. So we don't get a value. And when there are abnormal hemoglobin variants, so especially homozygous variants where HbA is not present, so we are not going to get A1C value. And there are certain heterozygous variants also which interfere with A1C values, causing either low or elevated A1C values. So these are the most common interferences that we come across.
So one more challenge is what we are seeing recently is HbA1c glycation can be interfered with heavy metal poisonings. So many non-traditional medicines contain heavy metals, which inhibits the glycation of HbA1c. If you see the HbA1c values may appear normal, but their fasting, postprandial, clinical picture, everything points to clear-cut diabetes. But if you see the HbA1c result, no other variants which Dr. Swati flagged, nothing is, but still values will be staying low side. So many heavy metal trace elements can interfere with the glycation, which may feel the patient is normal, but falsely glucose fasting and are elevated. In those cases, like even fructosamine may come normal because that glycation also limited. You have to look for heavy metal screening before proceeding with the HbA1c values, which needs to be monitored.
Yeah, apart from these, I think the non-steroidal anti-inflammatory drugs and malaria, chronic malaria, both of these contribute to discrepancy between A1C and blood sugar
levels.
I think that's something that we need to keep in mind.
I want to.
Yeah.
So recently we had a case in which the HbA1c was 54 and they had sent for HBB. And even I was like, how can we have? But there is a very specific mutation in Thailand. And that HBB variant causes this spurious HbA because that abnormal HBB moves along with that same
This is HPLC or
HPLC, yes.
I think we have seen a lot of variants contributing
Yes.
to abnormal spurious A1C, but there's some guideline. If if the variant is above 50%, it cannot be reported. If it's below 50%, it can be reported. Things like that. But clearly, I completely agree that variants cause a lot of spurious frequency results. In which case, continuous glucose monitoring or average glucose can be a good monitoring tool. Coming back to you, Dr. Sheetal, I think this you have answered in your talk as well as later. Setting aside symptomatic patients, where does genetic testing of this general asymptomatic population actually earn its place? And where are we testing simply because we can?
So the most important currently, I would focus on thalassemia because uh, I think when I was doing my DM, we had done a general, like a college screening. So we do the pre-test talk and everything, and whoever volunteers, and we found quite a high increase in the carrier status. Even recently, in one college in Surat, we just said, okay, let's target the, because even the university has done it compulsory to screen all as soon as they enter college. Before they go for the exam, they have to have their HbA1c done. So HbA2 level screening, that is a genetic test. But if they come carriers, we just do the HbB screening. So in such asymptomatic, it is earning its place as far as thalassemia, sickle cell, because we have that Prime Minister Yojana, eradication of sickle cell. So, and where we are testing simply because that's what I give the example, because parent is having cancer and you are screening asymptomatic underage minors. So if we have a asymptomatic consent form, so we have to make the parents understand that, you know, if it comes positive, because we have seen where the mother, instead of caring about BRCA, she has gone into depression because her child is having the BRCA variant. So that becomes, just because we are able to do it, we should not start doing scarier. So we have to do that pre-test counseling, whether they are really understanding why they are doing the testing. Sometimes it is for deafness. So there it is okay, because if you do an early screening of the child, then we can do for speech therapy or whatever, we can address them. So there are situations depending on how important is the test.
It really becomes an ethical dilemma.
Yes.
Particularly at the time of counseling.
Yes.
We know it has no value
Yes.
in the context that
Yes.
it's seen. Yet the parents insist that it needs to be done.
Hmm.
How do you go about such situation?
So for genetic counseling, one of the pillar is non-directiveness. So we cannot advise or tell the parent to do something or not do something. We try to convince them, see, this can cause this. So but they say, we just want to know, if it is not, then at least we are free of anxiety. But the other way around also has to be told. But if they agree, then we have to take a written consent that they have been explained this and still they are ready to do it. So that's fine. And more so because in asymptomatic, when we are doing newborn, parents don't agree because they don't even want to prick their child. They kuch hai nahi, why should we prick them? But newborn screening, at least for the 5 common disorders, it is a treatable condition, because hypothyroidism, within a year, the child comes with so much of subnormality, faces changes, growth disturbances, and just a small drug to be given. Similarly, for biotinidase or even for sickle cell, we are doing newborn. It is not going to change anything, but till 1 year, we know whether they will become symptomatic or not. So it, depending on the condition, we have to decide the importance of that testing.
Thank you. Thank you, Dr. Sheetal. Are there any questions from the audience? Yes. Can we have a mic there, please?
I have a two-part question. One is, what is the role of cystatin C in pediatrics? Is there any emerging role of that? Second, if at all we are doing an EGFR by different methods, which method would you advise in the pediatric age group? Because generally our creatinines are quite low. And what is the role of EGFR in PEM patients while adjusting the drug doses?
What patient?
Protein energy malnutrition, pediatrics.
Thank you. So two things in pediatrics, always enzymatic creatinine is preferred over chapter.
Okay.
That is why where low levels chapter can't detect, but still enzymatic can go up to 0.1 pediatrics. So specifically in pediatrics, always enzymatic creatinine is recommended. So to coming to EGFR, So whatever CKD EPI equations are currently available, all are for above 18 years. So for less than 18 years, there are only independent equations of cystatin C and creatinine. So in pediatrics, cystatin C only equation is the preferred one if it is case of PM. If it's not a case of PM, then still creatinine equation can be used.
Okay. Sir, Narayan Murthy sir, what method are we using here in Basaveshwara sir for the creatinine analysis?
In Basaveshwara, I think biochemistry department can answer. We are
Okay.
doing enzymatic method.
Enzymatic method. Okay, sir. Thank you.
Thank you. Thank you for the BMCH, I think. Biochemistry, same thing there, no?
Any other question? Okay, I think the next one follow-up has been answered. Does a negative genomic test rule out the genetic cause, and how do you set that expectation before the sample is even taken? Counseling. Yes. Yeah. Yes.
So we had a case in which the doctor who suspected a gun marker and for 80 days they said in basic test for trisomy 21. Now trisomy 21 is very specific but she had seen a test, right? And then the result gave us negative. The child was born and had some response. So the doctor said that there is not even mention micro. And micro, what are micro deletion or a duplication is some other. So the question is now medically they have gone that why did the doctor not advise microlevel where it was more sensitive and specific than a hair? But I think the 21 doesn't need a so medical lesion if the options are given. The clinician think on point of your patient, so they are not a body, it will be said, we will not even offer a possibility. But sometimes they surprise that if given an option, and if we explain the specificity of every test, a parent is more receptive to that even understand how they try to give. They might take it. But if they say no, they will negative quality problems because they are not ready to do it. And sometimes through the prenatal they don't want to continue.
Clearly a very challenging situation. Typically difficult, lot of variables contextually, and deciding on behalf which is not done as a principle, we cannot decide, but we need to only counsel, and that is not happening adequately. So
Most challenging is when we have neither yes nor no. It is the inconclusive or the uncertain variable get either microwave or in the lens. This really will get in NIT, then sometimes the data is not given. That is the most challenging part of doing a counseling. You are saying yes, but you are saying no. What are so that is more challenging than just getting a negative or a
in your experience on the medical legal side, do you think the legal system is ready for such situation? Okay.
because consumer protection always favors the patient. Only association can be but we have to give so much of scientific evidence, give so much of literature, and we have to come down to their level and explain the limitations of the test. So genetics, I think we are still not ready as far as medical legal.
Thank you, Dr. Shekhar. The next question to Dr. Jaina. FNAC is fast, cheap, and minimally invasive, but adequate and benign carries different weight in different organs. Where is FNAC genuinely decisive, and where are we asking it to do more than it can?
Here, I think we have to be very, very clear on not interpreting the evidence findings in isolation. There's always a trial which has to be followed, the clinical finding, the imaging findings and the cytology. Now, people often look upon cytology as a tissue diagnosis, and many times rather heavily on cytology, regardless of what your clinical impression or your imaging findings are. I think this trial has to be looked at in completion, not individually. So that is one point. Now, second is if there is a situation where cytology needs unequivocally a positive values, that needs to be given. But on the other hand, if cytology is negative, regardless of whether imaging was done or not, whether it's a blind cytology, if cytology is negative, then there are a lot of issues which can contribute to a negative cytology, apart from interpretation alone. It could be that the material is not representative simply, or the mass is so small that it's not sample. So negative cytology definitely needs, again, people have to go back to the clinical thing. So a lot of people ladder their problems when they focus especially only on psychology. Now, the other area in psychology which people have a lot of expectations, again here, this opinion may vary between pathologists, different institutions. When it comes to lymphoreticular system, lymphomas, I do not think the area, the institution where I train strongly does not advocate categorizing lymphomas based on cytology. You have one direction, you say that this looks like a neoplastic node, lymphoreticular malignancy, but it does require many other things. And often, now of course, everybody leans very heavily on IHC markers or even the further studies, molecular studies. So again, cytology, morphology alone cannot be relied upon to categorize a lymphoma. It may be a starting point.
So should the negative result of FNAC, should the report carry that sentence that the negative result does not rule out disease?
I think it is imperative in the current scenario where, at the top of the hat, you may be faced with a medical challenge. It is imperative that one needs, whether it's negative or positive, this blanket statement has to come, that the cytology finding has to be correlated with clinical and the imaging findings.
Okay. Thank you, Dr. Jayara. We go to Dr. Swati. ESR is one of the oldest tests still in daily use and one of the most non-specific tests. What, in your opinion, is the future of ESR?
I think it is losing importance day by day because most clinicians are shifting to CRP, especially in acute cases, so when they want to assess. But I would not see ESR becoming completely obsolete. In a discussion with certain clinicians, it has come up that ESR is still a part of certain criteria, diagnostic criteria, which is used in certain rheumatological tests. So there are currently around 30% spondyloarthritis cases where CRP might be low, but ESR might be elevated. So it still has value, but slowly the focus has been shifting to CRP. Also because there are a lot of interferences with respect to ESR, anemia, pregnancy, and gender, even all of them plays a role. Such interferences are not seen in CRP, but slowly it is losing importance, but I think it's going to stay this for a while.
Yeah, I agree. What about ESR more than 100? That's one area. That's one area where I see a lot of benefit. Anybody who's using ESR in your clinical practice and you see value in ESR? Lot of value. Excellent. So we have a user of ESR who says it cannot go out of reckoning. Any specific reason you will? Because, like Dr. Swati mentioned, the indicators or markers of inflammation have started to come, like CRP and others, IL-6.
I'm an ENT surgeon.
Yes, sir.
I found it to be useful in many diseases. First line screener, that will give an indication how to be going for it further.
Okay,
Yes,
so
yes, maybe.
were you looking at ESR that was high that helped you decide, or ESR that was normal? High ESR. A normal ESR would flag anything. You wouldn't give too much importance to that. But a high ESR is something that you look at. And a high ESR in your mind is inflammation, or is it related to something going on, but we don't know what. So you go. It's something that you use to go for the next test. Oh, thank you, sir. Yeah.
So in terms of ESR, we are intensive. So how we use ESR is, especially in some cases like macrophage activation syndrome, actually ESR going down, that gives us a very critical clue that the MA or macrophage activation syndrome is being activated. So it's not only that increasing ESR, not only intensivist, the even the decreasing ESR gives you the clue.
Excellent. Thank you. Thank you for that insight.
So is it in a decreasing trend for a certain value?
Decreasing trend, because once the ESR is going down, that means that macrophage activation syndrome is building up. So we have to work with higher steroid.
Do you see any other markers coming as a surrogate? This seems to be a surrogate marker rather than a very specific marker. ESR going down. Do you have any specific markers in your understanding?
Yeah, there are different by images. In the ferritin goes up, the fibrinogen goes down. So there are the markers, but this is the one screening test. Like if I get an ESR which is going low, that means antennas are up. That means something is going on.
So do you use soluble CD25 as well?
Not. No, we don't have it.
Okay. Thank you. I've been told that we have to wind up in 10 minutes. So 11:55 will be winding up. Is there any question?
Just a few points. Again, when ESR said it's more than 100, actually, which is a thing of only 3
Yes.
One is a malignancy, other is a connective tissue disorder, tuberculosis.
Yes.
Actually, rise ESR, that's more classic side, actually, it is an ICU, actually lowest, but IESR, actually, we are thinking always it is a one of the things actually we need to make differential diagnosis of these.
That's the classic teaching. Sarcoidosis, malignancy, tuberculosis, all these are. Thank you, sir. I think we'll go through a few more questions. This is for Dr. Prajwal. Pride is still the default LDL calculation in many labs, despite its known failure at high triglycerides and low LDL. Should we have moved wholesale to Martin Hopkins or Sampson equations by now, and what stops labs from switching?
So, as you said, Kidwal fails in PG not just 400, above 200, 250, and LDL level it is less than 70, then Kidwal would work. Even direct LDL for that part will won't work if the LDL is less than 70. So, where the implementation challenge is most probably the other. Martin Hopkins came in 2020, whereas first Samson came in 2021, and modified Samson came in 2024. So that may be the one reason that could be the stopping. And Martin Hopkins has a different challenge of implementation. It is a complex table which has 160 factors to be filtered, whereas Samson is slightly easier to be implemented, but it's a complex formula, but still it can be implemented very easily in life. And it's very secure. Up to PG 800, it works very well, and it correlates very well with the beta quantification of LDL, which is a good standard.
Please come. Exactly 12 o'clock. Follow-up. Non-H Non-HDL cholesterol and ApoB are arguably better markers of residual risk, yet clinicians rarely ask for them. Is that an education gap, a reporting gap, or a guideline adoption gap? And whose job is it to close?
So if you take the order of preference, the first place will go to ApoB, next non-HDL, next LDL, and last cholesterol. So if you see the ApoB should be the preferred marker for any screening. Till 2025, no guidelines have adopted ApoB into the screening. Only from 2026, they are bringing ApoB with a clear cutoff, but that also after first step. Once you achieve the LDL target, then next step is to achieve the ApoB target. The LDL target would be 100, whereas ApoB target would be 90. Once you achieve the LDL target, then move to the ApoB target. That is how it has come. But soon, 3 or 4 years, LDL and non-HDL will definitely be replaced with ApoB.
Any questions on the lipid profile part, using ApoB as a marker instead of LDL? Any experience? Okay. We have 4 minutes. I'll come back to Dr. Sheetal here. Where does pretest probability and phenotype fit in interpreting a genomic result? Is the lab interpreting a variant or interpreting a picture?
I told that in my talk that phenotype is
Especially you
as much and the easiest example I gave is solving a puzzle or solving a crime.
Yeah.
You cannot prove anybody guilty till you have as much evidence as possible. So whenever we are asking for additional information for clinicians, they feel that how much more is more. But it is that we are just filling in the puzzle. Even one more information about the patient can help us make that variant significant compared to making it as uncertain. So, genomics or this NGS data is dynamic. We are still learning phase. It's not completed. Out of 20,000 genes, we have information about 8,000 genes. We are still 12,000 genes away from knowing the complete disease pattern in humanity. So when it comes to that, to understand and interpret the genomic result is as much information about the patient you can give is still less. And sometimes we get the variant, it is a very good description, but still it is uncertain significance because we are just lacking one enzyme level, we are just lacking some functional study in claiming that variant to be significant for that variant. So yes, the most important is the pre-test differential diagnosis of the doctor, plus what the patient has come with, and more so because we are being specialized so much that pulmonologists will not look at the liver, a hepatologist will not look at the brain, but when we get a variant and it is going to affect all systems, then we have to have a unified decision from the neurologist, from the hepatologist, and we have to have a combined phenotype to confirm that the variant is finally matching. There's a described phenotype like seizures. So seizures can have multiple causes. There will be more than 1,000 genes which can do. But if seizure is associated with neurodegeneration or MRI is giving it agenesis of the corpus callosum. So these little clues will, instead of giving 4 variant of uncertain significance, we might very easily exclude 2 because the child doesn't have tasted like an eye finding, which causes tasting. So yes, the pre-test findings from the clinician is very important, including or excluding genetic variant.
Do you see proteomics in the near future assisting you in interpreting genome?
Not near future, it's already there. So nowadays, we are doing metabolomics. So along with the genomics, because genomics has a limitation, so you are just changing the code. But that code, how it is impacting the protein. So the proteomics is becoming a simultaneous testing to be done. So then we probably will move to whole genome testing, and along with that, the many of these variants of unsettled, because we want to know the protein structure, or we want to know whether it is increasing, decreasing, and how it is impacting the downgrade protein. So now it is coming to the pathways. Yes. So you have a genetic mutation in this gene, but it downgrade protein is getting affected. So that pathway study or metabolomics is coming up. So yes, proteomics along with epigenomics. So now we are moving towards multiomics. So just genomics will not be.
Thank you, Dr. Shipal. And I think with that, in the interest of time, we will wind up. A round of applause for the panelists, please. And a round of applause for all those who asked questions. Thank you very much.
We request the moderator and panelists to remain on the dais for the felicitation ceremony. As William Osler wisely said, medicine is uncertainty and an art of probability. Today's panel has beautifully demonstrated how thoughtful interpretation bridges the gap between investigation and patient care. As a token of a sincere appreciation, may I now invite Dr. Shilpa ma'am, Dr. Yogendra sir, and Dr. Ravikumar sir to kindly come forward and do the honors by felicitating our esteemed moderator and panelists. Ladies and gentlemen, our appreciation speaks loudest through our applause. Let's make it count. Dr. Sujay sir, he has over 30 years of experience in laboratory medicine. Next, we have Dr. Jairam sir, an eminent histopathologist. Dr. Sheetal Sharada ma'am, Director of Genomics at Neuberg Center for Genomic Medicine. Dr. Swati Kulkarni ma'am, Consultant Pathologist, HOD of Immunopathology in Neuberg Anand Laboratory, Bengaluru. Dr. Prajwal sir, Chief of Laboratory and HOD of Biochemistry in Neuberg Anand Laboratory, Bengaluru. Thank you, Dr. Shilpa ma'am, Dr. Yogendra sir, and Dr. Ravikumar sir, for graciously doing the honors. Great discussions may come to an end, but the ideas they inspire to live on.
ನೋಟ್ ಟೀ ಬ್ರೇಕ್ ಅದಕ್ಕೆ ಬಿಬಿಟಿ ಹಾಕಕ್ಕೆ ಹೇಳಿದ್ದೀನಿ ಅದಕ್ಕೆ ಸರ್ ಹೇಳಿದೆ ಟೀ ಬ್ರೇಕ್ ಕಳಿಸ್ಬಿಡಿ ಯಾರು ಬರಬೇಕು ಬರ್ತಾರೆ ಕಳಿಸ್ಬಿಡಿ
ಓಕೆ ಓಕೆ ನಂಗೊಂದು ಕೊಡಪ್ಪ
ಅಲ್ಲ ಸರ್ ಸ್ವಾಮೀಜಿ ಬಂದಿದ್ದಾರೆ ಈಗ ಹೇಳೋದು ಬೇಡ
ಇಲ್ಲೇ ಕುತ್ಕೊಳಕ್ಕೆ ಹೇಳಿ ಟೀ ವಿಲ್ ಬಿ ಥರ್ಡ್ ಇಯರ್
ಏನು ಹೇಳೋದು ಸುಮ್ಮನೆ
ಅಲ್ಲ ಬೇಡ ಹಿಂದೆ
ಏನ್ ಬಾರ್ ಇನಾಗ್ರೇಷನ್ ಅಂತ ಅನೌನ್ಸ್ ಮಾಡ್ರಿ
ಅನೌನ್ಸ್ ಮಾಡೋದಕ್ಕೆ
ಅನೌನ್ಸ್ ಮಾಡು ಆನ್ ಇಲ್ಲ ಇದು
Excuse me, everyone. Kindly please remain in your seats. The tea and snacks will be served in the auditorium. So we would like to request you all to be please seated. Thank you so much. Thank you. All right, on ಮಾಡಬೇಕಾಗಿತ್ತು ಮಾಡ್ಲಾ ಕ್ಲಿಕ್ ಮಾಡು
ಟೀ ವಿಲ್ ಬಿ ಥರ್ಡ್ ಇಯರ್ ಓನ್ಲಿ ಏನಪ್ಪ ಹಿಂಗೆ ಅವ್ರೊಬ್ರು ಇಲ್ಲ ಎಕ್ಸ್ಟ್ರಾ ನಾನಿದ್ದೀನಾ ನನ್ನ ಜೊತೆಗೆ ನಾಗೇಂದ್ರ ಗೌಡ ಯೋಗೇಂದ್ರ ಹಿಂದೆ ಚೇರ್ ಹಾಕ್ತೀವಿ ಕುತ್ಕೊಂತಾರೆ ಅವೇನು ಮತ್ತೆ ಇನ್ನೇನು ಅಡಿಷನ್ ಮಾಡಲ್ಲ ಓಕೆನಾ ತಗೊಳ್ಳ ಯಾರು ಬೇಕಾ
cover you want, sir?
ಏನು ಈಗ ಮೈಕಾ ಏನು ಈಗ ಬರ್ತಿಲ್ಲ ಈಗ ಬೇಕಾ
ವರ್ಕ್ ಆಗ್ತಾ ಇದೆ ಇನ್ನೊಂದು ವೈರ್ಲೆಸ್ ಇಲ್ಲ ನಮ್ಮ ಹತ್ರ ಎರಡು ಇತ್ತು ಇನ್ನೊಂದು ಆ ಕಡೆ ಇರ್ಬೋದು ಒಂದ್ಸಲಕ್ಕೆ ನೋಡಿ
ಇನ್ವಿಟೇಷನ್ ಎಷ್ಟು ಜನ ಇದ್ದಾರೆ ಕೌಂಟ್ ಮಾಡಿ ಎಷ್ಟು ಜನ ಇದ್ದಾರೆ ಹನ್ನೆರಡರಲ್ಲಿ ಒಬ್ರು ಇಲ್ಲ ಅಂತ ಅಂದ್ರು ಸರ್ ಹಾಂ ಅವರೊಬ್ರು ಇಲ್ಲ ಅದಕ್ಕೆ ಎಷ್ಟು ಚೇರ್ ಬೇಕು 12 ಚೇರ್ ಬೇಕೀಗ ಕರೆಕ್ಟಾ ಅವ್ರನ್ನ ಕ್ಯಾನ್ಸಲ್ ಮಾಡಿ 12 ಅದೆಷ್ಟು ಚೇರ್ ಇದಾವೆ ನೋಡಿ ಮತ್ತೆ ಕೌಂಟ್ ಮಾಡಿ
Good afternoon, respected dignitaries, esteemed doctors, faculty members, and students. Every heartbeat has a story, and behind many of those stories stands a doctor. With this thought, it gives me immense pleasure to welcome you all to the Doctor's Day celebration organized under the Indian Medical Association.
Founded in 1928, the Indian Medical Association has grown into India's largest voluntary organization of doctors, representing over 3.5 million medical professionals through more than 1,700 local branches. For nearly a century, it has stood as a pillar of ethical medical practice, medical education, and dedicated service to society.
SJMIT University is recognized for its commitment to academic excellence through its high-quality education, innovation, and skill development. This university integrates multidisciplinary learning and extensive clinical exposure, helping students to develop both professional competence and ethical values. We are privileged to be a part of this university.
Vasavi Diagnostic and Laboratory Pvt. Limited, a Neuberg Associate, is a clinical diagnostic laboratory providing a comprehensive range of pathology and laboratory testing services. As a part of the Neuberg network, it follows standardized laboratory practices and quality protocols to support accurate and reliable diagnostic testing for patients, clinicians, and healthcare institutions.
In India, National Doctors' Day is observed every year on July 1st to commemorate the birth and death anniversary of Dr. B.C. Roy, an eminent physician educator. The day acknowledges rememberable contributions to medicine and public health while expressing gratitude to all medical professionals for their selfless service to society.
Today, we gather to celebrate not just a profession, but a noble commitment to healing, compassion, and selfless service. Let us now begin the auspicious celebration by invoking the blessing of the Almighty through the IMA prayer. I would like to invite Dr. Nagraj Naik sir, retired DHO, Senior Dermatologist, Chitradurga, to recite the IMA prayer. I request everyone to kindly rise.
Before that, I would like to invite dignitaries to come on the stage. Dr. Palakshaya sir, IMA President. Dr. Sujay P. Prasad sir, please come onto the stage. Dr. Jayaraman sir. Dr. K.B. Gudsi sir, Vice Chancellor, SJM University. Sir, please come onto the stage. Dr. Rajesh M.S. sir, please come onto the stage. Dr. Yuvraj sir, in his absence, when he comes, please come onto the stage. I request somebody to follow him. Dr. N.B. Prahlad sir, Secretary IMA, please sir. Dr. K.M. Basuraj sir, please come onto the stage. Dr. Nagendra Gowda sir, Deputy MS, please come onto the stage. Dr. Nagaraj Naik sir, please start IMA prayers sir. Nagaraj Naik sir.
ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪ್ರಾರ್ಥನೆ. ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುರಿಪಡಿಸುವವರು ನಾವಾಗಿರಲಿ. ಧ್ವಜವಂದನೆ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ರಾಷ್ಟ್ರಧ್ವಜಕ್ಕೆ ವಂದನೆ ಸಲ್ಲಿಸಲು ನಿಂತಿದ್ದೇವೆ. ಅದರ ಗೌರವ ಮತ್ತು ವೈಭವವೇ ನಮ್ಮ ಬೆಳಕು ಮತ್ತು ಶಕ್ತಿ, ಮತ್ತು ಅದರ ಪಥವೇ ನಮ್ಮ ಪಥವು. ಈ ರಾಷ್ಟ್ರೀಯ ಸಂಸ್ಥೆಯ ಮಾನ್ಯತೆ ಪಡೆದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ಜವಾಬ್ದಾರಿಗಳನ್ನು ಅರಿಯುವ ಮೂಲಕ ಅದಕ್ಕೆ ನಮ್ಮ ನಿಷ್ಠೆಯನ್ನು ತೋರಿಸುವ ಪ್ರತಿಜ್ಞೆ ಮಾಡುತ್ತಿದ್ದೇವೆ. ದೇಶ ಸಮೂಹಗಳ ನಡುವೆ ನಮ್ಮ ರಾಷ್ಟ್ರಧ್ವಜವು ಉನ್ನತ ಮಟ್ಟದಲ್ಲಿ ಹಾರಾಡುವ ಸಲುವಾಗಿ ನಮ್ಮ ಅಧಿಕಾರದಲ್ಲಿ ಎಲ್ಲವನ್ನೂ ಅದಕ್ಕೆ ಸಮರ್ಪಿಸುವ ಪ್ರಮಾಣ ಮಾಡುತ್ತಿದ್ದೇವೆ. IMA ಚಿರಾಯುವಾಗಲಿ. ಜೈ ಹಿಂದ್.
Thank you, sir, for the prayer.
Dr. Yogesh sir, any point, please come.
Before we celebrate the achievements of medicine, now I invite Chandana, our second year student, to present a prayer.
ಗಜಮುಖನೇ ಗಣಪತಿಯೇ ನಿನಗೆ ವಂದನೆ, ನಂಬಿದವರ ಬಾಳಿನ ಕಲ್ಪತರು ನೀನೇ. ಗಜಮುಖನೇ ಗಣಪತಿಯೇ ನಿನಗೆ ವಂದನೆ, ನಂಬಿದವರ ಬಾಳಿನ ಕಲ್ಪತರು ನೀನೇ. ಭಾದ್ರಪದ ಶುಕ್ಲದ ಚೌತಿಯಂದು ನೀ ಮನೆ ಮನೆಗೋದಯ ಮಾಡಿ ಬರಸು ಎಂದು. ಭಾದ್ರಪದ ಶುಕ್ಲದ ಚೌತಿಯಂದು ನೀ ಮನೆ ಮನೆಗೋದಯ ಮಾಡಿ ಬರಸು ಎಂದು. ನಿನ್ನ ಸನ್ನಿಧಾನಕ್ಕೆ ತಲೆಬಾಗಿ ಕೈಯ ಮುಗಿದು ಬೇಡುವ ಭಕ್ತರಿಗೆ ನೀ ದಯಾ ಸಿಂಧು. ಗಜಮುಖನೇ ಗಣಪತಿಯೇ ನಿನಗೆ ವಂದನೆ, ನಂಬಿದವರ ಬಾಳಿನ ಕಲ್ಪತರು ನೀನೇ. ಈ ಏಳು ಲೋಕದ ನೋಲುವಿನ ಇಹ ಪರದ ಸಾಗರಕ್ಕೆ ನೀನೆ ಕಾರಣ. ನಿನ್ನೊಲುಮೆ ನೋಟದ ಒಂದು ಹೊನ್ನ ಕಿರಣ, ನೀಡಿದರೆ ಸಾಕಯ್ಯ ಜನ್ಮ ಪಾವನ. ಗಜಮುಖನೇ ಗಣಪತಿಯೇ ನಿನಗೆ ವಂದನೆ, ನಂಬಿದವರ ಬಾಳಿನ ಕಲ್ಪತರು ನೀನೇ. ಪಾರ್ವತಿ ಪರಶಿವನ ಪ್ರೇಮ ಪುತ್ರನೇ, ಪಾಲಿಸುವ ಪರದೈವ ಬೇರೆ ಕಾಯಣೆ. ಪಾಪದ ಪಂಕದಲ್ಲಿ ಪದುಮಯನಿಸು ಎನ್ನ, ಪಾದ ಸೇವೆ ಒಂದೇ ಧರ್ಮ ಸಾಧನ. ಗಜಮುಖನೇ ಗಣಪತಿಯೇ ನಿನಗೆ ವಂದನೆ, ನಂಬಿದವರ ಬಾಳಿನ ಕಲ್ಪತರು ನೀನೇ.
Thank you, Chandana. Every memorable gathering begins with a heartfelt welcome. It is now our privilege to invite respected Dr. Prahalad sir, an inspiring leader and an accomplished ENT surgeon. In recognition of his innovation, he was awarded the prestigious Dr. R.A.F. Cooper National Award in the year 2000 for his original surgical technique, the Karnataka flat-cord matched obliteration, becoming the first and to the date the only person from Karnataka to receive this honor. With great respect, I invite Dr. Prahalad sir to deliver the welcome address.
Thank you very much. I'm supposed to give invitation address, but I'm being praised at this moment. Thank you. Very much of you. Respected dignitaries of the dais and on the dais. I said off the dais first. It's because of you we're able to hold this program. So I think we always neglect the audience, but they form our first priority, rather the purpose of our program. That's why I said off the dais first. Okay. It really gives me immense pleasure to invite on behalf of two great organizations here. IMA Chitradurga, of course, which I am secretary of Chitradurga branch, It's one of the biggest organization in the country, IMA. The second is our organization, that is Basaveshwara Medical College Hospital, which belongs to SJMIT University. Let me tell you, for the visitors who are fresh here, this is one of the oldest organizations standing in the country, older than 500 years, which is a long lineage of Swamijis who have developed this mud and this organization with one unique purpose, that is giving away. Dasoha. Dasoha means it's of many various forms. So this one of the Dasoha giving away is the Gnana Dasoha, that's the knowledge. It's on the basis of this knowledge. The various institutions, more than 150 institutions, have been established under this organization. And now this organization is a new university, SJMIT University. And we are also very happy and blessed to have the vice chancellor of the university also among us. To begin with, I would like to invite our Swamiji who has come here to bless us and inaugurate this program. That is the Basaveshwara Swamiji of Murugamata. Swamiji, namaste. Nimage suswagata. This program is being presented by one of my close friend, my classmate, MBBS classmate, and also happens to be my president at IMA Chitradurga and also Professor Vasavi, and now he is medical superintendent also. Dr. Palache, I wholeheartedly welcome. Yeah. And we have two dignitaries here as chief guests. To start with, Dr. Sujay R. Prasad, who's Group of Chief of Medical Director of Neuberg Associate Pvt. And also we have Dr. Jairam sir, who conducted, was a part of the wonderful panel discussion we witnessed today. He happens to be director of the NALAM, part of the Anand group. Then we have our other guests of honors, our Sri KB Gursi sir, Vice Chancellor of SJMIT University. Despite his busy schedule, this is a baby university, it's still in infant stages, and you can imagine about the work it has to do to establish itself as one of the recognized and established university. And he is holding the helm of the university, helping us take this to a greater height. So I welcome you, sir, to be here, despite your busy schedule. And Registrar, he couldn't be here amongst us, Sri MS Gunachari, Visakha University. And in his absence, I still welcome him. Then we have our beloved dean, Dr. MS Rajesh, again another classmate of mine, and the Professor of Emergency Medicine as well as orthopedics and dean of Basaveshwara Medical College Hospital. And also with special thanks to him, he has provided this wonderful auditorium. That we wholeheartedly invite you, sir. Dr. Yuvraj, the director of Chitradurga Medical College, Government Medical College, was supposed to be here. He couldn't be here because of this busy schedule. I still be inviting in his absence. Then we also have our Deputy MS, Dr. Nagaraj Gowda, and my colleague at IMA Chitradurga and Senior Orthopedic Professor, Dr. Basaraj, who also happens to be the President of IMA. And the whole spirit behind this program, Dr. Narayan Murthy. Please go. Also, we have Dr. Yogendra, who happens to be, coordinating the medical education unit of our, and also he is professor and head of the dermatology department. I welcome you, sir. And we have many senior professors here. I'm not going to name each and every of them. Welcome all of you. And backbone of this medical college, all postgraduate students, undergraduate students, and interns, I welcome you all. And also, not but the least, any program gets unnoticed unless our press people publish it. Sometimes, and also the National Medical Council dictates we are not supposed to be advertising, not supposed to be projecting. Despite that, I emphasize that in some subtle way, the message should go to the public, directly or indirectly, whatever we do, good work we are doing. The press people here to take that message across the public. I invite them again. Thank you all for giving me this wonderful opportunity.
Thank you, Prahlad sir, for your gracious words of welcome. As a symbol of life, hope, and continuous growth, let's begin today's celebration with the ceremonial watering of a plant and floral tribute to Dr. B.C. Roy, sir.
I request everyone to stand. Thank you, everyone. I request our Honorable Dean Dr. Rajesh sir to address the gathering.
Good morning, everybody. The blessings of His Holiness, Shri Vasavi Swamiji, Pradhana, respected Chief Guest, Dr. Sujaya Prasad, Chief Medical Director, Neuberg Associate, Dr. Jagannathan, Director, NALLM, Guest of Honor, Dr. Budasi, Vice Chancellor, Dr. Pramala, Nagendra Goda, Dr. Basaraj, Dr. Narayan Murthy, Dr. Parak Shaya, Dr. Yogendra, Secretary, staff, dignitaries of the class, students, very happy Doctor's Day to one. Today, as we celebrate Doctor's Day, we also celebrate all the including doctors, which profession built on science, service, sacrifice, and humanity. This day carries special meaning in India as it honors Dr. Bidan Chandra Roy, a visionary physician whose life embodied excellence, compassion, and leadership. His legacy is a reminder that medicine is not just a career, it is a calling. Today we gather to celebrate Doctor's Day that was weekend for every person who has chosen the noble path of healing. And for all of you, that is especially the newly minted graduates, this day carries an even greater significance. Not just a celebration of professional entering, but a reminder of the legacy you are now part of. Doctors' Day in India is celebrated on the 1st of July in honor of Dr. Bidan Chandra Roy, a name that stands tall in the history of Indian medicine. He was not only a legendary physician but also a visionary leader, a teacher, and a humanitarian. His birth and death anniversary
falls on the same day, symbolizing the life that has come full circle in services to humanity. Who is Vidan? Dr. Vidan Chitradurga. He was an Indian physician, surgeon, educationist, and statesman who became the second Chief Minister of West Bengal, serving from 1950 until his death. He is remembered as one of the few individuals who excelled equally in medicine as well as in politics. He was born in Bankepur, Patna, to a Bengali Kayastha family, studied medicine at Calcutta Medical College. He then applied to St. Bartholomew's Hospital, London. He was initially rejected because he was a colored person. In 3 months, an extraordinary event. This early determination foreshadowed his future role as a pioneer in Indian medicine. The saying that goes when during his IMA, there were some number of patients. And at the end, he told, in addition to the number of patients, there was one more person with TB. The person who was examining was surprised. Who is the third person? He asked. Then the told, you are the one who is having, you are also one of the persons who is having TB. Not of that depth of his knowledge. So he could, one clinical base. Returning to India in 1911, Roy became one of the most respected physicians of his era. Key contributions include serving as a professor at Calcutta Medical College, shaping generation of doctors, establishing several major medical institutions, including Chitranjan Cancer Hospital, Chitranjan Seva Sadan for women and children, multiple hospitals and public health facilities across Bengal. And he was founder of Indian Medical Association, influencing the and also influenced national health policies. His approach combined clinical excellence with deep compassion, making him a role model for medical ethics and service. He believed that health and national development were inseparable, which led him into public service. His major achievements are he became mayor of Calcutta in 1933, improved sanitation and public health systems, served as Chief Minister of West Bengal from 1950 to 62, one of the longest tenures in the state's history. He was instrumental in creating planned cities in Calcutta, where Salt Lake City, Durgapur, Kalyani, and Ashok Nagar. He spearheaded industrialization, including Durgapur Steel Plant and Kalyani Engineering Hub. He was awarded Bharat Ratna in 1961, that is India's highest civilian honor. National Doctors Day in India, July 1st, is celebrated in his memory, symbolizing his dedication towards medical service. Why Dr. B.C. Rai matters today? He treated patients with unmatched skill, but more importantly, with unmatched compassion. He touched lives with empathy, humility, and integrity. Ultimately, what we are going to achieve is only with humility. With AI coming in, AI is not going to show humility. Humility can only be shown by human beings. As you stand at the threshold of your medical career, remember that you are stepping into a profession shaped by giants like him. You will make decisions that carry immense weight in those moments. Let the spirit of Dr. B.C. Rai guide. At a remarkable moment in a journey after years of sleepless nights, intense study, clinical coaching, and emotional challenges, you're stepping into a world that needs you more than ever. The healthcare landscape is evolving rapidly. New diseases, new technologies, new explanations. But one thing remains unchanged: the society, the trust the society places in its doctors. As graduates, we are all acquiring knowledge to save lives. Your words will comfort families and decisions that have shaped futures. The theme we reflect on today, behind the mask, who is the healers, that who is going to heal us, the doctors. It is only. We are also human. It is powerful and we are also human. We also get pleasure when we all carry the perform. Few others understand. Remember, seeking help is strength, not weakness. Supporting one another is essential. And nurturing our own well-being is part of serving our patients. As a step forward, we should carry these principles with us. Let curiosity guide us. Medicine never stops evolving and others will grow. Towards that goal, the same we learn as today. My association BMCH Chitradurga. Let humility ground you. Every patient teaches you something new. Every patient, we have to learn something new. Even if it's a very common problem, we should learn something new. Let compassion define us. People may forget your prescriptions, but they'll never forget your kindness. A few words will make a difference between being blessed by patients or being close to patients. Let integrity lead us in moments of critical challenge. Choose what is right, not what is easy. We have to do what is right, not just to please our patients. We have to please ourselves. At the end of the day, we should have good night's sleep. That is most important. You are all the future researchers, surgeons, physicians, innovators, and leaders who will shape the next era of healthcare. We will all bring hope where there is fear, clarity where there is confusion, and healing where there is pain. On this Doctor Day, we honor the profession, but today we also honor all doctors. May all of us carry a white coat with pride, purpose, and humility. May all of us serve with courage and compassion, and may we always remember why we chose this noble profession. Congratulations to all the doctors. The world is ready for you. A happy Doctors' Day to follow. Thank you.
Thank you, Dr. Rajesh sir, for your kind words.
ದಯವಿಟ್ಟು ನಮ್ಮ ಡಾಕ್ಟರ್ ರವೀಂದ್ರ ಸರ್, ಜಿಲ್ಲಾ ಶಸ್ತ್ರಚಿಕಿತ್ಸಕರು, ದಯವಿಟ್ಟು ವೇದಿಕೆ ಮೇಲೆ ಬರಬೇಕಂತ ಹಾಗೂ ಅವ್ರಿಗೆ ನನ್ನ ನಿಮ್ಮೆಲ್ಲರ ಪರವಾಗಿ ಪೂರ್ವಕವಾದ ಸ್ವಾಗತವನ್ನ ಬಯಸ್ತೇನೆ. ಈಗ ಬಿಕಾಸ್ ಆಫ್ ಸಮ್ ಅನ್ಅವಾಯ್ಡಬಲ್ ಸರ್ಕಮ್ಸ್ಟೆನ್ಸಸ್ ಡಾಕ್ಟರ್ ದೇವರಾಜ್ ಅವರು ಭದ್ರಾವತಿಗೆ ಹೋಗ್ಬೇಕಾಗಿರುತ್ತೆ. ಕಾರ್ಯಕ್ರಮ ಶುರುವಾಗೋದಕ್ಕಿಂತ ಮುಂಚೆ ಅವರ ದಂಪತಿ ಸಮೇತ ದಯವಿಟ್ಟು ವೇದಿಕೆ ಮೇಲೆ ಬರಬೇಕು. ಅವ್ರಿಗೆ ಹಾನರ್ ಮಾಡಿ ನಾವು ಅವ್ರನ್ನ ಬೀಳ್ಕೊಡ್ತೇವೆ. ದಯವಿಟ್ಟು ಡಾಕ್ಟರ್ ದೇವರಾಜ್ ಸರ್ ಅವರು ಹನುಮಂತಪ್ಪ ಮತ್ತೆ ಹಂಸಯ್ಯಮ್ಮ ದಂಪತಿಗಳ ಮುದ್ದಿನ ಪುತ್ರನಾಗಿ ಮೊಳಕಾಲ್ಮೂರಿನಲ್ಲಿ 1966ರಲ್ಲಿ ಜನಿಸಿರ್ತಾರೆ. ಇವರ ಪ್ರೈಮರಿ ಎಜುಕೇಶನ್ ಅನ್ನ ನಮ್ಮ ದುರ್ಗದ ಪಕ್ಕದಲ್ಲಿ ಇರ್ತಕ್ಕಂಥ ದಂಡಿನ ಕುರುಬರಹಟ್ಟಿಯಲ್ಲಿ ಮುಗಿಸ್ಕೊಂಡು, ಆಮೇಲೆ ಜಿಲ್ಲಾದ್ರಿ ಹೈಸ್ಕೂಲ್ ಮುಗಿಸ್ಕೊಂಡು ಗವರ್ಮೆಂಟ್ ಸೈನ್ಸ್ ಕಾಲೇಜ್ ಚಿತ್ರದುರ್ಗದಲ್ಲಿ PUC ಕಾಲೇಜ್ಗೆ 4ನೇ ಟಾಪರ್ ಆಗಿ ಹೊರಹೊಮ್ಮಿರ್ತಾರೆ. ಇವರು ಬಳ್ಳಾರಿ ಮೆಡಿಕಲ್ ಕಾಲೇಜಿನಲ್ಲಿ MBBS ಅನ್ನ ಮುಗಿಸಿ ಸರ್ವಿಸ್ಗೆ 1991-92ರಲ್ಲಿ ಜಾಯಿನ್ ಆದವರು 34 ವರ್ಷಗಳ ಸುದೀರ್ಘ ಸೇವೆಯನ್ನ ನಮ್ಮ ಸರ್ಕಾರಿ ವೈದ್ಯಕೀಯ ವೃತ್ತಿನಲ್ಲಿ ಮುಂದುವರಿಸಿರ್ತಾರೆ. ಇವರು 2002ರಲ್ಲಿ DCH ಪದವಿಯನ್ನ RGUHSಗೆ ಟಾಪರ್ ಆಗಿ ಪಡ್ಕೊಂಡಿರ್ತಾರೆ. ಅಲ್ಲಿಂದ 2 ವರ್ಷ ರಾಯಚೂರಿನಲ್ಲಿ ಒಂದು ತಾಲೂಕಿನಲ್ಲಿ ವರ್ಕ್ ಮಾಡಿ 1992ರಿಂದ 95ರವರೆಗೂ ಮೊಳಕಾಲ್ಮೂರಿನಲ್ಲಿ ವರ್ಕ್ ಮಾಡಿರ್ತಾರೆ. ಹಾಗೂ 2002ರಿಂದ 2005ರಿಂದ 2015ರವರೆಗೂ ನಮ್ಮ ಚಿತ್ರದುರ್ಗ ಜಿಲ್ಲಾ ಆಸ್ಪತ್ರೆಯಲ್ಲಿ ಪೀಡಿಯಾಟ್ರಿಷಿಯನ್ ಆಗಿ ಕರ್ತವ್ಯ ನಿರ್ವಹಿಸಿರ್ತಾರೆ. ಹಾಗೂ 2015ರಿಂದ 2017ರವರೆಗೂ ಚಳ್ಳಕೆರೆ ತಾಲೂಕು ಆಸ್ಪತ್ರೆಗೆ ವರ್ಗಾವಣೆಗೊಂಡು ಅಲ್ಲೂ ಸಹ ಸರ್ವಿಸ್ ಅನ್ನು ಕೊಟ್ಟು 2017ರಿಂದ 2026ರವರೆಗೆ ರಿಟೈರ್ಡ್ ಆಗೋವರೆಗೂ ಚಿತ್ರದುರ್ಗ ಜಿಲ್ಲಾ ಆಸ್ಪತ್ರೆಯಲ್ಲಿ ಮಕ್ಕಳ ವೈದ್ಯರಾಗಿ ಸೇವೆ ಸಲ್ಲಿಸಿರ್ತಾರೆ. ಇವರ ಸೇವೆಯನ್ನ ಮೆಚ್ಚಿ ಸರ್ಕಾರಿ ವೈದ್ಯಾಧಿಕಾರಿಗಳ ಸಂಘದಿಂದ ಬೆಸ್ಟ್ ಮೆಡಿಕಲ್ ಆಫೀಸರ್ ಮತ್ತೆ ಬೆಸ್ಟ್ ಪೀಡಿಯಾಟ್ರಿಷಿಯನ್ ಅಂತ 2010 ಮತ್ತೆ 2011ರಲ್ಲಿ ಇವರನ್ನ ನಾವು ಹಾನರ್ ಮಾಡಿರ್ತೇವೆ. ಹಾಗೂ ದೇವರಾಜ್ ಸರ್ ಬಗ್ಗೆ 2 ವರ್ಡ್ನಲ್ಲಿ ಹೇಳಬೇಕಂದ್ರೆ, ನಿಮ್ಮ ಹಿಂದಿನ ಡೀನ್ ಆಗಿದ್ದಂತಹ ಸುರೇಶ್ ಬಾಬು ಅವರು ನನ್ನ ನೆಚ್ಚಿನ ಮಿತ್ರರಿದ್ರು. ನಾನು ಬೆಂಗಳೂರಿನಲ್ಲಿ ಕರ್ತವ್ಯ ನಿರ್ವಹಿಸ್ತಿದ್ದೆ. ಒಂದ್ಸಾರಿ ನಾನು ಚಿತ್ರದುರ್ಗಕ್ಕೆ ಬಂದಾಗ ಹೇಳಿದೆ, ಸುರೇಶ್ ಬಾಬು ನಿನ್ನ ಹೆಸರು ತುಂಬಾ ಚೆನ್ನಾಗಿ ಶೈನ್ ಆಗ್ತಾ ಇದೆ ಚಿತ್ರದುರ್ಗದಲ್ಲಿ, ಮತ್ತೆ ಮೆಡಿಕಲ್ ಕಾಲೇಜನ್ನ ತುಂಬಾ ಚೆನ್ನಾಗಿ ನಡೆಸ್ತಾ ಇದೆಯಾ ಅಂತ ಒಂದೇ ವರ್ಡ್ ಹೇಳಿದ್ರು ಅವರು. ಗೌರವ ನನ್ನಂತವ್ರಿಗೆಲ್ಲಪ್ಪ, ದೇವರಾಜ್ ಸರ್ ಅಂತವ್ರಿಗೆ ಸಿಗ್ಬೇಕು. ಅವರು ಚಿತ್ರದುರ್ಗ ಜಿಲ್ಲಾ ಆಸ್ಪತ್ರೆಯಲ್ಲಿ ಒಬ್ಬ ಸೋಲ್ ಪೀಡಿಯಾಟ್ರಿಷಿಯನ್ ಆಗಿ ಎಷ್ಟು ಸೇವೆ ಸಲ್ಲಿಸ್ತಾ ಇರ್ತಾರೆ ಅಂತ ಅವ್ರನ್ನ ನೋಡಿದ್ರೆ ಗೊತ್ತಾಗುತ್ತೆ. 24 hours ವಿಥೌಟ್ ರೆಸ್ಟ್ ಈ ಯೂಸ್ ಟು ಗಿವ್ ಅ ಸರ್ವಿಸ್ ಟು ದಿ ಇದು ಅಂತ. ಹಾಗಾಗಿ ಇಷ್ಟೊಂದು 34 ವರ್ಷಗಳ ಸುದೀರ್ಘ ಸೇವೆಯನ್ನು ಸಲ್ಲಿಸಿ ರಿಟೈರ್ಡ್ ಆಗಿರ್ತಾರೆ. ಅವ್ರಿಗೂ ಅವರ 2 ಮಕ್ಕಳ ಬಗ್ಗೆ ನಾನು ಹೇಳಬೇಕು. 2 ಮಕ್ಕಳು ಸಹ ಗಂಡು ಮಕ್ಕಳು ವೈದ್ಯಕೀಯ ವೃತ್ತಿ ವ್ಯಾಸಂಗವನ್ನ ಮಾಡ್ತಾ ಇರ್ತಾರೆ. ಇವರಿಗೆ ನನ್ನ ನಿಮ್ಮೆಲ್ಲರ ಪರವಾಗಿ ದೇವರು ಆಯುರಾರೋಗ್ಯ ಐಶ್ವರ್ಯ ಮತ್ತೆ ಇದೇ ಸಕ್ಸಸ್ ಅನ್ನ ಮುಂದೆ ಕೊಡ್ಲಿ ಅಂತ ನಾನು ದೇವರಲ್ಲಿ ಬೇಡ್ಕೊಳ್ತೇನೆ. ಜೈ ಹಿಂದ್, ಜೈ ಕರ್ನಾಟಕ.
ಎಲ್ರಿಗೂ ನಮಸ್ಕಾರ. ವೇದಿಕೆ ಮೇಲೆ ಉಪಸ್ಥಿತರಿರತಕ್ಕಂಥ ನಮ್ಮ ಹೆಸರಾಂತ ಮುರುಘಾ ಮಠದ ಪುರಾತನ ಮುರುಘಾ ಮಠದ ಸ್ವಾಮೀಜಿಗಳಾಗಿರ್ತಕ್ಕಂಥ ಸ್ವಾಮೀಜಿಯವರೇ ಹಾಗೂ ಇತರ ಎಲ್ಲ ಗಣ್ಯ ವ್ಯಕ್ತಿಗಳಿಗೆ ನಮಸ್ಕರಿಸುತ್ತಾ, ಇವತ್ತು ನನಗೆ ಈ ಸಂದರ್ಭದಲ್ಲಿ ನಮ್ಮ ಚಿತ್ರದುರ್ಗ IMA ವತಿಯಿಂದ ಹಾಗೂ ಬಸವೇಶ್ವರ ವೈದ್ಯಕೀಯ ಕಾಲೇಜ್ ವತಿಯಿಂದ ಒಂದು ಸನ್ಮಾನವನ್ನು ಮಾಡಿರ್ತಕ್ಕಂಥದ್ದು ನಿಜವಾಗ್ಲೂ ಕೂಡ ನನಗೆ ತುಂಬ ಹೃದಯ ತುಂಬಿ ಬಂದಿದೆ. ಏಕೆಂದರೆ ವೈದ್ಯರು ಅಂತಂದರೆ ಮುಖ್ಯವಾಗಿ ಬೇಕಾಗಿರ್ತಕ್ಕಂಥದ್ದು ನಮ್ಮ ರಾಜೇಶ್ ಸರ್ ಹೇಳಿದ್ರು ಅವಾಗಲೇ ಮಾನವೀಯತೆ ಮತ್ತು ನಮ್ಮಲ್ಲಿ ಬಹಳ ದಯಾಪರತೆ ಇರಬೇಕು. ಸೊ ಬರೀ ನಾವು ಹಣದ ಹಿಂದೆ ಹೋದರೆ ಮಾತ್ರ ಏನು ಸಾಧನೆ ಮಾಡಲಿಕ್ಕಾಗೋದಿಲ್ಲ. ಯಾಕೆಂದರೆ ರೋಗಿಗಳು ನಮ್ಮ ಹತ್ರ ಬರೋರೆಲ್ಲ ನೋವಿನಿಂದನೇ ಬರ್ತಾರೆ. ಅವರ ನೋವಿಗೆ ಸ್ಪಂದಿಸಿ ನಾವು ಅವರನ್ನು ಚಿಕಿತ್ಸೆಗೊಳಪಟ್ಟಾಗ ನಿಜಕ್ಕೂ ನಾವು ಚಿಕಿತ್ಸೆ ಕೊಡೋದಕ್ಕಿಂತ ನಮ್ಮ ಒಂದು ಹೃದಯವಂತಿಕೆಯಿಂದ ಅವರನ್ನು ಗೆದ್ದು ಅವರ ಕಾಯಿಲೆಗಳನ್ನು ನಾವು ವಾಸಿ ಮಾಡ್ಬೋದು ಅನ್ನಿಸ್ತದೆ. ಆ ವಿಚಾರವಾಗಿ ಇವತ್ತಿನ ದಿವಸದಲ್ಲಿ ನನಗೆ BC ರಾಯ್ ಅವರ ಒಂದು ಜನ್ಮದಿನದ ಒಂದು ಡಾಕ್ಟರ್ಸ್ ಡೇ ಏನು ಮಾಡಬೇಕಿತ್ತು, ಆ ಸಂದರ್ಭದಲ್ಲಿ ನನಗೆ ಸನ್ಮಾನಿಸಿದ್ದಕ್ಕೆ ತಮ್ಮೆಲ್ಲರಿಗೂ ಕೂಡ ನಾನು ಹೃದಯಪೂರ್ವಕ ಧನ್ಯವಾದಗಳನ್ನು ತಿಳಿಸುತ್ತಾ, ನನಗೆ ಈ ವೇದಿಕೆಯಲ್ಲಿ ಸನ್ಮಾನ ಸ್ವೀಕರಿಸಿದ್ದಕ್ಕೆ ನಿಮ್ಗೆಲ್ರಿಗೂ ಕೂಡ ಅಭಿನಂದನೆಗಳನ್ನು ಸಲ್ಲಿಸುತ್ತಾ ನಾನು ಮಾತು ಮುಗಿಸ್ತೇನೆ. ಜೈ ಹಿಂದ್, ಜೈ ಕರ್ನಾಟಕ. ಥ್ಯಾಂಕ್ ಯು.
ಈಗ ಆಶೀರ್ವಚನ ನೀಡಲು ಆಗಮಿಸಿರುವ ಪೂಜ್ಯ ಶ್ರೀ ಬಸವಪ್ರಭು ಸ್ವಾಮೀಜಿಯವರು ಶ್ರೀ ಮುರುಘಾಮಠ ಅವರನ್ನು ಆತ್ಮೀಯವಾಗಿ ಸ್ವಾಗತಿಸುತ್ತೇನೆ. ತಮ್ಮ ಅಮೃತ ವಚನಗಳ ಮೂಲಕ ನಮ್ಮೆಲ್ಲರನ್ನು ಆಶೀರ್ವದಿಸಬೇಕೆಂದು ಕೋರುತ್ತೇನೆ.
ಶ್ರೀ ಗುರು ಬಸವಲಿಂಗಾಯ ನಮಃ. ಶ್ರೀ ಗುರು ಬಸವಲಿಂಗಾಯ ನಮಃ. ಸ್ಮರಣೀಯರಾಗಿರುವಂತಹ ಧರ್ಮಗುರು ವಿಶ್ವಗುರು ಬಸವಣ್ಣನವರನ್ನ ಸ್ಮರಣೆ ಮಾಡಿಕೊಳ್ತಾ, ಮಹಾಜಂಗಮ ಜ್ಯೋತಿಗಳಾದ ಕರ್ತು ಮುರುಗೇಶನ ಪಾದಕ್ಕೆ ನಮಸ್ಕರಿಸುತ್ತಾ, ಅರಿವಿನ ಗುರುಗಳಾದ ಮುರುಘಾಶರಣರ ಪಾದಕ್ಕೆ ನಮಸ್ಕರಿಸುತ್ತಾ, ಇವತ್ತು ವೈದ್ಯರ ದಿನಾಚರಣೆ ಕಾರ್ಯಕ್ರಮ ನಮ್ಮ ಬಸವೇಶ್ವರ ಮೆಡಿಕಲ್ ಕಾಲೇಜಿನಲ್ಲಿ ಜರುಗ್ತಾ ಇದೆ. IMA ಚಿತ್ರದುರ್ಗ ಇವರು, ಬಸವೇಶ್ವರ ಮೆಡಿಕಲ್ ಕಾಲೇಜಿನವರು, ವೈಷ್ಣವಿ ಲ್ಯಾಬ್ನವರು, ಇವರೆಲ್ಲರ ಸಹಯೋಗದಲ್ಲಿ ಇವತ್ತು ಜರುಗ್ತಾ ಇದೆ. ಅಧ್ಯಕ್ಷತೆಯನ್ನು ವಹಿಸಿರುವಂಥ ಡಾಕ್ಟರ್ ಪಾಲಾಕ್ಷಯ್ಯನವರಲ್ಲಿಯೂ ಹಾಗೂ ಮುಖ್ಯ ಅತಿಥಿಗಳಾಗಿ ಆಗಮಿಸಿರುವಂಥ ಡಾಕ್ಟರ್ ಸುಜಯ್ ಅವರಲ್ಲಿಯೂ ಹಾಗೂ ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಪಾಲ್ಗೊಂಡಿರುವಂತಹ ನಮ್ಮ SJM ಯೂನಿವರ್ಸಿಟಿಯ ಕುಲಪತಿಗಳಾಗಿರುವಂಥ ಡಾಕ್ಟರ್ KB ಗುಡ್ಸಿ ಸರ್ ಅವರಲ್ಲಿಯೂ ಹಾಗೂ ನಮ್ಮ ಬಸವೇಶ್ವರ ಮೆಡಿಕಲ್ ಕಾಲೇಜಿನ ಡೀನ್ ಆಗಿರುವಂತಹ ಡಾಕ್ಟರ್ ರಾಜೇಶ್ ಅವರು ಹಾಗೂ ಡೈರೆಕ್ಟರ್ ಆಗಿರುವಂತಹ ಡಾಕ್ಟರ್ ಯುವರಾಜ್ ಅವರು ಹಾಗೂ ಡಾಕ್ಟರ್ ಪ್ರಹ್ಲಾದ್ ಅವರು, ಡಾಕ್ಟರ್ ಬಸವರಾಜ್ KM ಅವರು ಹಾಗೂ ವೇದಿಕೆಯಲ್ಲಿರುವಂಥ ಎಲ್ಲ ವೈದ್ಯರಲ್ಲಿಯೂ ಗಣ್ಯರಲ್ಲಿಯೂ ಭಾಗವಹಿಸಿರುವ ತಮ್ಮೆಲ್ಲರಿಗೂ ಶರಣು ಶರಣಾರ್ಥಿಗಳು. ನಮಗೆ ಕಣ್ಣಿಗೆ ಕಾಣುವ ದೇವರು ಅಂತಂದ್ರೆ ನಾವು ವಿಚಾರ ಮಾಡಿದಂತೆ ನಮ್ಮ ತಂದೆ ತಾಯಿ ನಂತರ ವಿದ್ಯೆಯನ್ನು ಕಲಿಸಿಕೊಟ್ಟಿರುವಂತಹ ಗುರು, ಮುಂದೆ ಇನ್ನೊಬ್ಬ ದೇವರು ಯಾರಂದ್ರೆ ನಮ್ಮ ಜೀವವನ್ನು ಉಳಿಸುವಂತಹ ವೈದ್ಯರೇ ನಮ್ಮ ಕಣ್ಣಿಗೆ ಕಾಣುವ ನಿಜವಾದ ದೇವರು, ದೇವರಕ್ಕೆ ಸಮಾನ ಅನ್ನುವಂಥದ್ದನ್ನ ನಾನು ಭಾವಿಸಿದ್ದೇನೆ ಅನ್ನುವಂಥದ್ದು. ವೈದ್ಯರು ಇರದೇ ಇದ್ದಿದ್ರೆ ಯಾರು ಸಹ ಆರೋಗ್ಯವಾಗಿ ಇರಲಿಕ್ಕೆ ಸಾಧ್ಯ ಇಲ್ಲ. ಏನಾದರೂ ಅಪಘಾತ ಅಥವಾ ಆಕ್ಸಿಡೆಂಟ್ ಆತಂದ್ರೆ ತಕ್ಷಣ ನಮಗೆ ಚಿಕಿತ್ಸೆಯನ್ನು ನೀಡಿ ಜೀವ ಉಳಿಸುವಂತಹ ಕಾರ್ಯವನ್ನ ವೈದ್ಯರು ಮಾಡ್ತಾರೆ. ಅಷ್ಟೇ ಅಲ್ಲ, ಅವರು ಎಷ್ಟು ಪ್ರೀತಿಯಿಂದ ನೋಡ್ಕೊಂತಾರೆ, ಎಷ್ಟು ಮಾನವೀಯತೆಯಿಂದ ನೋಡ್ಕೊಂತಾರೆ, ಅದ್ರ ಮುಖಾಂತರ ನಮಗೆ ತಕ್ಷಣ ಸ್ಪಂದನೆ ಮಾಡಿ ಹೃದಯವಂತ ವೈದ್ಯರು ಅಷ್ಟು ಚೆನ್ನಾಗಿ ಅವರು ಟ್ರೀಟ್ಮೆಂಟ್ ಅನ್ನ ನೀಡೋದ್ರ ಮುಖಾಂತರ ನಮ್ಮ ಜೀವ ರಕ್ಷಣೆಯನ್ನ ಮಾಡ್ತಾರೆ ಎನ್ನುವಂಥದ್ದು. ಇವತ್ತು ನಮ್ಮ ಗುರುಗಳಾದ ಮುರುಘಾಶರಣರು ಒಂದು ವಚನವನ್ನ ಹೇಳಿದ್ದಾರೆ. ಮಾನವ ಜನ್ಮ ದೊಡ್ಡದಲ್ಲ, ಮಾನವೀಯತೆ ದೊಡ್ಡದು. ಧರ್ಮ ದೊಡ್ಡದಲ್ಲ, ದಯೆ ದೊಡ್ಡದು. ಕೈಲಾಸ ದೊಡ್ಡದಲ್ಲ, ಕಾಯಕ ದೊಡ್ಡದು. ವಿದ್ಯೆ ದೊಡ್ಡದಲ್ಲ, ಅನುಭವ ದೊಡ್ಡದು. ಬಸವಪ್ರಭು ಮುರುಗೇಶ, ನೀ ದೊಡ್ಡವನಲ್ಲ, ನಿನ್ನನ್ನು ಅರಿಯುವ ಮನಸ್ಸೇ ದೊಡ್ಡದು. ಈ ವಚನಕ್ಕೆ ಯಾರು ಸಾಕ್ಷಿಯಾಗಿದ್ದಾರೆ ಅಂದ್ರೆ ನಮ್ಮ ವೈದ್ಯ ಲೋಕವೇ ಸಾಕ್ಷಿಯಾಗಿದೆ ಅಂತ ಹೇಳಿಕ್ಕೆ ನಾನು ತುಂಬಾ ಖುಷಿ ಪಡ್ತಾ ಇದ್ದೀನಿ ಅನ್ನುವಂಥದ್ದು. ಮಾನವ ಜನ್ಮ ದೊಡ್ಡದಲ್ಲ, ಮಾನವೀಯತೆ ದೊಡ್ಡದು. ಮಾನವೀಯತೆಯೇ ದೊಡ್ಡದು ಅನ್ನುವಂಥದ್ದನ್ನ ಅರ್ಥ ಮಾಡಿಕೊಂಡು ವೈದ್ಯರುಗಳು ಬಡವನೇ ಬರಲಿ, ಯಾರೇ ಬರಲಿ, ಅವನ ಹತ್ರ ಹಣ ಐತೋ ಇಲ್ಲೋ ಅದನ್ನ ಲೆಕ್ಕಿಸದೇನೆ ಮೊದಲು ಅವರಿಗೆ ತಾಯಿಯಂತೆ ಜೋಪಾನ ಮಾಡ್ತಾರೆ, ರಕ್ಷಣೆ ಮಾಡ್ತಾರೆ. ಹಾಗಾಗಿನೇ ಇವತ್ತು ದೇಶದಲ್ಲಿ ಮರಣ ಹೊಂದುವವರ ಸಂಖ್ಯೆ ಕಮ್ಮಿ ಆಗಿದೆ. ಮೊದಲು ದೇಶದಲ್ಲಿ ದೊಡ್ಡ ದೊಡ್ಡ ಕಾಯಿಲೆಗಳು ಸುನಾಮಿ ತರ ಅಪ್ಪಳಿಸಿಬಿಟ್ಟವು. ಪ್ಲೇಗ್ ಅನ್ನುವಂತಹ ಕಾಯಿಲೆ ಬಂತು ಅವತ್ತಿನ ಕಾಲದಲ್ಲಿ, ಅಂದ್ರೆ 40 ವರ್ಷದ ಹಿಂದೆ ಸಾವಿರಾರು ಜನ ಆ ಕಾಯಿಲೆಯಲ್ಲೇನೆ ತೀರ್ಕೊಂಡು ಹೋದ್ರು. ಇನ್ನು 2-3 ವರ್ಷ ಆಗಿಲ್ಲ ಕೋವಿಡ್ ಬಂದು, COVID-19 ಅಂತ ಹೇಳಿ ಆ ಟಿವಿಲೆಲ್ಲ ತೋರಿಸ್ತಾ ಇದ್ರು. ಮಾಸ್ಕ್ ಹಾಕೇಳ್ರಿ, ಕೆಮ್ತಾ ಇದ್ದೀರಾ, ಕೈ ತೊಳ್ಕೊಳ್ರಿ, ಯಾರನ್ನು ಸಹ ನಾವು ಮಾತಾಡ್ಸಂಗಿದ್ದಿಲ್ಲ ಅಂತ ಒಂದು ಪರಿಸ್ಥಿತಿ ಇಡೀ ಜಗತ್ತಿನಾದ್ಯಂತ ಆಗಿತ್ತು. ಜಗತ್ತಿನ ತುಂಬಾ ಕೋವಿಡ್ ವ್ಯಾಪಿಸಿದ್ರು, ಭಾರತ ತುಂಬಾನು ವ್ಯಾಪಿಸಿದ್ರು, ಎಲ್ಲರನ್ನೂ ಜೀವ ರಕ್ಷಣೆ ಮಾಡಿದಂತ ಕೀರ್ತಿ ನಮ್ಮ ವೈದ್ಯರಿಗೆ ಸಲ್ಲುತ್ತೆ ಎನ್ನುವಂತಹದ್ದು. ನಿಜವಾಗ್ಲೂ ವೈದ್ಯರ ಕೆಲಸ ಹೇಗಿದೆ ಅಂದ್ರೆ, ಸೈನಿಕರು ಯಾವ ರೀತಿಯಾಗಿ ಗಡಿ ಭಾಗದಲ್ಲಿ ನಿಂತುಕೊಂಡು ಹಗಲು ರಾತ್ರಿ ಎನ್ನಲಾರ್ದನೆ, ಬಿಸಿಲು ಚಳಿ ಎನ್ನಲಾರ್ದನೆ, ಶತ್ರುಗಳಿಗೆ ಗುಂಡಿಗೂ ಬಲಿಯಾಗ್ತೀವಿ ಅನ್ನುವಂತಹದನ್ನ ಲೆಕ್ಕಿಸಲಾರ್ದನೆ ಇಡೀ ದೇಶಕ್ಕೆ ತಮ್ಮ ಪ್ರಾಣವನ್ನು ತೆತ್ತು ಯಾವ ರೀತಿಯಾಗಿ ದೇಶ ರಕ್ಷಣೆಯನ್ನ ಮಾಡ್ತಾರೋ, ಅದೇ ರೀತಿಯಾಗಿ ವೈದ್ಯರು ಸಹ ಸೈನಿಕರಂತೆ 24 ತಾಸು ಕೆಲಸ ಮಾಡುವಂತಹ ಕಾರ್ಯಕರ್ತರು ಅಂತ ಹೇಳಲಿಕ್ಕೆ ನನಗೆ ಅತ್ಯಂತ ಸಂತೋಷ ಆಗ್ತಾ ಇದೆ ಎನ್ನುವಂತಹದ್ದು. ನಮಗೆ ಯಾವ ಟೈಮ್ನಾಗೆ ಏನಾಗುತ್ತೆ ಅನ್ನೋದು ಗೊತ್ತಿಲ್ಲ. ಹಾರ್ಟ್ ಅಟ್ಯಾಕ್ ಅನ್ನೋದು ಹಗಲೊತ್ತನ ಆಗ್ಬೋದು, ರಾತ್ರಿನೂ ಆಗ್ಬೋದು. ಮಲಗದವರು ಎಷ್ಟೋ ಜನ ಎದ್ದೇ ಇಲ್ಲ. ಕೆಲವು ಜನಕ್ಕೆ ರಾತ್ರಿ ಎದೆ ನೋವು ಅಂತ ಬಂದಿದ್ದಾರೆ. ಸಾಕಷ್ಟು ನಮ್ಮ ಚಿತ್ರದುರ್ಗದ ಉದಾಹರಣೆ ಹೇಳಬೇಕು ಅಂತಂದ್ರೆ, ನಮ್ಮ ಬಸವೇಶ್ವರ ಮೆಡಿಕಲ್ ಕಾಲೇಜು ಆಸ್ಪತ್ರೆ ಇರೋದ್ರಿಂದ ನಮ್ಮ ಮಠದ ಭಕ್ತರು, ಉದ್ಯಮಿಗಳು, ಅವ್ರ ಹೆಸರು ಹೇಳೋದು ಬೇಡ, ಅವರು ದೊಡ್ಡ ಬಿಸ್ನೆಸ್ ಮ್ಯಾನ್, ಅವರು ಎಲ್ಲ ಕ್ರಷರ್ಗಳು ಅದಾವೆ. ಅವರಿಗೆ ಎದೆ ನೋವು ಬಂದ್ಬಿಡ್ತು. ಎಷ್ಟೊತ್ತಿಗೆ? 3 ಗಂಟೆಗೆ, ರಾತ್ರಿ 3 ಗಂಟೆಗೆ. ತಕ್ಷಣ ಏನ್ ಮಾಡಿದ್ರು ಅವರು? ಬಸವೇಶ್ವರ ಆಸ್ಪತ್ರೆಗೆ ಬಂದ್ರು. ಹಾರ್ಟ್ ಅಟ್ಯಾಕ್ ಆಗಿತ್ತು. ತಕ್ಷಣ ನಮ್ಮ ಯಾರು ನಮ್ಮ ಪಾಲಕ್ಷಪ್ಪರು ಡಾಕ್ಟರ್ ಇದ್ರು, ಅವರು ಅಟೆಂಡ್ ಮಾಡಿದ್ರು. ಅಲ್ಲಿರುವಂತ ಹಾರ್ಟ್ ಡಾಕ್ಟರ್ ಇಂದ ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಡಿಸಿದ್ರು. ಅವರ ಜೀವ ಉಳಿತು. ಹೀಗೆ ಸಾವಿರಾರು ಜನರ ಜೀವವನ್ನ ಉಳಿಸುವಂತಹ ಕಾರ್ಯವನ್ನ ಯಾರು ಮಾಡಿದ್ದಾರೆ ಅಂದ್ರೆ ನಮ್ಮ ವೈದ್ಯರು ಮಾಡಿದ್ದಾರೆ ಅಂತ ಹೇಳಿಕ್ಕೆ ನಮಗೆ ಖುಷಿ ಆಗುತ್ತೆ ಅನ್ನುವಂಥದ್ದು. ಹಗಲು ರಾತ್ರಿ ಅನ್ನಲಾರ್ದನೆ ದುಡಿತಾ ಇದ್ದಾರೆ. ನೈಟ್ ಶಿಫ್ಟ್ ಇರ್ಬೋದು, ಡೇ ಶಿಫ್ಟ್ ಇರ್ಬೋದು, ನಿಮಗೆ ಯಾವಾಗ ಬೇಕಾದ್ರೂ ಫೋನ್ ಬರ್ತಾವ್, ಬರ್ರಿ ಹೆರಿಗೆ ಆಗ್ತಾ ಇದೆ ಬರ್ರಿ ಅಂತಂದು ಹೆರಿಗೆ ಡಾಕ್ಟ್ರಿಗೆ ಕರಿಬಹುದು. ಅಥವಾ ಆಕ್ಸಿಡೆಂಟ್ ಆಗಿದೆ ಬರ್ರಿ ಅಂತ ಹೇಳಿ, ಕಾಲು ಮುರಿದೈತೆ ಅಂತ ಹೇಳಿ ಮೂಳೆ ಡಾಕ್ಟ್ರಿಗೆ ಕರಿಬಹುದು. ಕಣ್ಣಿನ ತೊಂದರೆ ಆಗೈತಿ, ಕಣ್ಣ ಹೋಗ್ತಾ ಇದೆ, ಕಣ್ಣಿನ ಡಾಕ್ಟ್ರು ಕರಿಬಹುದು. ಹಲ್ಲಿನ ಡಾಕ್ಟ್ರು, ಕಿವಿ ಡಾಕ್ಟ್ರು. ಒಂದೇ ಸಲ ನಿಮಗೆ ಹೇಳ್ಬೇಕಂದ್ರೆ, ಇಲ್ಲೇ ನಮ್ಮ ಪ್ರಹ್ಲಾದ್ ಡಾಕ್ಟರ್ ಅದಾರ. ಒಂದ್ಸರಿ ನಾವು ಮುರುಘಾ ಮಠದಲ್ಲಿ 1 ವರ್ಷದ ಹಿಂದೆ ವಾಕ್ ಮಾಡಾಕತ್ತೀವಿ. ರಾತ್ರಿ 10 ಗಂಟೆಗೆ, ತಂಪಿದೆ, ವಾತಾವರಣ ಚೆನ್ನಾಗಿದೆ ಅಂತ ಹೇಳಿ, ಸಡನ್ ಆಗಿ ಕಿವಿ ಒಳಗ ಒಂದು ಸಣ್ಣ ಹುಳ ಹೋಗ್ಬಿಡುತ್ತೆ. ಏನ್ ಮಾಡ್ಬೇಕಪ್ಪ ಅಂತೇಳಿ ನಾವು ಮತ್ತೆ ಇಲ್ಲಿ ನಮ್ಮ ಆಸ್ಪತ್ರೆಗೆ ಫೋನ್ ಮಾಡಿ, ಇಲ್ಲ ನಮ್ಮ ಡಾಕ್ಟರ್ ಪ್ರಹ್ಲಾದ್ ಅದಾರೆ ಅಂತ ಹೇಳಿ ಅವ್ರಿಗೆ ನಾವು ಫೋನ್ ಮಾಡಿದ್ವಿ. ಸ್ವಾಮೀಜಿ ನೀವೆಲ್ಲಿದ್ರಿ? ಸೀದಾ ನಮ್ಮ ಕ್ಲಿನಿಕ್ಗೆ ಬರ್ರಿ. ಹೋಗ್ವಿ. 2 ನಿಮಿಷಕ್ಕೆ ನಮ್ಮ ಕಿವಿಯಾಗಿ ಹೋಗಿರುವಂತ ಹುಳವನ್ನ ಅವರು ನೀರು ಬಿಟ್ಟು ಸ್ವಚ್ಛ ಮಾಡಿ ಕ್ಲೀನ್ ಮಾಡಿ ಕಳಿಸಿದ್ರು. ನೋಡ್ರಿ, ಈ ರೀತಿಯಾಗಿ ಹಗಲು ರಾತ್ರಿ ಸರ್ವಿಸ್ ಕೊಡುವಂತಹ ವೈದ್ಯರು ನಮ್ಮ ಚಿತ್ರದುರ್ಗದಲ್ಲಿನೂ ಅದಾರೆ, ನಮ್ಮ ಭಾರತದಲ್ಲಿನೂ ಅದಾರೆ. ಹಾಗಾಗಿನೇ ಇವತ್ತು ಭಾರತ ಹಾಗೂ ಚಿತ್ರದುರ್ಗ, ಕರ್ನಾಟಕ ಆರೋಗ್ಯವಾಗಿದೆ ಅಂತಂದ್ರೆ ಅದಕ್ಕೆ ನಮ್ಮ ವೈದ್ಯರೇ ಕಾರಣ. ವೈದ್ಯರಿಂದ ಇವತ್ತು ಆರೋಗ್ಯಕರವಾಗಿರುವಂತಹ ಸಮಾಜ ಇವತ್ತು ನಿರ್ಮಾಣ ಆಗಿದೆ ಎನ್ನುವಂಥದ್ದು. ಆ ಒಂದು ಹಿನ್ನೆಲೆಯಲ್ಲಿ ಇವತ್ತು ವೈದ್ಯರಿಗೆ ಗೌರವವನ್ನು ಸಲ್ಲಿಸುವಂತ ನಿಟ್ಟಿನಲ್ಲಿ ವೈದ್ಯರ ದಿನಾಚರಣೆಯನ್ನ ನಾವೆಲ್ಲರೂ ಸೇರಿ ಆಚರಣೆ ಮಾಡ್ತಾ ಇದ್ದೀವಿ. ಈ ಸಂದರ್ಭದಲ್ಲಿ ಸಾಕಷ್ಟು ಜನ ನಿಸ್ವಾರ್ಥವಾಗಿ ಸೇವೆಯನ್ನು ಸಲ್ಲಿಸಿರುವಂತಹ ವೈದ್ಯರುಗಳಿಗೆ, ಡಾಕ್ಟರ್ಗಳಿಗೆ ಅವರಿಗೆ ಅಭಿನಂದನೆಯನ್ನು ಸಲ್ಲಿಸುವಂತಹದ್ದು, ಗೌರವವನ್ನು ಸಲ್ಲಿಸುವಂತಹದನ್ನ ನಿಟ್ಟಿನಲ್ಲಿ ನಮ್ಮ ಮೆಡಿಕಲ್ ಕಾಲೇಜಿನ ವತಿಯಿಂದ ಹಿರಿಯ ವೈದ್ಯರುಗಳಿಗೂ ನಾವು ಇಲ್ಲಿ ಸನ್ಮಾನವನ್ನ ಮಾಡ್ತಾ ಇದ್ದೀವಿ. ಅಂತಹ ಎಲ್ಲ ವೈದ್ಯರಿಗೆ ಹಾಗೂ ಮುಂದೆ ತಯಾರಾಗುತ್ತಿರುವಂತಹ ಹೊಸ ವೈದ್ಯರುಗಳಿಗೂ ನಾವು ವೈದ್ಯರದ ದಿನಾಚರಣೆಯ ಶುಭಾಶಯಗಳನ್ನು ತಿಳಿಸ್ತಾ, ನಿಮ್ಮ ಸೇವೆ ಹಗಲು ರಾತ್ರಿನೂ ನಡೀತಾ ಇದೆ. ಇದೇ ರೀತಿಯಾಗಿ ನಿರಂತರವಾಗಿ ನಡೆಯಲಿ. ಜಗತ್ತನ್ನ ಉಳಿಸುವಂತಹ, ಜೀವವನ್ನು ಉಳಿಸುವಂತಹ ಕಾರ್ಯವನ್ನ ನೀವೆಲ್ಲರೂ ಮಾಡ್ತಾ ಇದ್ದೀರಿ. ನಿಮ್ಗೆಲ್ಲರಿಗೂ ನಾವು ಒಂದು ಧನ್ಯವಾದವನ್ನು ಹೇಳ್ತಾ, ನಿಮ್ಗೆಲ್ಲರಿಗೂ ವೈದ್ಯ ದಿನಾಚರಣೆಯನ್ನ ಶುಭಾಶಯಗಳನ್ನು ತಿಳಿಸ್ತಾ ನಮ್ಮ ಮಾತನ್ನು ಮುಗಿಸ್ತೇವೆ. ಶರಣು ಶರಣಾರ್ಥಿಗಳು.
ಧನ್ಯವಾದಗಳು ಪೂಜ್ಯ ಸ್ವಾಮೀಜಿಯವರಿಗೆ.
Now I request Dr. Sujay R. Prasad sir, Group of Chief Medical Director, NDPL, to address the gathering.
Respected and revered Swamiji, dignitaries on the dais and off the dais, frankly, I'm not prepared for this speech. I was taken aback when Dr. Murthy asked me to come here and talk. Nevertheless, I have got this opportunity and I see a lot of students So I'll take this opportunity to share with you my few learnings. I think all of us have had the opportunity to be amongst good teachers. I think that is a very important aspect for each one of us, because we rely on our intellect, and our intellect relies on what we know. But keep in mind that what we don't know is immensely more than what we know. So when you're trying to rely on your knowledge, be aware there is a vast amount of knowledge that you do not know. Have the humility to understand from that point of view and take decisions. That is the first point. Second point, every day when you come to your place of work, students, to your college, ask yourself, can I be better than yesterday? Because there's always a better and faster way to do things. Just ask yourself whether you can do it. And I'm sure you'll find a way. Third, and last but not the least, please take care of yourself, because nobody else is going to do that for you. When I say take care of yourself, you take care of your physical body and take care of your mind. Because you are not your mind, you are the witness of your mind. You are the awareness in which the mind operates. If you believe you are the mind, you'll suffer the consequences of your mind. So if you just pay attention to the awareness who you truly are, then you are that inner peace in which thoughts arise, you decide what you want to do with it. With that, I wish you all the very best in your student life and your professional life. Thank you very much.
Thank you so much, sir, for your words. Now, I would like to welcome Dr. Jayaram Yan, sir, Director, NAALM, to address the gathering.
ಗುರುಜಿ ಅವರಿಗೆ ಮತ್ತೆ ಎಲ್ಲರಿಗೂ ನನ್ನ ನಮಸ್ಕಾರ. ದಿ ಸಿಟಿ ಆಫ್ ಚಿತ್ರದುರ್ಗ, Basaveshwara Medical College, Vasavi Diagnostic Laboratory, and Narayan Murthy. All of these have a very special place in my life and my memories. Chitradurga was the first time I addressed an IMA gathering. You remember, it was years ago. I delivered my first talk to the IMA in Chitradurga. And even today, I was recounting to my colleague the kind of hospitality and the kind of experience I had from the time I entered Chitradurga city, leave alone the IMA hall, till the time we left. It's something memorable. Basaveshwara Medical College, I've visited multiple times for multiple training sessions and for conference, but the greatest experience for me, the first time in my life, and hope it is not the last, was that I was called to address the outgoing students for a graduation ceremony. I mean, this is something I never dreamt of in my life. And in line with what Dr. Sujay was mentioning, I told the doctors, young doctors, just one thing. Yes, we are all coming out into a noble profession. We are coming to serve a lot of patients. But please bear in mind, at the back of your mind, that you also need to take care of yourself and your family. So these two become very important pillars which will drive us into the quest for so-called selfless service. And I've been following Dr. Murthy from his younger days as a student and as a professional, as a diagnostician. Our association with Vasavi Lab and Dr. Murthy has been increasing over time. And as a teacher, if I can call myself a teacher, I think the proudest moment in a teacher's life is when they have the opportunity to learn from their students. And I think Dr. Murthy's deeds, his achievements teach me a lot in my life, and I'm indeed extremely proud, Dr. Murthy, that I have this association with you. So I won't say much more. I just wish you all a wonderful celebration on Doctor's Day, and please follow your heart. Please follow your passion, and whatever is the outcome, please pursue that relentlessly. Thank you very much.
Thank you so much, Jairam sir.
ಧನ್ಯವಾದಗಳು ಪೂಜ್ಯ ಸ್ವಾಮೀಜಿ ಅವರಿಗೆ. Now I request Swamiji sir to come on the dais. To felicitate Swamiji.
ಈಗ ವೈದ್ಯಕೀಯ ವೃತ್ತಿಯಲ್ಲಿ ಸುದೀರ್ಘ ಸೇವೆ ಸಲ್ಲಿಸಿರ್ತಕ್ಕಂಥ ಮತ್ತೊಬ್ಬ ವ್ಯಕ್ತಿ ಡಾಕ್ಟರ್ ರೇಣುಪ್ರಸಾದ್ GP ಅವರು ದಯವಿಟ್ಟು ವೇದಿಕೆ ಮೇಲೆ ಬರಬೇಕು ಅಂತ ಕೇಳ್ಕೊಳ್ತೇನೆ. ಡಾಕ್ಟರ್ ರೇಣುಪ್ರಸಾದ್ ಅವರು 31/5/2026 ನಮ್ಮ ಚಿತ್ರದುರ್ಗ ಜಿಲ್ಲೆಯ ಜಿಲ್ಲಾ ಆರೋಗ್ಯ ಮತ್ತು ಕುಟುಂಬ ಕಲ್ಯಾಣಾಧಿಕಾರಿಗಳಾಗಿ ಸೇವೆ ಸಲ್ಲಿಸಿ ನಿವೃತ್ತಿ ಹೊಂದಿರ್ತಾರೆ. ಇವರು ಕಮಲಮ್ಮ ಮತ್ತೆ ಡಾಕ್ಟರ್ ಪುಟ್ಟಗಿಡ್ಡಪ್ಪನವರ ಪುತ್ರರಾಗಿ 1966ರಲ್ಲಿ ಚಿಕ್ಕಮಗಳೂರು ಜಿಲ್ಲೆಯ ಮೂಡಿಗೆರೆಯಲ್ಲಿ ಜನಿಸಿರ್ತಾರೆ. ಇವರು ಪ್ರಾಥಮಿಕ ಶಿಕ್ಷಣ ಮತ್ತು ಹೈಸ್ಕೂಲನ್ನ ಹಾಸನದಲ್ಲಿ ಪಡೆದು ವೈದ್ಯಕೀಯ ಪದವಿಯನ್ನ SJMIT ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ದಾವಣಗೆರೆಯಲ್ಲಿ ಪಡ್ಕೊಂಡು 1995ರಲ್ಲಿ ವೈದ್ಯಕೀಯ ವೃತ್ತಿಗೆ ಸರ್ಕಾರಿ ವೈದ್ಯಕೀಯ ವೃತ್ತಿಗೆ ಸೇರಿರ್ತಾರೆ. ಇವರು ಗುತ್ತಿಗೆ ಆಧಾರದ ವೈದ್ಯಾಧಿಕಾರಿಯಾಗಿ ನೇರ್ಲಿಗಿಯಲ್ಲಿ PHC ವೈದ್ಯಾಧಿಕಾರಿಗಳಾಗಿ, ಅದಾದ ನಂತರ 18/11/2012ರಿಂದ ದಾವಣಗೆರೆ ಜಿಲ್ಲೆಯ ಕುಷ್ಠರೋಗ ನಿಯಂತ್ರಣಾಧಿಕಾರಿಗಳಾಗಿ ಸೇವೆ ಸಲ್ಲಿಸಿರ್ತಾರೆ. 2012ರಿಂದ 2013ರವರೆಗೆ ಉನ್ನತ ವ್ಯಾಸಂಗವನ್ನ DPH ವ್ಯಾಸಂಗವನ್ನು ಪಡೆದಿರ್ತಾರೆ. ಅದಾದ್ಮೇಲೆ ನಮ್ಮ ಚಿತ್ರದುರ್ಗ ಜಿಲ್ಲೆಗೆ ಇವರು 2013ರಿಂದ 2020ರವರೆಗೆ ಜಿಲ್ಲಾ ಸರ್ವೇಕ್ಷಣಾಧಿಕಾರಿಗಳಾಗಿ, ಜಿಲ್ಲಾ ಸರ್ವಿಲೆನ್ಸ್ ಆಫೀಸರ್ ಆಗಿ ವರ್ಕ್ ಮಾಡಿರ್ತಾರೆ. 2020ರಿಂದ 2023ರವರೆಗೆ ಜಿಲ್ಲಾ ಕುಟುಂಬ ಕಲ್ಯಾಣ ಅಧಿಕಾರಿಯಾಗಿ FW ಆಫೀಸರ್ ಆಗಿ ವರ್ಕ್ ಮಾಡಿರ್ತಾರೆ. ಈ ಕೊನೆಗೆ 2/10/2023ರಿಂದ 31/5/2026ರವರೆಗೆ ನಮ್ಮ ಜಿಲ್ಲೆಯ ಜಿಲ್ಲಾ ಆರೋಗ್ಯ ಮತ್ತು ಕುಟುಂಬ ಕಲ್ಯಾಣಾಧಿಕಾರಿಗಳಾಗಿ ತಮ್ಮ ವೈದ್ಯ ವೃತ್ತಿಯಲ್ಲಿ ಸೇವೆಯನ್ನು ಸಲ್ಲಿಸಿರ್ತಾರೆ. ಇವರಿಗೆ ದೇವರು ಆಯುರಾರೋಗ್ಯ ಐಶ್ವರ್ಯವನ್ನ ಮತ್ತೆ ಸಕ್ಸಸ್ ಅನ್ನ ಸದಾ ನೀಡಲಿ ಅಂತ ನಮ್ಮ IMA ಹಾಗೂ ನಿಮ್ಮೆಲ್ಲರ ಪರವಾಗಿ ಹೃತ್ಪೂರ್ವಕವಾಗಿ ದೇವರನ್ನ ಬೇಡ್ಕೊಳ್ತೇನೆ. ಡಾಕ್ಟರ್ ಶರತ್ BV ಅವರು ವೇದಿಕೆ ಮೇಲೆ ಬರಬೇಕು ಅಂತ ಕೇಳ್ಕೊಳ್ತೇನೆ. ಡಾಕ್ಟರ್ ಶರತ್ BV ಇವರು 1979 ಜಗಳೂರಿನಲ್ಲಿ ವೆಂಕಟೇಶ್ ರೆಡ್ಡಿ ಮತ್ತು ಗಾಯತ್ರಿ ಅವರ ಮಗನಾಗಿ ಜನಿಸಿರ್ತಾರೆ. ಇವರಿಗೆ ಶ್ರಾವಂತಿ ಅಂತಕ್ಕಂಥ ಇವರ ವೈಫ್ ಹೆಸರು ಶ್ರಾವಂತಿ. He is blessed with 2 kids, Disha, elder daughter. She is studying in BCom. Shraddha, BS. 14 years she is studying in 9th standard. He is graduated from JNMC Belgavi and graduated MS degree from JJMMC Davangere. He got a fellowship in FMAS and DMAS from World Laparoscopy Hospital Gurugram in 2016. Now he is working as a proctologist and since 4 years. He is the HOD in Basaveshwara Medical College from 2020 to 26. ನಮ್ಮೆಲ್ಲರ ಪರವಾಗಿ ದೇವರಲ್ಲಿ ಅವ್ರಿಗೆ ಇದೇ ಸಕ್ಸಸ್ ಅನ್ನ ಮತ್ತೆ ಆಯುರಾರೋಗ್ಯವನ್ನ ನೀಡಲಿ ಅಂತ ದೇವರಲ್ಲಿ ಬೇಡ್ಕೊಳ್ತೇನೆ. ಡಾಕ್ಟರ್ ಸುಧೀಂದ್ರ KS ಮೈಕ್ರೋಬಯಾಲಜಿಸ್ಟ್ ಅವರು ವೇದಿಕೆ ಮೇಲೆ ಬರಬೇಕು ಅಂತ ಕೇಳ್ಕೊಳ್ತೇನೆ. ಸ್ಟೂಡೆಂಟ್ ಅಪ್ಲಾಸ್ ಅನ್ನ ಕೇಳಿದ್ರೆ ಡಾಕ್ಟರ್ ಸುಧೀಂದ್ರ ಅವರು ಎಷ್ಟು ಹೆಸರು ಮಾಡಿದ್ದಾರೆ ಈ ಬಸವೇಶ್ವರ ಮೆಡಿಕಲ್ ಕಾಲೇಜಲ್ಲಿ ಅಂತ ಗೊತ್ತಾಗ್ತದೆ. ಇವರು 1980ರಲ್ಲಿ ಕೆ ಸುಬ್ರಹ್ಮಣ್ಯಂ ಮತ್ತು ಶ್ರೀಮತಿ ಶೋಭಾ ಅವರ ಪುತ್ರರಾಗಿ ಜನಿಸಿರ್ತಾರೆ. ಹೊಸಪೇಟೆನಲ್ಲಿ ಇವ್ರದ್ದು ನೇಟಿವ್ ಪ್ಲೇಸ್ ಹೊಸಪೇಟೆ. ಇವರು ಪ್ರೀ ಯೂನಿವರ್ಸಿಟಿವರೆಗೂ ಹೊಸಪೇಟೆನಲ್ಲಿ ಓದ್ಕೊಂಡು ಬಳ್ಳಾರಿ ವಿಮ್ಸ್ ಅಲ್ಲಿ MBBS ಡಿಗ್ರಿಯನ್ನು ಪಡ್ಕೊಂಡಿರ್ತಾರೆ. ಓಸ್ಮಾನಿಯಾ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ಹೈದರಾಬಾದಲ್ಲಿ MD ಮೈಕ್ರೋಬಯಾಲಜಿ ಡಿಗ್ರಿಯನ್ನು ಪಡ್ಕೊಂಡಿರ್ತಾರೆ. ಇವರು ಸ್ಟೂಡೆಂಟ್ ಇರುವಾಗಲೇ CS ಸುಬ್ರಹ್ಮಣ್ಯಂ ಮೆಮೋರಿಯಲ್ ಗೋಲ್ಡ್ ಮೆಡಲ್ ಅವಾರ್ಡ್ ಅನ್ನ PG ಪೇಪರ್ ಪ್ರೆಸೆಂಟೇಷನ್ಗೋಸ್ಕರ ಪಡ್ಕೊಂಡಿರ್ತಾರೆ. ಇವರು ಸುಮಾರು 15 ವರ್ಷದಿಂದ ಬಸವೇಶ್ವರ ಮೆಡಿಕಲ್ ಕಾಲೇಜಿನಲ್ಲಿ ಮೈಕ್ರೋಬಯಾಲಜಿಸ್ಟ್ ಆಗಿ ವಿವಿಧ ಹುದ್ದೆಗಳನ್ನು ಅಲಂಕರಿಸಿ ಈವನ್ ಈಗ ಪ್ರಾಂಶುಪಾಲರಾಗಿಯೂ ಸಹ ಕರ್ತವ್ಯ ನಿರ್ವಹಿಸ್ತಾ ಇರ್ತಾರೆ. ಇವರ ಪೇಪರ್ ಪ್ರೆಸೆಂಟೇಷನ್ ಮತ್ತೆ ಈ ನ್ಯಾಷನಲ್ ಅಂಡ್ ಇಂಟರ್ನ್ಯಾಷನಲ್ CMEಗಳನ್ನ ಅಟೆಂಡ್ ಮಾಡಿರೋದಕ್ಕೆ ಲೆಕ್ಕವೇ ಇಲ್ಲ, ಅಷ್ಟೊಂದು ಸರ್ವಿಸ್ ಅನ್ನ ಕೊಟ್ಟಿರ್ತಾರೆ. ಇವರಿಗೆ ದೇವರು ಆಯುರಾರೋಗ್ಯ, ಐಶ್ವರ್ಯ ಮತ್ತೆ ಸಕ್ಸಸ್ ಅನ್ನ ಕೊಡ್ಲಿ ಅಂತ ನಿಮ್ಮೆಲ್ಲರ ಪರವಾಗಿ ದೇವರಲ್ಲಿ ಬೇಡ್ಕೊಳ್ತೇನೆ.
ಬೇಗ ಮಾಡ್ಲಿ
ಸ್ಟೂಡೆಂಟ್ಸ್ ತೊಂದರೆ ಇದೆ.
Navami N, Doctor of Nagraj KV and Dr. Shubha DS, who secured 98.6 in her second PUC examination and All India rank of 13,303 in NEET 2026. I request Navami to come on the stage. Vishwajit Gowda CN, son of Dr. Nagendra Gowda MR and Mrs. Chaya, who secured 92% in second PUC examination. Rohan Kumar KM, son of Dr. KP Mallappa and Mrs. Rashmi, who secured 92% in second PUC examination. Vaishnavi C, daughter of Dr. Channa Reddy H and Mrs. Rekha Ji, who secured 91.2% in his second PUC examination. R. Yasha, daughter of Dr. Raghavendra and Dr. Ganashri, who secured 97% in her second PUC examination. I.S. Shibravi, daughter of Dr. Sharat Kumar and Mrs. Jyoti Sharat Kumar, who secured 91% in her second PUC examination. Ananya GM, daughter of Dr. B. Mallikarjun Kirti and Mrs. Sunita, who secured 90% in her 10th examination. Dr. Akshay SR, MD General Medicine, Hassan Institute of Medical Sciences, son of Dr. SP Ravindra and Mrs. Veena.
ಅವ್ರ ಪೇರೆಂಟ್ಸು ವೇದಿಕೆ ಮೇಲೆ ಬರ್ಬೇಕಂತ ಕೇಳ್ಕಂತೆ. I request their parents to come onto the stage, please. ಅವ್ರ ತಂದೆ ತಾಯಿ ದಯವಿಟ್ಟು ವೇದಿಕೆ ಮೇಲೆ ಬರ್ಬೇಕಂತ ಕೇಳ್ಕೊಳ್ತೀವಿ.
ಅದಾದ್ಮೇಲೆ ಇವರು ಪ್ರಹ್ಲಾದ್ ಸರ್ ಆಯ್ತಲ್ಲ ಲಾಸ್ಟ್
I request
ಕೆಲಸ ಇರೋದಕ್ಕೆ ಸ್ವಾಮೀಜಿ ಮುಂದಿನ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಕಾರ್ಯಕ್ರಮ ಮತ್ತೆ ಮುಂದುವರಿಯುತ್ತೆ ಅಂತ ಹೇಳ್ತೀರಾ?
due to uncertain reasons, Swamiji couldn't be here. So we'd like to continue this program after this. Now I request Dr. K.B. Gudusi sir, Vice Chancellor, SJM University, to address the gathering.
Let me address my ambassadors first here. My dear student friends, you are our ambassadors. Next comes the parents and the doctors and the elite, lot of the same flock, the doctors on the dais. First and the foremost, let me wish you on this Doctor's Day. Have a great day, great year, and great life as a professional doctor. And let me congratulate you for choosing this noble profession, because as one of the previous speaker was talking about the defense people, but you are the one who have chosen this field and who have chosen the service of this mankind before even the profession starts, to learn and then go into. So congratulations for that. Shakti, one request. Can you please circulate Dr. Sujay Prasad's words to everyone? Because each and every word of him can be a statement for everyone here. Dr. Sujay, really it was very short, but one of the best speech I have heard so far.
Very simple, very precise, and accurate. Every word is to be remembered by my doctor friends here. Thank you so much, Dr. Prasad. So at the same time, I should thank Dr. Murthy here for giving me an opportunity to be with all the doctors. So as a teacher, as Prasad was talking about, can you just give me a few minutes? Though I had, Dr. Murthy had given me 2 minutes. Just think of this campus. Medical education here, engineering is here, pharmacy is here, and of course, nursing is also there. Can you, the whole ecosystem is so conducive for you to think beyond that, as Prasad was telling. So you have to think of that part which is not known rather than which is known to you. So friends, one of the best, the conducive environment to do research. I know in medical field a lot of research is very less, but still when you are having such an environment at your disposal, please make use of that. And as a university, this SJM University will give you everything that is required for the research. That is my promise. Okay. So think of that. Let Basaveshwara Medical College as well as SJME University be the front runner in research in medical field. That's what I expect and I wish as well. Because just I'll quote one incident here, why I'm giving more emphasis on research. One of my research student, I'm from chemistry background, and out of 22 PhDs, I think 12 or 13 have worked on cancer. Okay, so let us keep that all apart. One of my research student, during her working in the around maybe around 132, she spilled aniline onto her body. I hope everyone knows aniline is a very basic material, highly basic in nature. And that stupid girl, instead of taking off or going to the hostel and have a wash and other things, she continued working in the same lab. She washed all that table and she continued. By evening, she fell unconscious. Then she was shifted to SJMIT Medical College in Dharwad. It was maybe around 9 o'clock in the night. Then the doctors, night duty doctors, one was busy there. They could not get any clue for that. They tried to push oxygen. It was not getting saturated. So no history, nothing. So there the real thinking of a science student gets in. We started post-mortem the whole thing that she has done in the day. Then finally, we came to know that she had spilled over this aniline on her body. She has washed it, but she has not changed in neither her clothes nor she had a wash. Then we started thinking about aniline, a very, very simple, common chemical you find in any chemical laboratory. oxygen was not getting saturated. That was the concern. Then one PG doctor, she went to Google University and found that since it is more basic, it binds to the iron of hemoglobin. So that much amount of hemoglobin was lost actually. To regain that hemoglobin, we have to break that bond between iron and this aniline. It was really tough to think. And that too we have to think in a very short time. Then we could get one information that methylene blue, again a very, very common indicator that one uses in the labs. Since many of you are from the pathology, you'll be knowing that. So that can do this breaking. So methylene blue was pushed in. Then after almost some 24 hours, that girl could regain the life. So why I'm putting this across, my friends, as I said, you are my ambassadors. Every simple science, simple chemistry or physics, whatever it is, that may help you in your experience. That means the real clinic or whatever, the operation, whatever you think. So please be with science. Then I think one of the previous speaker, I could not remember his name. He was talking about, please don't go after money. Money will follow you. Please go after the patients. That's very, very important. Okay. So with this request, have a great environment for research, wherein you are having the technologist with you, pharmacist with you, and of course, the whole lot of doctors and the medical practitioners are here. So please make use of this great environment and give us something better, not known, for a purposeful as well as safe life. Thank you so much. All the best.
Thank you so much, sir. Now, it's my privilege to introduce our respected medical superintendent, a leader who is known for, not just for his vision, but for the genuine connection he builds with the people. He knows every corner of this institution, remembers every individual, and is always approachable and encouraging, especially to the students. His dedication to excellence and compassionate leadership continue to inspire us all. With great respect, I now invite our esteemed medical superintendent, Dr. Palakshaya Yel, sir, to deliver the presidential address.
ನಮಸ್ಕಾರ. ಇವತ್ತು ವೈದ್ಯರ ದಿನಾಚರಣೆ ದಿವಸ ಎಲ್ಲರಿಗೂ ಶುಭಾಶಯಗಳು. ನಾನು ಮೆಡಿಕಲ್ ಸೂಪರ್ಡೆಂಟ್ ಆಗಿ ಇವತ್ತು ಬಂದಿಲ್ಲ, IMA ಪ್ರೆಸಿಡೆಂಟ್ ಆಗಿ ನಾನು ಇಲ್ಲಿ ನಿಂತಿದ್ದೀನಿ. ವೇದಿಕೆ ಮೇಲೆ ನಮ್ಮ ಇರ್ತಂಥ ಬಸವಪ್ರಭು ಸ್ವಾಮೀಜಿಗಳಿಗೆ ನಮಸ್ಕರಿಸುತ್ತಾ, ವೇದಿಕೆ ಮೇಲಿರುವಂತಹ ನಮ್ಮ SJM ಯೂನಿವರ್ಸಿಟಿ ವೈಸ್ ಚಾನ್ಸಲರ್ ಅಂತ ಗುಡಿಸೆ ಸರ್ ಅವರಿಗೆ ವಂದಿಸುತ್ತಾ, ವೇದಿಕೆ ಮೇಲಿರುವ ಇತರ ಎಲ್ಲ ಗಣ್ಯರಿಗೂ ನಮಸ್ಕರಿಸುತ್ತಾ, ನಾನು ಈ ದಿನ ನಾನು ಏನು 2 ಥಿಂಗ್ಸ್ ರಿಮೆಂಬರ್ ಮಾಡಬೇಕಾಗುತ್ತೆ. ಒಂದು, ನಮ್ಮ IMA ಬಿಲ್ಡಿಂಗು ಕಟ್ಟಿದ್ದಕ್ಕೆ ಡೊನೇಷನ್ ಕೊಟ್ಟಿದ್ದೆ ನಮ್ಮ ಮಲ್ಲಿಕಾರ್ಜುನ ಮುರುಘರಾಜೇಂದ್ರ ಸ್ವಾಮಿಗಳು. ನಮ್ಮ IMA ಬಿಲ್ಡಿಂಗ್ ಹೆಸರೇ ಮುರುಘರಾಜೇಂದ್ರ IMA ಭವನ ಅಂತಿದೆ. ಇದು ನಮ್ಮ ಸ್ವಾಮೀಜಿಯವರು ಅವತ್ತಿನ 67ರಲ್ಲಿ 10,000 ರೂಪಾಯಿ ಡೊನೇಷನ್ ಕೊಟ್ಟು ನಮ್ಮ ಇದನ್ನ ಏನು IMA ಬಿಲ್ಡಿಂಗ್ ಕಟ್ಟಿಸಿದ್ದಾರೆ. ಅದೇ ರೀತಿ ನಮ್ಮ ಇಂದಿನ ನಮ್ಮ ಜಿಲ್ಲಾ ಮಂತ್ರಿಗಳಂತ ಸುಧಾಕರ್ ಸಾಹೇಬರು, ನಾವು ಹೋಗಿ ನಾನು ನಾರಾಯಣ ಮೂರ್ತಿ ಸರ್ ವಿಜಯ್ ಕುಮಾರ್ ಅಪ್ರೋಚ್ ಮಾಡಿದಾಗ ನಮ್ಮ ಬಿಲ್ಡಿಂಗ್ ಸ್ವಲ್ಪ ರಿನೋವೇಟ್ ಮಾಡ್ಬೇಕಂತೇಳಿ ಅವರು ನಮಗೆ 25 ಲಕ್ಷ ರೂಪಾಯಿ ಕೊಟ್ಟಿದ್ದಾರೆ. ಅದು ಸ್ಯಾಂಕ್ಷನ್ ಆಗಿದೆ. ಅದು ಮೋಸ್ಟ್ ಇಷ್ಟರಲ್ಲೇ ನಮ್ಮ IMA ಬಿಲ್ಡಿಂಗಿಗೆ ನಮಗೆ ಕೊಡ್ತಾ ಇದ್ದಾರೆ. ಅವ್ರನ್ನ ಸುಧಾಕರ್ ಅವರು ಡೆತ್ ಆಗಿದೆ, ಎಲ್ಲರಿಗೂ ಗೊತ್ತಿದೆ. ಅವ್ರನ್ನ ನಾವು ಇವತ್ತು ಮರೆಯೋಕ್ಕಾಗೋದಿಲ್ಲ. ನಮಗೆ IMAಗೆ ಮೋಸ್ಟ್ಲಿ ಯಾವ IMAಗೂ ಈ ಥರ ದುಡ್ಡು ಕೊಟ್ಟರೆ ಡೌಟ್ ಇದೆ. ನಮ್ಮ ಸುಧಾಕರ್ ನಾರಾಯಣ ಮೂರ್ತಿ ಅವ್ರ ಮುಖ ನೋಡಿ ಏನೋ ನಮಗೆ ಕೊಟ್ಬಿಟ್ರು ದುಡ್ಡು. ಅದು ಒಳ್ಳೆ ಕೆಲಸಕ್ಕೆ ನಾವು ಯೂಸ್ ಮಾಡ್ತೀವಿ ಅಂತೀವಿ. ಅದೇ ರೀತಿ ನಮ್ಮ ಚಿತ್ರದುರ್ಗ IMA ಭಾಳ CME ಕಂಡಕ್ಟ್ ಮಾಡ್ತಿದ್ವಿ ನಾವು. ಆಲ್ಮೋಸ್ಟ್ ನಾನು 2 ಇಯರ್ಸಿಂದ IMA ಪ್ರೆಸಿಡೆಂಟ್ ಆಗಿದ್ದೀನಿ. 10-15 CME ಕಂಡಕ್ಟ್ ಮಾಡಿದ್ದೀನಿ. ಅದರ ಸದುಪಯೋಗನ ನಮ್ಮ IMA ಡಾಕ್ಟರ್ಸ್ ಅಷ್ಟೇ ಅಲ್ಲದೆ ನಮ್ಮ PG ಸ್ಟೂಡೆಂಟ್ಸು, ರಿಮ್ಸ್ ಚಿತ್ರದುರ್ಗ ಸಿಮ್ಸ್ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ಸ್ಟೂಡೆಂಟ್ಸ್ ಸಮೇತ ಯೂಸ್ ಮಾಡ್ತಿದ್ದಾರೆ. ಅದೇ ರೀತಿ ನಾವು ಇದುವರೆಗೂ 3-4 ಬ್ಲಡ್ ಕ್ಯಾಂಪ್ ಕಂಡಕ್ಟ್ ಮಾಡಿದ್ವಿ, ಹೆಲ್ತ್ ಕ್ಯಾಂಪ್ ಕಂಡಕ್ಟ್ ಮಾಡಿದ್ವಿ. ಅದೇ ರೀತಿ IMAದು ಕೊರೋನಾ ಸಮಯದಲ್ಲಿ IMA ಡಾಕ್ಟರ್ಸ್ಗಳು ಫಸ್ಟ್ ನಾವು ಗೌರ್ಮೆಂಟ್ ಹಾಸ್ಪಿಟ್ಲಿಗೆ ಹೋಗಿ ನೋಡಿದ್ದೆ IMA ಡಾಕ್ಟರ್ಗಳು. ಇದೇ ರೀತಿ ನಾವು IMA ಇಂದ ಭಾಳ ಸರ್ವಿಸ್ ಮಾಡ್ತಾ ಇದ್ವಿ. ಇನ್ನು ಮುಂದೆ ಅದೇ ರೀತಿ ನಾವೊಂದು ಬಿಲ್ಡಿಂಗ್ ಕಟ್ಬಿಟ್ಟು ಅದರಿಂದ ಆಲ್ಮೋಸ್ಟ್ 60,000 rupees ಅಮೌಂಟ್ ಬರಂಗಾಗಿದೆ ಬಾಡಿಗೆ. ಸೊ ನಮ್ಮ IMA ನಮ್ಮ ಒಂದು ಹೆಗ್ಗಳಿಕೆ ಏನಂದರೆ ಇನ್ನು ಮುಂದೆ IMAಗೆ ಆಲ್ಮೋಸ್ಟ್ 1 lakhs per month ನಮಗೆ ಬಾಡಿಗೆ ಬರುತ್ತೆ. ನಮ್ಮ IMA ಯಾರನ್ನೂ ಸಹಾಯ ಕೇಳದಲ್ಲಿ ಇನ್ನು ಮುಂದೆ ಸಸ್ಟೈನ್ ಆಗ್ಬೋದು. ಆ ಒಂದು ಕೆಲಸ ಮಾಡೀನಿ ಅಂತ ನನಗೊಂದು ಹೆಮ್ಮೆ ಇದೆ. 60,000 ರೂಪಾಯಿ ಬಾಡಿಗೆ ಬರಂಗೆ. ಅದೇ ರೀತಿ ಮುಂದೆ ಬರುವ ಇದೊಂದು ವರ್ಷ ಮೋಸ್ಟ್ಲಿ ಲಾಸ್ಟ್ ನಂದು 2 ವರ್ಷ ಬಲವಂತಕಾಯಿ 2 ವರ್ಷ ಕಂಟಿನ್ಯೂ ಮಾಡಿದ್ವಿ. ನಾನು ಪ್ರಹ್ಲಾದ್ ಸರ್ ಇಬ್ಬರು ಕ್ಲಾಸ್ಮೇಟ್ ಬೇರೆ, ಹಂಗಾಗಿ ನಾವು ಬೇಡ ಅಂತ ಅನ್ನೋಕ್ಕಾಗಲಿಲ್ಲ. ಮುಂದೆ ಬರುವಂಥ IMA ಪ್ರೆಸಿಡೆಂಟ್ಗಳು ಮುಂದೆ ಒಳ್ಳೆ ಕೆಲಸ ಮಾಡ್ತಾರೆ. ಹಿಂದೆ ಮಾಡಿದಂಥ IMA ಪ್ರೆಸಿಡೆಂಟ್ಗಳ ಸಹಾಯದಿಂದಲೇ ಆ IMA ಬಿಲ್ಡಿಂಗ್ ಕಟ್ಸೋಕೆ ಅನುಕೂಲ ಆಯಿತು. ಇದು IMA ಆಕ್ಟಿವಿಟೀಸ್ ಹೇಳಿ ನನ್ನ ಮಾತು ಮುಗಿಸ್ತೀನಿ. ಆಯ್ತು.
Thank you, sir, for your wonderful presidential address. Every successful event is a result of dedicated planning, teamwork, and tireless effort. Behind this wonderful celebration stands a person whose vision, leadership, and commitment made all this possible. It's our privilege to invite our respected Dr. Narmurthy C. Sir, Head of the Department of Pathology, Director of Vasavi Diagnostic Laboratory Pvt. Limited, a Neuberg Associate, to deliver vote of thanks.
Seeking the blessings of His Holiness, it's a privilege to propose vote of thanks. ಸ್ನೇಹಿತರೆ, ಈ ಕಾರ್ಯಕ್ರಮ ಯಾವ ಥರ ಶುರುವಾಯಿತು ಅಂದರೆ, ಆ್ಯಸ್ ಯು ಆರ್ ಅವೇರ್, ಎವ್ರಿ ಇಯರ್ IMA is conducting Doctors Day program, and also Basaveshwara Medical College is conducting Doctors Day program. And we will be honoring the doctors who has crossed 60 years. And in Basaveshwara Medical College, based on the seniority, academic performance, we will be honoring the doctors. And also the doctors' kids who has scored distinction more than 90% in SLC, PUC, and also MBBS, MD final examinations we will be honoring every day in the month of July. So this time, the thought came to my mind that we from the Vasavi Diagnostic Laboratory and Neuberg Associate should host this program. So when this thought came, so I sent a mail to Sujay sir and Jairam sir, and also Elizabeth madam and Sitakan sir, administrative staff. Immediately, very next moment, I got an approval. So next I approached Palakshaya sir, who is having multiple roles, but concerned role in this is President IMA and also Medical Superintendent of Basaveshwara Medical College. Immediately they have agreed and they have given full support. So Rajesh sir, Basaveshwara Medical College Hospital Dean, and also all the entire team, it may be Nagendra Gowda sir and Yogendra sir, Medical Education Unit Coordinator. And we went to, let me not forget the hierarchy. We went to meeting before, announcing the invitation. We met KB Gudsi sir and also Ganachari sir. Immediately we told, we are telling you, doctor, do such many programs, call the speakers from outside, do the programs frequently. Then we had a departmental meeting. They, I thanks to my department colleagues, they gave, a complete freedom in selection of speakers and also selection of topics. Thank you for, imposing faith on me and trusting me. So this is how the program started. We from the Vasavi Diagnostic Laboratory, we are conducting CMEs once in 5 years. This is 4th CME in association with, IMA. This time we planned in a little bigger way. Thanks to Palakshaya sir and also, Prahlad sir, who is my mentor, and also Rajesh sir and all the team. If I start telling the name, I may miss many names. And also today, many renowned doctors got honored in this occasion. Renu Prasad sir, who is also batchmate of Palakshaya sir. Many doctors got honored. So thank you one and all. Thanks to my team. Thanks to my better of Vani. Will be tolerating my sudden ideas, coping with me, and also all my staff. If I forget any name, please, forgive me. And whatever I am today, let me tell you honestly, I should, accept that whatever I am today in the field of laboratory medicine, it is because of two people. One is Dr. Jairam sir, Dr. Sujay sir. Either you do the test by best method or follow the people who do the test by best methods. They are the one who has given, one big, respect to the field of pathology by their hard work, perseverance and consistency, and no compromise in the quality policy. So their words are very clear, and thank you for guiding me right from my PG days, sir. Thank you. Lucky to work under you, sir. Thank you, sir. And also thanks to Parvati madam, who has come all the way from Tumkur. Thanks to all the doctors, senior doctors who are sitting quietly. Thanks to speaker madam, who has come all the way from Gujarat, Bangalore, and Prajwal sir, who did a brain enhancing session yesterday. I could not attend properly. Before I conclude my talk, sir, I would like to thank administrative team of Neuberg, Elizabeth madam, Vice President, Sales and Operational, Business Unit Head, Karnataka and Kerala, Sitakan sir, Associate Vice President, Karnataka and Kerala, Lakshmi Narayan sir, Sales Head, Karnataka, and all the team members. I sincerely ask apology if I missed any name. And thank you one and all. Afternoon also, I expect same crowd. So please, I request a dignitary to accept the honor on behalf of organizers. Please, sir. Please come by one fast. I request good teacher Palakshaya sir to honor Sujay sir. To honor Sujay sir. Next, I would like to request Prahlad sir and Gudsi sir to honor Jairam sir. Next, please honor our Vice Chancellor sir. I request Palakshapa sir and Rajesh sir. Please honor Dr. Rajesh sir. Thank you, sir. Thanks for all the cooperation, sir. Next, please honor our one and only Palakshaya sir. Next, please, I request Jairam sir and Sujay sir to honor Prahlad sir. I request Yogendra sir, DS Ravindra sir to honor Basuraj sir. Next, I request, sir, same team. Next, I request to honor Dr. Nagendra Gowda sir. Ravindra sir. Next, I request Palakshaya sir and Rajesh sir to honor Dr. Ravindra sir, SP Ravindra sir. Sir, sons also got MD seat, medicine government seat in an ASAN. He was honored on the same occasion.
Dr. Prahlad sir, Palakshaya sir, Narayan Murthy sir ಅವರಿಗೆ ಆನರ್ ಮಾಡಬೇಕು ಅಂತ ಕೇಳ್ಕೊಳ್ಳಿ. ಯೋಗೇಂದ್ರ ಸರ್ ನಿಮಗೆ ಹಾನರ್ ಇದೆ ಸುಮ್ಮನೆ. ಈ ಕಾರ್ಯಕ್ರಮದ ಕೇಂದ್ರ ಬಿಂದು ಡಾಕ್ಟರ್ ನಾರಾಯಣ ಸ್ವಾಮಿ ಅವರು, ನಾರಾಯಣ ಮೂರ್ತಿ ಸರ್.
Thank you, sir. In behalf of everyone, we have not reached the lunch break. We invite you all to enjoy the authentic flavors of Karnataka cuisine. Wish you have a delightful meal. We look forward to welcoming you back after the meal.
ಆಯ್ತು.
Good afternoon, everybody. It's my indeed. I should congratulate Department of Pathology, Neuberg as well as the Basaveshwara Medical College and IMA on this auspicious occasion of Doctors' Day to conduct such a high-level CME. So I'm pleased to introduce Dr. Swati Kulkarni. She's a consultant pathologist and HOD, Immunopathology, Neuberg Reference Laboratory, Bangalore. She have a short-term senior residency in the Department of Clinical Hematology and Bone Marrow Transplantation in September 2008 to March 2009 at Fortis Hospital, Bangalore. And she has got observership at CMC Vellore Department of Transfusion Medicine in the Immunohematology Department from December 2022 to January 2023. And she is associated with Neuberg Anand since September 2000. It's indeed pleasure to hear you, ma'am. We expect to look forward a good CM in here.
Thank you. Good afternoon, everyone. Thank you for that kind introduction, sir. Without further ado, I think I'll go ahead with my topic. So I'm here to speak about immunopathology case discussion. This is about anti-nuclear antibody testing in systemic autoimmune rheumatic diseases. Plan of the talk is to briefly cover introduction to ANA, testing methods used, principles of testing, and the main focus would be on case discussion. Autoantibodies are a hallmark of autoimmunity. ANAs are the most relevant autoantibodies present in systemic autoimmune rheumatic diseases. There are different methods to assess ANAs. Earlier it was ELI cell was used, and currently what is most commonly used is HEP2 cells by indirect immunofluorescence, and solid phase assays have been developed to study ANA-associated SARS. So the flow chart that is recommended or what is usually done is ANA testing. Initially, it is done by screening, and there is confirmatory method. For screening, there is ANA by indirect immunofluorescence, which is the gold standard. And we also use solid phase assays such as ELISA or CLIA. And for confirmatory line blot assay, which is most commonly done, there are also monospecific ELISAs, which are less commonly requested. So whenever there's a clinical suspicion of SARS, screening is done either by ANA indirect immunofluorescence or CTD screen, which is ANA by CLIA. And if either of these two comes positive, a confirmatory test is recommended, usually by ANA blot. Screening ANA by indirect immunofluorescence is the gold standard, and HEP2 cell is the reference screening method for ANA in SARS. So these cells that are seen in the image are HEP2 cell substrate. These detect autoantibodies against nuclear, cytoplasmic, and mitotic antigens. Although we call it ANA, anti-nuclear antibodies, historically it has been called as ANA. But now we know that the antibodies are not directed only against the nuclear, but also against the cytoplasmic and mitotic compartment of the cell. So currently the terminology which is recommended by certain bodies is anti-cell. But since ANA has been in use in such a long time, ANA is still continued to be used. A positive screen is suggestive of not just the positive screen, along with the right clinical context is suggestive of connective tissue disorder. So it is used to diagnose various connective tissue disorders such as SLE, systemic sclerosis, Sjogren's, mixed connective tissue disorder, etc. So why do we use these HEP2 cells as substrates? Because they have large nuclei, they have high mitotic activity, so we can study these cells in the interphase and metaphase, so where the cells in dividing and non-dividing state, which gives us information on the target antigen. It has abundant intracellular antigens and has distinct fluorescence patterns.
principle is indirect immunofluorescence. This is the HEP2 substrate, which has the antigen. Primary antibody, which is present in the patient serum, binds to the antigen. And to detect the primary antibody, we have a fluorescent labeled secondary antibody, which is called as conjugate. And excitation at specific wavelength makes this immune complex fluoresce under the microscope. And this is how it appears under the microscope. So these are HEP2 cells. There are two substrates to study ANA. HEP2 cells, and this is the primate liver. Primate liver was used earlier, but currently HEP2 cells is considered the gold standard. But primate liver also gives us information, and these act as complementary. So both are studied together while we report the cases. ICAP is international consensus on ANA patterns. It has divided, this is to bring a standardized way of reporting ANAs. This is divided into negative, nuclear, cytoplasmic, mitotic, and recently there is a class called as unclassified, where certain patterns that don't fit into any of these defined classes are being classified as ACXX, which is unclassified. We have not reported these patterns yet. So AC0 is negative, and there are classes up to AC31. It covers nuclear, cytoplasmic, and mitotic. Nuclear antibodies are the most commonly encountered ones in clinical practice, and which have definite clinical associations or most studied antibodies. And the way we report ANAs is IF pattern is reported along with beginning titer and endpoint titer. It is very important to report that. We use this AC nomenclature to report our cases. Reflex and confirmatory tests recommendation is given, and autoantibody associations are mentioned. These are all different patterns that we come across. These are the three most common patterns: nuclear speckled, homogeneous, and AC30, which we report most commonly, which we have reported most commonly according to our recent data. So this table talks about the various patterns which are present. There are many more. I've just highlighted a couple of them, and associated AC codes and key target antibodies. So whenever we report these particular patterns, these particular antibodies are suggested, and they come with typical disease association. With all this advantage, HEP2 cells also has a limitation with high inter-observer variability and low specificity. And HEP2 cells might miss presence of certain antibodies such as SSA-Rho, Rho52, ribosomal P proteins, or Jo1. So to overcome this limitation, we also use ANA-CTD screen, which is ANA by CLIA method, which it is a solid phase ANA screen. It uses a defined mixture of certain antigens, clinically relevant antigens, and it is reported as index. A numerical value is given. Less than 20 is considered negative, and more than 20 is considered positive. It is objective, reproducible, and there's high throughput. And this helps us in picking up certain antibodies which IF might miss, but limitation being it detects only the antibodies represented in its antigen panel and can miss rare nucleolar or cytoplasmic specificities. So it is recommended to use both as screening method. And according to our recent data, using IF and CTD as a parallel screen improved our specificity and sensitivity tremendously. So we report our screen cases by IF and CTD, both methods, and our study has shown that that has improved the sensitivity and specificity tremendously. This was about screening assays. Confirmatory assays are usually done by solid phase immunoassay. IF tells us if ANA is present and what pattern, and solid phase assays tells us which specific antibody is positive. So a positive IF or a negative IF with strong clinical suspicion is followed by a solid phase assay, and SPS determine the exact autoantibody specificity behind the pattern. And there are different solid phase assay types which are present: line immunoassay, ELISA, and enhanced ELISA. Line immunoassay is the most commonly requested confirmatory test. It is also called as ANA profile or ANA blot. Now, this is how the line immunoassay picture looks like in the report. These test strips are coated with multiple. So these are the number of antibodies that can be tested at once as a confirmatory test in these patient samples. Test strips are coated with parallel lines of highly purified antigens. So here we can see this is shown positivity, which corresponds to RNP Smith. So patient IgG antibodies bind to their corresponding antigenic line, and with the help of enzyme reaction, a dark band, a color formation is noted, which indicates a positivity for a particular antibody if present in patient sample, and it is graded, intensity is graded as per antigen from 0 to 3. Now, with this introduction, I'll quickly just go through a couple of cases that we have encountered. So first case was a 23-year-old female with fever, cytopenias, joint pains, and rash. And this was the ANA pattern that we encountered. This is a homogeneous staining of the nucleus in the interface cells. Please don't worry about identifying the particular pattern, because at once it might seem a bit confusing and daunting. But as we keep seeing these patterns, it becomes easier for us to recognize. So this is the AC1 homogeneous pattern, where in the nucleus, if you can observe, the homogeneous entire nucleus is homogeneously stained, along with these metaphase plate being positive in dividing cells. So this is what we call as homogeneous pattern. Now, what do we and this is how we report. So CTD in this case was strong positive, and it was AC1 nuclear homogeneous pattern. Now, what does it mean if we see this pattern? We also look at each compartment of the cell and report it individually, so that we don't miss any component of the cell. So each of these components are looked at, and we give antigen association. So whenever we see this particular pattern, dsDNA, nucleosomes, or histones are the most commonly encountered antibodies. And because of these particular antibodies, which are a part of the nuclear chromatin, we see this particular pattern. Clinical relevance, whenever we see this pattern, is it can be associated with SLE, chronic autoimmune hepatitis, or juvenile idiopathic arthritis. And we also begin the test with initial titer of 1:100, and a supplementary report depending on the intensity is given later. And in this particular case, it was of high antibody titers, more than 1280. So clinical relevance of this particular pattern is found in patients with SLE and autoimmune hepatitis or juvenile idiopathic arthritis. So depending on the clinical presentation of the patient, the next step is to be taken. So if SLE is clinically suspected, it is recommended to perform a follow-up test for anti-dsDNA antibodies and the other antibodies. And the test that commonly is done as confirmatory is ANA profile. If anti-dsDNA antibodies are positive, it is associated with lupus nephritis, and their levels correlate with disease activity. Nucleosomes and histones are associated with drug-induced lupus. Whereas if the clinical presentation doesn't fit SLE, and if it is arthritis or autoimmune hepatitis, then we don't really recommend doing there is no test to confirm that. So if clinically it is either of these conditions, a follow-up test is not recommended. So clinical history is crucial. Now, in this case, there was also, this test is called as Crithidia lucile. The substrate here is Crithidia lucile, a flagellate organism. This is used to test for dsDNA by indirect immunofluorescence, which is very specific for this antibody. And in this particular case, so we had AC homogeneous pattern, and dsDNA was positive by this particular test. And in blot, dsDNA was negative. So blot also was requested, and dsDNA was negative. So discordant test results. So one test is showing positive and the other test is showing negative. So we got a query, what do we do in this case? Do we consider it positive or do we consider it as negative? So how should these results be interpreted? This is where interpretation requires an understanding of sensitivity and specificity of each assay. So ANA blot has its limitations, that it is not very sensitive to pick up anti-dsDNA antibodies. So in these cases, Crithidia lucile, or there is also dsDNA testing by ELISA, which is considered a much more sensitive option, and we repeated the test and it was positive on another platform. So understanding the sensitivities and specificities of the SS becomes important. So this was a case of SLE. Now, 35-year-old female had a difficulty in swallowing, itching and hardening of lower limb skin. And this was a particular pattern that we observed on IF. And these, unlike the previous pattern, which was homogeneously positive, we can see distinct dots being present in the cells. This is known as centromere pattern. Around 40 to 80 distinct dots are observed in the cells. And this is commonly associated with limited cutaneous systemic sclerosis, and it can also be seen in PBC. So we did a blot for this particular case, which also showed centromere pattern. Now, for this particular antibody, if IF is positive, blot is generally not sufficient. So this particular pattern seen on IF, a confirmatory test is not really recommended. So this was a case of limited cutaneous systemic sclerosis. 34-year-old female with back pain, fever, and joint pains. And this is a pattern which we call as DFS 70 pattern. Now, unlike homogeneous, we can see that these showing speckling in the nucleus. And this is known as DFS, nuclear dense fine speckle. CTD in this particular case is negative, because it is not a very clinically relevant antibody, and hence it is not part of the component of CTD panel. So IF can be positive of high intensity, high titers, but if it is of this particular pattern, it is not of any clinical significance. In fact, this can be seen in healthy individuals. So blot also showed anti-DFS70 antibody positive. And if we see this particular pattern, recognition of this pattern is important, because isolated DFS70 antibodies are generally not associated with autoimmune disorders, and these patients will not require any further evaluation. 12-year-old female had fever on and off, pain abdomen, splenomegaly, bicytopenia, generalized lymphadenopathy, and also had triple positive APLA. So clinically, this there was a high clinical index of suspicion of SLE in this particular patient, and a blot was sent to us. If you can observe this, there's a dark background observed here. So this is something in the patient serum which is interfering with the test results. So we don't rely on the test results when we see this particular background. But also control band was positive, but no other antibodies was positive. So we got a call from the clinician saying, clinically this is nothing but SLE for us. How come there's no antibody positive, and what do we do next? Then what we asked was IF done in this particular case? And the clinician said, no, we had not done IF, because confirmatory, they were so sure that it is going to be SLE, they did blot right away. And that is not really recommended. So we did IF in this patient, and IF actually showed homogeneous pattern of moderate titers, moderate to high titers of 1:640 dilution. Now it is important. So there are IF negative SLE cases, but it's very rare. So around 98-99% of SLE cases should be IF positive. And that is the entry criterion for classification of SLE. It says positive ANA test at a titer of 1:80 by IF, or an equivalent positive test at least once should be present. So the classification doesn't talk about blot being positive. In the right clinical context, IF being positive and blot negative is still considered significant, and this case can still be defined as SLE. And it turned out to be a pediatric SLE. So 3-month-old female with acute metabolic crisis with myocardial dysfunction showing AV block and a rash on face. We received the sample for ANA testing. It is very unusual in this age group to receive sample for ANA testing. And we did the test, and it showed nuclear speckled fluorescence, and so this was nuclear speckle, and surprisingly CTD also was strong positive in this case. So this nuclear speckle positive and CTD strong positive is suggestive of an autoimmune disorder, but the age group was unusual for us. and these are the associated antigen antibodies. So the clinician, along with the baby sample, also had sent mother sample to us. So mother was asymptomatic, but mother sample also showed a similar pattern of nuclear speckle, and CTD screen also was positive and strong intensity of nuclear speckle, high titer antibody positivity. Blot was requested for both of them, and the baby sample showed SSA and SSB positivity, and the mother sample also showed positivity for the same antibodies. So when SSA or SSB are associated with Sjogren's syndrome, SLE, and neonatal lupus erythematosus, which presents commonly with congenital heart block. So this was a case of neonatal lupus erythematosus. So NA positivity in a neonate should raise suspicion for neonatal lupus erythematosus, and mother sample should be tested even if asymptomatic. 7-year-old male, skin rashes, photosensitivity, difficulty in climbing stairs and lifting objects. We saw a similar nuclear speckle pattern in this patient as well. CTD screen here was negative, although nuclear speckle pattern was positive. So it's important for us to remember that the CTD screen doesn't comprise of all the antigens. So it may not have certain antigens, and it is important to know the components of the antigens of the CTD screen. And this, we cannot really disregard the results just because one is negative or one is positive. So in fact, it helps us in arriving at a diagnosis. And ANA profile, high titer was there. ANA profile was negative in this patient, but clinical findings were significant. So what next? So the clinician next requested for myositis profile. So although ANA profile was negative, myositis profile showed Me2 beta antibodies. Now again, going back to the history, it becomes important to take the step on what confirmatory test should be requested based on the clinical presentation. So it was a 7-year-old male, skin rashes, photosensitivity, difficulty in climbing stairs and lifting objects is suggestive of myositis than SLE. So although ANA profile was negative in this case, myositis profile showed Me2 beta antibodies, and these are also part of, this also can show a nuclear speckle pattern. And it is suggestive of, it is a myositis specific autoantibody suggestive of classic dermatomyositis with rash and all present. So clinical findings together with IF pattern should direct the choice of confirmatory serological assays. So 77-year-old male had bilateral swollen feet with painful, poorly healing lower limb ulcers since 1 year. This was the clinical presentation. History of progressive skin tightening of hands and forearms was noted, and dyspnea over several months. Biopsy showed leukocytoclastic vasculitis, fibrin deposits, neutrophils, and no granulomas. Echo showed moderate pulmonary artery hypertension. DDs were vasculitic ulcer or pyoderma gangrenosum. Creatinine was very high in this patient, and certain autoimmune tests were requested. This was the pattern that we observed. It might appear very subtle and might appear like homogeneous and nuclear speckle, but on close observation, it is a very complex pattern comprising of nuclear speckle and metaphase plate positive, cytoplasmic positive, and I'm not sure if you can appreciate, but nucleolar rim is also positive in these cases. This is a very typical appearance, and CTD also was positive of AC29 pattern called as DNA topoisomerase 1. And a blot also showed similar positivity. This particular pattern is highly specific for systemic sclerosis, in particular with diffuse cutaneous systemic sclerosis and more aggressive forms. Interestingly, in this patient, MPO-PR3 also was requested, and MPO was positive. So this is not something we commonly encounter, ANA and ANCA coming positive together. But when we discussed the case and read further, there's a component, there's an entity called ANCA-associated vasculitis. So it was a case of systemic sclerosis along with ANCA-associated vasculitis. Now it is important to differentiate. So systemic sclerosis, if you remember, the creatinine was very high in this patient. So systemic sclerosis patients can go in scleroderma renal crisis, or it can be a compound ANCA-associated vasculitis. It becomes important to differentiate these two entities because management differs. So this was a case of diffuse systemic sclerosis with ANCA-associated vasculitis. I think I'll just skip the next two cases and probably go to the last case. Yeah. So it was a 49-year-old male presenting with multiple joint pains and swelling since 4 months, generalized tiredness and breathlessness since 1 week, which worsened in a day. So it was a case of sepsis with septic shock and MODS. Patient also had bilateral pneumonia, pulmonary thromboembolism, and DVT, multiple, a very complex case, and patient was doing very bad clinically. Because of pneumonia, cultures were sent and no organisms were detected. Autoimmune workup was requested, CRP, ANA, and because of thromboembolism, thrombophilia profile also was requested. This was a pattern that we saw on IF. It is not something, initially we thought if this is something non-specific because it is not a common pattern that we encounter, and it just appeared like vague speckles throughout the cell in the nucleus and cytoplasm both. So we had requested for history because we couldn't finalize which particular pattern it was. And I think we ultimately ended up calling it AC 19 or 20. We weren't sure which one. And it was also very low intensity, 1+. But if we look at CTD was very strong positive. So that made us not ignore the pattern and in fact pay attention to what we are seeing. We called it 19 or 20 with associated these particular antibodies, and further testing was ANA profile or myositis profile in correlation with clinical details based on this particular class and antibodies associated. So ANA profile picked up Rho52 and Jo1. And thrombophilia profile also was requested for this patient. Patient was in septic shock. All three protein C, protein S, antithrombin 3 were reduced. So in inherited thrombophilia profile, we don't expect all the 3 proteins to be reduced. So firstly, it shouldn't be done so immediately after a thrombotic event because all these factors would be consumed. And patient's CRP also was very high. It was 25. And this CRP also causes interference in lupus anticoagulant testing and causes falsely reduced protein C, protein S antibodies. So we gave a note that all 3 levels could reduced could be because of acute thrombotic event or sepsis. And APLA workup otherwise was negative in this case. So with the IF pattern that we saw and the history that we got later and CRP high and antibodies, the particular antibodies that we observed. So it fit into a classical triad, and all 3 were noted in this case of arthritis. Patient had polyarthralgia swelling since 4 months, ILD, acute, which is interstitial lung disease, acute ARDS like pneumonia with culture negative workup, and myositis. Although clinically it was not mentioned if myositis-like features were there, but these antibodies, Rho52 and Jo1, are specific for myositis, and these antibodies were positive. So this was a case of antisynthetase syndrome with rapidly progressive ILD, and we unfortunately lost the patient. So to summarize, clinical history is crucial and confirmatory test should be requested based on the initial IF pattern and clinical findings. Interpretation of results requires an understanding of sensitivity and specificity of each assay. And certain antibodies like anticentromere antibodies, IF pattern is sufficient, blot is not really necessary in the right clinical context. And recognition of DFS 70 pattern is important because these are seen in apparently healthy individuals and further workup is not really recommended. Clinical findings together with ANIF pattern should direct the choice of confirmatory serological assay, and always remember IF first, screening first, and then blot. Thank you. My gratitude to Jairam sir, Sujay sir, and Narayan Murthy sir for giving me this opportunity to speak, and Basaveshwara Medical College Chitradurga, my colleagues and patients. Thank you.
In recognition of this inspiring session, I respectfully invite our esteemed chairpersons to kindly honor our distinguished speaker, Dr. Swati Kulkarni ma'am. Does anyone have any questions?
Indeed, it's a nightmare for so many clinicians to have so many tests and ambiguity regarding the diagnosis. In that, this is an eye opener. It's a wonderfully done, and so many case illustrations has been done. It has cleared so many of the doubts. So I should congratulate you for the lucid presentation what you had. Any questions from the audience?
Madam, it was very nice presentation.
Thank you,
Actually, it is least touched topic.
Yes.
You have done it, worked up so well. Actually, I feel more postgraduates should have been attended this session. It would have been nice rather than. It was very nice presentation, madam. Thank you.
Very nice presentation. Thank you, sir. Thank you. Thank you.
Yes. Yes. Thank you.
Our sincere appreciation to our esteemed chairpersons for the guidance and encouragement throughout this session. May I now invite Dr. Sudhindra sir to kindly come forward and do the honors by felicitating our respected chairpersons.
As we enter the final scientific session of today's CME, we conclude our academic journey with a topic that has the potential to transform lives from the very beginning: newborn screening. Early detection is not just about diagnosis, it is about giving every newborn the best possible start in life. To chair this session, may I respectfully invite our esteemed chairpersons, Dr. Shiv Kumar sir and Dr. Suman sir, to come forward and grace the dais. It is now my privilege to invite our distinguished speaker, Dr. Prajwal sir, Head of the Department of Biochemistry and Chief of Laboratory, Neuberg Reference Laboratory, to kindly take the podium and deliver today's lecture on newborn screening. Ladies and gentlemen, please join me in welcoming our eminent chairpersons and our distinguished speaker to the dais. I would like to request one of the chairpersons to introduce our speaker.
Hello. Indeed, it's my honor to introduce Dr. Prajwal A, Chief of Lab and HOD Biochemistry, Neuberg Reference Laboratory, Bengaluru. He has expertise in clinical diagnostics, advanced biochemistry, NABL accreditation, automation, quality management, and oversight of high throughput reference labs, leadership in and also in process optimization, HR and resource balancing. Technical skills, he immunoassays, protein electrophoresis, material screening, maternal screening, therapeutic drug monitoring, LCMS, CRISPR, molecular diagnostics, and he has been chief of lab and HOD of biochemistry since 2024. Before that, he was consultant and HOD at Agilus Diagnostics at Fortis from 2021 to 2024, and cluster head. In Niemann's, he was senior assistant, quality coordinator 2019 to 2021. He was also a senior assistant in the Institute of Liver and Biliary Sciences. So, and LCMS implementation 2018 to 2019. He has an MD in biochemistry and distinction in biochemistry and anatomy, researches and publications, tumor markers, ovarian malignancy diagnostics, microbiota in cancer, e-learning in medicine. And he is an invited speaker for electrophoresis, Six Sigma, AI in diagnostics, LCMS workshops, international CME events. So a lot of experience. Kindly enlighten us on the newborn screening so that which is very needed. Thank you.
Thank you, sir. There is slight change in my topic. Along with newborn screening, we have added evidence-based lab reporting from guidelines to practice. So how recent guidelines from ACC, HA, ADLM and European Society, how we adopted and we also incorporated into our reports. So mainly I will be focusing on lipids, cardiac markers, a new syndrome that has come up, cardiometabolic, kidney, newborn screening and hypertension screening. So first, one of the ADLM guidelines is lipid profile should be a clean report. As soon as the clinician sees, you should be able to pick up what is the issue, where we have to start. So initially, all the guidelines used to recommend to give 3 cutoffs for each value, like intermediate risk, low risk, high risk. So they wanted to eliminate that, give a single cutoff for each and every parameter. And lipid profile should mandatorily have all these 5 tests: total cholesterol, HDL, triglycerides, LDL cholesterol, preferably calculated. We'll come to that afterwards. And non-HDL cholesterol calculated. If you see that 3 will be a measured parameters, 2 will be the calculated parameters, and all should have single cutoff. So before implementing this guideline, our report used to look like this. So each parameter having 3 to 4 cutoffs, 3 to 4 differentiations, optimal, and it is very difficult to flag what is abnormal, what is normal. Once we implemented the guidelines, we also went back to single cutoff, and we also started reporting only 5 necessary parameters instead of all the parameters. So the report started looking like this with single cutoff. So any clinician in his busy work, he can directly identify what is the issue, where to pick and what to do. So that is one important guideline while reporting lipid profile. It should be a single cutoff and only required 5 parameters, 3 measured and 2 calculated parameters to be reported. So next, coming to specifically to the LDL cholesterol. So there is a long ongoing, though the beta quantification is a gold standard from last 40 to 60 years, but it couldn't be adopted to routine clinical practice because it takes almost 24 hours to just process LDL, and it is very tedious process. You have to centrifuge the sample for almost 18 hours in ultracentrifuge with utmost care. So that is why it never came into clinical practice. But Friedewald formulas, which came in 1972, is being still used, though it is not recommended. And many companies came with direct LDL cholesterol from last 15 to 20 years, but none could match the beta quantification method. So recently, in last 5 years, around 3 formulas came up. One is Martin Hopkins, and extended version for Martin Hopkins, Samson IH, and a modified Samson IH, totally 4 formulas. So depending on the LIS, this thing, you can adopt. So we wanted to adopt Samson's, one of the Samson formula. So we didn't directly adopt that. We first validated against our last 10 years data. We pulled out our last 9.5 lakhs lipid profile data, and we applied the statistics, and we compared to the beta quantification. So if you see, So the black thick line is the beta quantification. The closer to your beta quantification, your LDL value superiority increases. If you see the green line, modified Samson has the least bias compared to beta quantification, only 1.59, whereas Friedwald had anywhere between 9.5 to 11.9. Why this becomes critical? So LDL reduction treatment, the cutoff is around 100. If a patient is being reported under 90, actually who is above 100, who has to be started on statins, those cases may get missed if you are using direct LDL or Friedwald. Whereas modified Samson has only bias of 1.59, so we'll less likely to miss any cases. So, but what does the guidelines say? Now guidelines, this is come in ACC 2026, almost 11 cardiac associations came together and gave a level 1 recommendation that in any adults and children who have undergone standard lipid profile, you should use Martin Hopkins or Samson equation over Friedwald in first point. In other second point, same Martin Hopkins or Samson is preferred over even use. It should be stopped and we start using Samson NH or Martin Hopkins formula to estimate LDL so that risk stratification of the patients becomes corrected. So next, in the same lipid profile, in the same guidelines, there was something was recommended to flag who are all have risk for familial hypercholesterolemia. So how to flag? So previously there were many criteria to identify familial cholesterolemia with multiple points, but now it is a single cutoff. If LDL more than 190, suspect heterozygous familial hypercholesterolemia. Only thing is screen LPA before going to genetic test. If LDL is more than 330, straight away genetic testing can be done for homozygous FH. So before going to genetic test in LDL cases or high LDL cases, always LPA is recommended. At least once in a lifetime, everyone should test LPA. It is an inherited genetic risk you can identify by simple blood test and very cost effective. So if you see, we started flagging whenever LDL is more than 190, we recommend first measure LPA before considering genetic testing, as increased LPA can also contribute to LDL and increase independently cardiovascular risk. So if it is more than 330, we straight away recommend to go to genetic testing, mainly 3 genes, LDLR, that is LDL receptor gene, ApoB gene, and PCSK9 gene. So if 3 genes are covered, most of the familial hypercholesterolemia homozygous FH gets covered. So we went back and checked our existing data. Does our population have that case? So if when we saw almost 2.25% of our profile fell into heterozygous FH and 0.01%, that is almost 94 cases came into the category of homozygous FH. So there is a population who are having heterozygous FH and homozygous FH. Why it is important to identify? So one is the index case can be treated. The most important is cascade screening. Earlier to identify the LDL high values, the better the risk come down. So LDL is a cumulative risk parameter. More the duration of your lifespan you have higher LDL, you have the higher CVD risk. That is where the genetic testing comes into play. So next, after this, the same association, 11 association came up with CKM syndrome. This is a new terminology that has been introduced 2026. What they are planning to replace is, previously there was a guidelines to manage overweight and obesity in adults. That has been replaced with now as cardiovascular kidney metabolic syndrome. Why this has been done is, all these patients who are obese, overweight and have metabolic disease generally have both cardiovascular disease and renal disease. So they want to manage all these 3 together. So it has been named as CKM syndrome and has been replaced both overweight and obesity guidelines. So what with respect to lab they identified is, they have identified 5 to 6 markers which can be used for the staging of CKM syndrome. First, start with high sensitive troponin, not all the troponins, only high sensitive cardiac troponins, both T and I, NT-proBNP, HSCRP and USCR, and all came with clear cutoffs. For example, if you take troponin T, women 14, men 22. This is not MI cutoff. This cutoff is below the MI but above the normal levels. It is in between the normal levels and MI levels. though that is becomes 50th percentile to 99th percentile. Once it crosses 99th percentile, it becomes MI. Whereas NT-proBNP more than 125 pg per ml, for HSCRP more than 2 mg per liter. Before flagging HSCRP, recent infection should be ruled out, and USCR more than 30 mg per gram of creatinine. Along with that, routine creatinine EGFR, preferably cystatin creatinine combined EGFR is preferred. If that is not available, only creatinine EGFR by enzymatic method is preferred. So how they classified? Into 4 stages. Stage 0 is no risk factors, that is normal BMI, no hypertension, glucose lipids are within normal limits. Stage 1 is you identify higher BMI. Stage 2, your HbA1c start increasing, triglycerides started increasing. Stage 3, where our all cardiac markers, which I showed in previous slide, will start increasing. And stage 4, you have eventually EGFR less than 60 and cardiovascular disease in progress, either as coronary heart disease or as heart failure, or you may have seen stroke or even renal failure at stage 4B. So this is where lab plays a role, because entire staging is dependent on the mainly 4 parameters along with creatinine EGFR. So this also they recommended a heat map where both dual EGFR, that is coming from cystatin and creatinine, along with urine albumin creatinine ratio, to do the heat mapping and CKD staging, which will be very useful in the clinic, which we are currently working, and soon we will be having it in our reports. So the another one which is more neglected because the availability of the state, that is aldosterone renin ratio. So in renin also there are 2 tests available. One is renin activity and another one is direct renin. Now current guidelines recommends one of the tests can be used. So whom to test? Whoever is having hypertension, age is less than 40 years, resistant hypertension regardless of potassium values, persistent hypokalemia, obstructive sleep apnea, incidental adrenal mass, and early onset hypertension family history, all should get tested. And how it works? So in all guidelines, you will look only into the ratio. Only in ARR, you look into the primary first value and second value. That also should meet the criteria. Then you have to look into the ratio, though all the 3 line items should meet the criteria. I will show an example. So this was a case of 28-year male who presented with 2 consistently BP readings on consecutive days, and secondary hypertension is suspected. If you see, so aldosterone should be more than 277. In this case, it is 800. Renin should be less than 8.2. In this case, it is 6. And ratio should be more than 70. In this case, it is more than. Even one doesn't meet criteria, then it doesn't fit the diagnosis of primary hyperaldosteronism. So all the 3 should meet the criteria. Then only you can consider for primary hyperaldosteronism. And also, while collecting the sample, you need to be remember it should be before the start of antihypertensive reagents. Sample should be collected in upright position after 2 hours of rest, and electrolytes should be within the range when this test is being done. So with how we implemented clinical guidelines, I am now going into newborn screening. So in newborn screening, I am going to highlight evolution, what is the prevalence and burden in India, pre-analytics that needs to be taken care, and genomic NBS. So in global, the NBS, everyone would have done in first MBBS, Guthrie test for PKU. That is the first NBS test that was started in 1960, though it was not done on dry blood spots. Then in 1990, LCMS has come into diagnosis for NBS. From 2003, ACOG started updating their panels for NBS screening, the first panel RUSP. The last update was come in 2025, which covers 38 conditions, 26 secondary conditions. Recently, they have added infantile Krabbe disease also to the list. How the screening test works? It should fall all the 4 points and it should fulfill all. If you are detecting a disease, then treatment should be available. If you start early treatment, you should be majorly avoid the disease illness. Then routine observation or examination will not reveal the disorder in a newborn. So definitely a test is required. and it should be the rapid and economical. You should be able to get as quick as possible. It should be highly sensitive. That means no false negatives. It could be reasonably specific. Few false positives are acceptable because you will be doing a confirmatory test, level 1, level 2 confirmatory test once you get any positive in NBS. So in India, IIC Bangalore in 1980 started the first NBS test. So it was amino acid disorders by TLC, mainly to pick phenylketonuria. Then 1991, ICMR started screening only for metabolic disorders, whoever have mental retardation. Then in 2003, Hyderabad actually started the newborn screening for congenital hypothyroidism, congenital adrenal hyperplasia, and hyperhomocystinemia. Then 2004, all commercial labs came into picture. 2007, two institutes, NIMANS and MAMC, started a proper NBS 5 and 7 profiles. 2011, India's National Neonatology Form recommended 3 disease screening for NBS. And from 2015, from till now, we are consistently getting guidelines for IAP based on categorization A, B, and C, what test to be done in what group. So how is the testing in India compared to the global group? In compared to US, we are doing less, but it is slowly increasing. So in 2020 till we have screened almost 7.5 lakhs per year. But now during COVID, it drastically dropped down. Post-COVID, it has consistently increased due to the awareness among all the clinicians. Almost 48 per 10,000 live births, NBS positive is being seen when this was published in 2024. So if you see 2024-25, it is almost double now number of cases being screened. So number of positivity will increase in India because previously we are under screening. So surely this will help in diagnosing the diseases very early. So in India, this is the overall population. If you go to specific population, the dominant disease may same. In overall population, PKU was the most common when at India level it was seen. And second most common was organic acidemia and fatty acid, and G6PD coming in third place. But when we came to regional perspective, this study was done by BMCRI in 2016 to 18. The dominant disease was G6PD galactosemia. The same was also reflected in our lab data. The dominant was G6PD deficiency and congenital adrenal hyperplasia. This is our last 5 years data. The top one was being G6PD and the second top was CAH. So with this, how do what pre-analytical issues can give false positives? One is type of the card being used. Every lab would have standardized to the card which they provide for their testing. So if you use the one lab card to other lab card, the standardization may distort and may have a trouble in the reporting. Next, always capillary sampling is preferred for NBS. But if venous sample has been collected for some reason, that should be notified to the lab so that G6PD correction may have to be done in these cases. And best time to collect the sample is 48 to 72 hours. But because of the discharge requirement and all, still 24 to 48 hours is preferred, but not less than 24 hours. Then storage and transport, it should never expose to sun. It should be put properly into the pouch and it should be sent to the lab within 24 hours and it should be stored in -20 degrees. Many places, if they identify this thing, they start on formula. Before that itself, the sample should be collected. And in preterm and low birth weight babies, high 17 OHP can be expected. So with the same conditions, if not followed, same we'll get same false positive, false negative, which we explained in the previous slide. So once comes positive, what to do next? There are level 1 and level 2 testings. In case of IRT only, the repeat IRT is advised. In none of the cases, repeat in dry blood spit is not advised. So whereas if it's CH, if it comes positive, straight away 17 OHP serum levels can be looked. If CH, that is congenital hypothyroidism, comes positive, straight away FT4 and TSH serum levels can be looked into. If G6PD comes positive, whole blood G6PD levels are advised. In galactosemia, GALT enzyme activity is recommended. And for PKU, confirmation with LCMS phenylketonuria is advised. Genetic testing is mainly recommended in IRT for CFTR gene. With if variant is suspected, then level 2 CFTR sequencing is recommended. So this is for normal babies get delivered. If there is a ICU babies or sick babies, how to collect? Routine is 24 to 72, preferably 48 to 72, which I do. If infant is sick or being shifted to NICU, preferably before to the shifting of NICU, one sample should be collected. After that, the repeat sample should be collected just before 7 days or at the time of discharge or 28 days, whichever is later, that should be done. And one more important is if there is a plan of transfusion, even though if it is less than 12 hours of 10 hours, first sample should be collected. Then post 48 to 72 hours of transfusion, one more sample has to be collected. So we also started, apart from routine 7 diseases, amino acid disorders, mainly to pick this PKU and tyrosinemia type 1 and homocystinuria, and also acyl-carnitine disorder, mainly medium chain fatty acid disorders, which is more common. So these two are done on currently LCMS, whereas all the 7 tests are done on fluorescent immunoassays, FIA. So apart from this, what else to be screened in newborn? One is hemoglobinopathies, which needs to be screened without missing. This currently we are doing on LCMS. This was in-house developed test by Dr. Deepa Lakshmi and team. So mainly to pick variants HBS, E, C, D, Punjab. So LCMS is highly sensitive instrument used for even amino acid screening or hemoglobinopathies. So this is how the proteins appear on LCMS like chromatograms. So with this we can screen all this HBS, E, C, D, and globin chain analysis also is being done in our lab. So to summarize, lipids, single cutoff should be used and only 5 required parameters to be reported. Auto flag wherever FH is suspected, and to prefer Samson formula over direct LDR or free Edward. Cardiac risk estimation to be done using troponin I, proBNP, HSCRP, and USCR. And wherever EGFR is being done, it should be combined both creatinine and cystatin C EGFR. Newborn screening, at least DBS 7, that is primary 7 parameters should be offered. If required, along with TMS of amino acids and acyl-carnitine should be done. And for hypertension screening, all the 3 parameters, that is aldosterone, renin, and AR ratio needs to be considered. Thank you for giving this opportunity. Thank you.
Any questions in the audience? It's truly appreciated. Thank you, Dr. Pazwal sir, for an enlightening and an inspiring session.
Thank you, sir, and it was a wonderful experience because I'm from microbiology. I know that all those quality things in biochemistry, they take so much time and so much, and also all those. Thank you for everything. Thank you.
Just I wanted to tell actually, I worked abroad actually for 10 years. So there the newborn screenings are like quite routine actually. As soon as they're born, like they have the very strict and stringent to like follow like as soon as the baby is born within 72 hours, like even like paramedicals, they necessarily like would take the samples and send it across actually without fail. So here like is there any streamlined or is it just private to like
very few state guidelines have started implementing. Not all states have implemented. Few states are mandating this currently.
So it is just initiation from the doctors.
Yes.
And, like clinical suspicion.
No, sir. Now so most of the private hospitals are getting done for all the babies born in their hospitals. But government mandate is currently in 3 to 4 states, not in all the states.
That's really the thanks for all the labs because now the like wide range of panels are available for the testing, like newborn screening. When I was a student, actually, we used to just like as you said, it's a Guthrie's test, then G6PD. Only like few like a numbered tests were available actually. So now I can see the like whole panel actually. Thank you for the wonderful presentation.
Thank you, Dr. Pazwal sir, for an enlightening and an inspiring session. As a token of our sincere appreciation, may I now respectfully invite our esteemed chairpersons to kindly come forward and honor our distinguished speaker, Dr. Pazwal sir. May I now invite Dr. Radha ma'am, Dr. Radhika ma'am, and Dr. Sanu ma'am to kindly come forward and felicitate our esteemed chairpersons.
Before we proceed, it is my privilege to extend a warm welcome to Mr. Ganeshan Sir, Vice President of Neuberg Diagnostic Private Limited. Sir, we are delighted to have you with us today. Please join me in welcoming him with a big round of applause.
I request a Ganeshan sir to come on the stage. Please accept the honor, sir. I request Neuberg family to join in honoring him.
Thank you, sir. Thank you all. Now I would request everyone to kindly stand up for the national anthem. On behalf of the organizing committee, IMA Chitradurga, in association with Vasavi Lab and Diagnostic Private Limited, an associate of Neuberg Research Center, I take this opportunity to express a heartfelt gratitude to our respected chief guest, esteemed dignitaries, distinguished speakers and panelists for their valuable presence and contribution.
Sincere thanks to all the delegates and participants who joined us from near and far and made this CME truly enriching through their enthusiasm and engagement. We extend our deepest appreciation to the organizing committee, technical team, volunteers, and every individual who worked tirelessly behind the scenes. As it is rightly said, great achievements are built by many hands, often unseen but always essential. Your dedication transformed our vision into successful reality. We hope that today's deliberations inspire continued learning, collaboration, and innovation in advancing the fields of pathology.
Thank you all.
ಉಂಡಿ ಬಿಡ ಮಾಡಿದ್ರೆ ಚೆನ್ನಾಗಿತ್ತು. ಇದನ್ನ ನಮ್ ತಂಗಿತ್ತು ಜೇಸರಿಗೆ ಹೋಗಿ ಏನ ಆರಾಮ ಉಂಡೆ
ಇನ್ನೊಂದೈತೆ
ಮೋಸ ಇರ್ತದೆ
ಎಲ್ಲ ಇಲ್ಲ ಕಣ ಹೇಳಿ.
ನಮ್ಮ ಹಾಸ್ಪಿಟಲ್ ಉಂಟನಲ್ಲ, ಹಾಸ್ಪಿಟಲ್ ನಡೀತಾ ಇರೋದೇ ಆಕ್ಚುಲಿ ಮೆಡಿಕಲ್ ಬಿಲ್ 2 ಲಕ್ಷ ಬಿಲ್ ಆಗಲ್ಲ ಅಂದ್ರೆ ಹೆಂಗೆ ಕೊಡ್ಬೇಕು? ಬಿಲ್ ಇರೋದು ಕಂತಿರ್ಬೇಕು.
ಇದು ಖಜಾನೆ,
ಇದು ಖಜಾನೆ. ಅದು ತೀರ್ಥ ಪ್ರಸಾದ.
ಸರ್ ನಾವು ಸರ್ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್
ಗೊತ್ತೈದು ನಮಗೆ ಅಲ್ಲಿ ಅವಾಗ ಬರ್ತಾನೆ ಇರ್ತೀನಿ, ಮರೆಯಕ್ಕಾಗಲ್ಲ.
ಮುಳುಗಿ ಕೊಡ್ತೀನಿ ಅಂದಲ್ಲ ಉದುರಿಸಿ ಯಾಲೆ
ಕಾಸ್ಟ್ಲಿ ಒರಿಜಿನಲ್ ಕೊಡ ಬಿಡಲ್ಲ
ಕೊಡು, ಇಲ್ಲ ಐತಲ್ಲ.
ಸುನೀಲ ನೈಟ್ ಡ್ಯೂಟಿ ಅಪ್ಪ ಅಣ್ಣಯ್ಯ. ಹೋದ್ ತಿಂಗಳು ಸುನೀಲ ನೀನ ಒಂದು ಕ್ಲಾಸ್ಮೇಟ್ ಅಂತಲ್ಲ ಸುನಿ, ನೀನ್ ಅವತ್ತು ಬಾರಾಗ ಹೋದಾಗ ಫೋಟೋ ತಕೊಂಡಿದ್ದೆ ಅಂತ. ಫೋಟೋ ತಕೊಂಡು ಹೇಳ್ತಿ ಬಾ ಡ್ಯೂಟಿ
ಸ್ವಾಮೀಜಿ ಫೋಟೋ ಹಾಕ್ತೀನಿ ತಡ್ರಿ ಅಂತ ಹೇಳಿ.
ಏನ್ ಅಂದವ್ ನೈಟ್ ಡ್ಯೂಟಿ ಬಾರಿ ಬಿಡು. ಸರ್ಕಲ್ಗೆ ಆಂಬುಲೆನ್ಸ್ ತಗೊಂಡು ಹೋಗ್ತಿದ್ವಿ
ಕೈ ಕುಡಿಯಕ್ಕೆ ಆಂಬುಲೆನ್ಸ್ ತಗೊಂಡು ಸರ್ಕಲ್ಗೆ.
ಅವನೇನೆಲ್ಲ ಬಾರಿ ನನ್ನ ಮಗಳು ಎಲ್ಲ ಒಂದೊಂದು ಮದ್ದುಗಳು ಬಿಡ ಒಬ್ರಿಗೆ ಅವ್ನು ನೋಡ್ರಿ ಅಜ್ಜಿ ನಾಳೆ ಏನಾಗುತ್ತೆ ನಡಿಯಲ್ಲಿ ತಗೊಂಡು
ಇಲ್ಲ ಇಲ್ಲ ಇದಕ್ಕೆ ಹೇಳಕ್ಕಾಗಲ್ಲ ಸರ್, ತೆಗಿಯಲ್ಲ ತೆಗಿಬೋದು ಬಾ.
ಬಿಸ್ಕಿಟ್ ಜಾಸ್ತಿ
ಇವನಿ ಬಿಟ್ಟೆ. ಹಲೋ ಸರ್.
ಸರ್ ತೆಗಿಲ್ಲ.
ಹಾಂ ಓಕೆ ಸರ್, ಓಕೆ. ತೆಗಿಬೇಡ ಇರಲ್ಲ, ಇಲ್ಲ ಇತ್ತಲ್ಲ, ಇಲ್ಲಿದ್ದಾಗ ನೋಡ್ಲಿಲ್ಲ, ಮಾತಾಡ್ಲಿಲ್ಲ.
ರಜಾ ಸಿಗಲ್ತಾ ಇಲ್ಲಿ ಡ್ಯೂಟಿ ಅಂತ. ಅದೇ ಬರ್ತಾನಿಗೆ ಏನು ಚಾಟ ಒಂದು ಸ್ವಲ್ಪ ಹೇಳ್ಬಿಟ್ಟು 91 ಅಂದ್ರೆ ಅದು ಪ್ರೆಸೆಂಟ್ ಹಾಕ್ಸ್ತಾನೆ.
ನಡೀತತ್ರಿ ನಿಮ್ದು, ನನ್ನ ತಂಬೆ ಇಲ್ಲ.
ನಡೆಯಲ್ಲ ಸಿಕ್ಕರ್ಸ್ತಾರೆ, ತಂಬಿಲ್ಲ ಸರಿ ಸಿಗರ್ಸ್ತಾರೆ, ತಂಬಿದ್ದು ಮಾಡ್ತಾರೆ, ತೆಗ್ಬಿಡ್ತಾರೆ. ಅಲ್ಲೂಟ ಹಾಕ್ತಾರೆ, ಇಲ್ಲೂಟ ಹಾಕ್ತಾರೆ. ನಾಳೆ ನನಗೆ ಇವನ್ನೆಲ್ಲ ನೋಡ್ಕೊಳ್ಳದೆ ಮಾಡೋಣ, ಡಿಜೆ ಮಾಡೋಣ. ನಾನು ಡಿಜೆ ಮಾಡೋಣ ನೆಕ್ಸ್ಟ್, ಇವನ್ನೆಲ್ಲ ನೋಡ್ಕೆ.
ಅಷ್ಟು ಜನ ಇದ್ರು.
ಹೊರದ್ 3 ಬಾಗ್ಲ ಐತೆ. ಹೆಂಗ್ ಗೊತ್ತೈತೆ, ದೊಡ್ಡ ಮನೆ ಹೊರದ್ 3 ಬಾಗ್ಲಾದ್ರು ಹೊರಗಡೆ ಹೆಂಗೆ ಚೆನ್ನಾಗಿ ಹಂಗೆ ಐತಲ್ಲ ಇದು. ಕರೆಕ್ಟ್ ತಾನೆ?
ಎಷ್ಟು ಇದು ಇನ್ನೂ ಹೊಡೆಯೋದೊಂದು ಬ್ಯಾಲೆನ್ಸ್ ಮಾಡಪ್ಪ. ಕಿರ್ಚಾಡ್ತಿದ್ದಾರೆ.
ಯಾಕೆ ಸರ್ ಮಳೆ ಬಂತ?
ಸರ್ ವಾಯ್ಸ್ ಎಲ್ಲ ರೆಕಾರ್ಡ್ ಆಗಿರ್ತೀವಿ.